Okay, good morning. Good morning, everyone, and welcome to our scientific session. I'm Dr. Amna Khalifa Al-Hadari, and I'll be moderating the first session for today's virtual meeting from 9 to 12, followed by lunch break. And then thank you. I would like to thank you all for joining us today for our sixth annual meeting on this scientific forum. We truly appreciate you taking the time to join us today online for our meeting. And we are grateful for your continued engagement and support. Today's program brings together a distinguished group of experts who is going to talk today about the current and evolving challenges in kidney transplantation with a strong focus on clinical relevance and real-world practice. This session will take us through the transplant journey from start to finish, beginning with transplantation and donation practices in UAE, moving into advanced molecular HLA matching and its role in predicting rejection risk. And then we're going to focus on disease donor pathway from early identification to successful donation. We will also address the key post-transplant challenges, including the recognition and management of atypical HUS, strategies to optimize immunosuppression in critically ill patients, and recent updates on post-transplant diabetes with the emerging role of SGLT2 inhibitors in kidney transplant recipient. To keep the session running smoothly in this virtual format, I kindly ask speakers to stay within their allocated time, and participants are welcome to submit questions through their chat or Q&A, and we'll be covering most of them during the discussion. Thank you again for being with us, and let's get started with our first presentation. Our first speaker will be Dr. Maria Gomez. She's the Director of and Organ Transplant Expert at the National Center for Regulating Donation and Transplantation of Human Organs and Tissues in Ministry of Health, UAE. Dr. Maria is going to talk today about transplantation and donation in UAE. Dr. Maria, the screen is yours.
Good morning, everyone. Dr. Amna, thank you very much for your kind introduction. And thank you to the organizing committee for inviting me and invite Hayat to share our experience and more important, the outcomes of the implementation of the disease organ donation and transplant program in UAE. So I will share my screen. Just a minute. I think that, okay. Just please let me know that you are seeing my screen.
Yeah, we're seeing it, Doctor.
Okay, yes. Good. So I will go to mode presentation. Oh, hold on. I did something wrong. Can you see the presentation or the?
Now we can't. Can you please reshare it?
Again, here and here. Okay.
Yes, now we can see it. Yeah.
Okay, so let me do that now. Okay, so in the following 20 minutes, I would like to present to you what has been the journey of disease organ donation and transplant in UAE, something that all of us, we know as the Hayat program. So just a little bit of background of why all of this is important, why World Health Organization is making a call to all countries worldwide in order to enhance and to be self-sufficiency in organ donation and transplant. This is the situation. No? We know that more than 150,000 organ transplant has been happening around the world, but this is only covering less than 10% of the global needs. So 90% of the people worldwide, they don't have access or they don't have the opportunity to receive an organ for transplant. Then this is also coming from the World Health Organization. We know that non-donor, no transplant, this is the warm map regarding disease organ donation activity. The dark blue are the countries with the highest organ donation rate. We are talking about Spain, US with about 50 and 49 donors per million of population. And then the other countries that they are in the process to implement and develop this activity. What we know, again, as I mentioned, no donor, no transplant. So it doesn't matter how strong the transplant programs can be in a country, but if the disease organ donation program is not as well as the transplant program is strong, it will be very difficult for a country to have the possibility to offer this type of services to the population. So this is the journey of UAE, Hayat Organ Donation and Transplant Program. Maybe you are quite familiar with this. Since 1985, from the first living kidney transplant, living related, till last year, we will see the numbers that we did more than 1,500 transplant from deceased donor. So key milestone, the first disease organ donation in UAE happened in 2017. When the brain death law finally was implemented, and brain death as a death of the person. And then from that time, from the last 7-8 years, the growth of organ donation, disease organ donation in the country has been exponential. And we will see why. What is happening here? So all type of transplant is possible to perform already in UAE: heart, lung, pancreas, liver, and of course kidney, from deceased donor and living donor. National Center for Organ Donation and Transplant was launched in 2020 together with our Hayat Pledge Registry. Of course, the people are welcome to pledge in UAE for organ donation. And then in 2023, we did an update of the federal decree law. So we will go through that law also during the presentation. And maybe another key milestone is our international collaboration with our neighbor countries like Saudi and Kuwait. So more than 250 organs now, more than 250 organs has been shared from UAE to Saudi and from Kuwait to UAE. To understand about the implementation of the program in UAE, I think we can refer to this article and a study from the London Business School that they highlighted what are the key elements of any disease organ donation program in the world. So we will go briefly, not for all of them, but we will highlight and the ones that we believe are impacting in UAE. And also we will highlight what are the uniqueness of what UAE is doing. So the first enable element is about government, of course, legislation. We talk about our legislation. And then they mention about building and maintaining public support and trust in the system. But what is happening in UAE, and that UAE started to do since before 2016, is building and maintaining the healthcare professional support and trust in the system. And why it's important to differentiate? The reason is because the strategies to do this are completely different than the strategies that you have to implement for public support. So it's needed to highlight the part of the healthcare professionals, and we are just following what the World Health Organization recommendation and the last assembled resolution mentioned, how we have to integrate organ donation inside of the healthcare system. So basically, we know that our law in UAE established that organ donation is a right in UAE. So any family, any patient has the right to decide. And of course, healthcare professionals, we have to facilitate that right to be granted. As well as the law established about the universal transplant access. So there is not any different regardless nationality or socioeconomic status. We are towards the implementation of this part of the law. So we also know that 40% of the patients in dialysis eventually could be eligible for kidney transplantation. So we are in the process to optimize that these patients in UAE will have that right. And ideally, 100% of the patients in dialysis should receive an assessment, an early assessment and we can talk even before, if we mention preemptive kidney transplant, but 100% of these patients, they should receive an assessment for kidney transplantation. What else is mentioned in our law? Unrelated living donation, so it's allowed by the law. There is a national special committee responsible to approve all these unrelated living donation. Donors after circulatory death still is not implemented in the country, but is in the pipeline. So the numbers that I will present today all are related to donor after neurological determination of death. International collaboration is one of the main pillars of the federal decree law, knowing and following what World Health Organization established, how regional self-sufficiency and international collaboration based on reciprocity between the different countries. Donor support, understanding as this donor support area as removing the disincentives. I do believe that all of us, we are more familiar to removing disincentives from living donor, but also our duty is to remove disincentives from deceased donation. And we will talk a little bit about that. And of course, health insurance. So our law established that health insurance must cover all process, all the journey of donation and transplant, from disease donation, of course, living donation, transplantation, and transplant follow-up. The next block of elements is the structural element. So, and there are different areas here like the reimbursement. We talk about health insurance, registries, database and information technology, Hayat National Registry for Organ Donation, together with the digital platform, is already in place, aiming to capture all the information, and especially for traceability and outcomes monitoring, quality assurance program, standards and KPIs that has been implemented in the country, and of course the National Transplant Organization that is a facilitator. We believe that the role of the national agencies is to facilitate and support that all other stakeholders can implement their duties. So this is the governance of the system in UAE. We have, of course, inside of the Ministry of Health and Prevention, the National Healthcare Committee, but then we have our UAE National Committee for Organ Transplantation, following by the National Center. And maybe this is the uniqueness, to start to highlight the uniqueness in UAE. So this national agency or national center has 4 different roles. As a national agency, like UNOS, to do all the regulation or to support the development of regulation, to audit quality, to run the registry, of course, but also we have the role of an OPO, Organ Procurement Organization, or Organ Donation Organization. What does mean? We have doctors and nurses that they work 24/7. Some of those nurses are deployed inside of donor hospitals, and then to guarantee and to run the disease organ donation process together with the doctors and nurses from the donor hospitals. In addition to that, also the National Center has the role of the registry, the National Registry for Outcomes Follow-up in transplantation. And of course, we are the organ allocation agency. We have as well the committees integrated by all the members of the transplant program plus local health authorities. Those committees are the ones who, in a quarterly basis, follow up the allocation, define the new rules for organ allocation, and give feedback to the operation of the center. In addition to that, of course, we also have the role of awareness, capacity building and awareness. So for awareness, we have our Hayat registry as well, but for pledges for organ donation. So National Center with these 4 different roles, of course, we work very close with the local health authorities, Dubai Health Authority, DOH, Department of Health Abu Dhabi, and with the health operators, EHS, DH, SAHA, and the private sector. This that you see here, like UMOC and DCAS, they are the Center of Emergencies or ambulances. So we also collaborate with them in order to prepare early identification and referral, but also for in preparation of the implementation of the DCD program. And of course, we have the donor hospital and transplant centers. So about 90 active donor hospitals in UAE. They are referring in a regular basis. Last year, we have 1,200 referral for potential deceased organ donors. And so far, we have 8 transplant programs, as I mentioned before, with all type of organs. So the key note here, this is a unified approach, federal and local authorities. There is a government endorsement of all the program, and then is the trust in the system. So being part of this collaboration with the local health authorities and being part of the Ministry of Health and Prevention provide a trust in the operation and in the implementation of the system itself. So more in detail, just the right side, I know that maybe you are familiar with US and Spain or European model. So we are combining model in UAE right now. What we have is this national center acting as an OPO as well, or in the capacity and in the role of organ procurement organization, but we also have inside in-hospital organ donation and organ donation coordinators in the donor hospital. So this is something that we are labeled as critical care support units, because they are responsible not only for the aim of this is not only for potential organ donors, but is to support and assist any family who has a relative in towards the end-of-life care process. And in between, as I mentioned before, all the emergency command center like UMOS and DCAS. The next element, which is going through the operational part, no? Then, of course, prevention is essential in any healthcare matter. And Hayat, in their campaign, in order to raise awareness for organ donation, is included also prevention of chronic diseases and enhancement of lifestyle, a good quality of lifestyle. Of course, what you see here is the journey of the different areas that we have in the process. So in orange, you can see the disease donation part when there is initiated by the donor hospital with the referral, and then how the OPO, or the organ donation organization, receive that referral, and our doctors and nurses start to do all the assessment and the approach with the family till after the approval, then proceed with the retrieval. In blue, you are seeing here the journey of the donor, of the recipient, sorry, of the kidney transplant recipient. And in yellow, you can see the journey of the living donor. And then, of course, the different interactions with these three, but maybe the most important here is to have this coordination between the different centers and the different stakeholders. So what is happening different in UAE of this process? The first thing is the referral. So it has been implemented 2 types of referral, an internal referral, sorry about that, and one external referral. And this is regarding the neurological status of the potential donor. We have been able to increase in 63% the number of referrals. With the declaration of death by neurological criteria, something also, let's say, unique in this part of in the country is the implementation of second or third opinions for the families. We have to acknowledge that this is a new subject for them. So sometimes it's not because of hesitation of the diagnosis done by the doctors, is more to provide more comfort to that family who is not familiar with this type of diagnosis. And those second opinions always are done in collaboration, of course, with the treating doctor and the donor hospital. Donor maintenance, we are familiar with process in Europe and in America that they last maybe 24 hours or 48 hours. Our average time in UAE is 4 days for organ optimization. I will not go for the details, but we can, during the question and answer, we can talk more about that. This donor maintenance or organ optimization allow us to retrieve more organs, although we have to acknowledge that it implies some challenge in the process. And then the family approach, that we know 80% of our families are abroad, so 80% of our conversations are virtual. Of course, we also have families here, so in-person conversation also occurs. We have our approach is done by ICU doctors, intensive care unit doctors, that they have been trained to approach families, and we match the same nationality, same language with the donor family. So we avoid to use just pure translators. We believe that is, and this is the, you will see the outcomes, having the same interviewer with the same language and same nationality make a huge effect for clear communication, clear understanding, and again, trust in the communication. And then, of course, we do 2, 3, 4, 5 approaches according to the needs of the family. Something that we are implemented also is the communication with the family early on, especially not to talk about organ donation, but in order to let them know about the poor prognosis of the family. Capacity building is one of the pillars of the program, whereas we have been done, or we initiate capacity building training before the law, in brain death law in 2016. So that helped us that when the law finally was approved, it was possible immediately to implement disease organ donation, especially death by neurological criteria. So these are a few examples of the training. Something that we do is we engage with all type of conference across UAE, across the year. So we are invited, Hayat is invited to participate in all of these cardiology, neurology, nephrology, or pulmonology conference during the year. We do have alliance with the universities. This is Mohammed bin Rashid University in Dubai, but also we are collaborating with EHS and the training center. So we have 2 courses already, certified courses that train regarding organ donation. This is, as I mentioned, certified, and of course we are now training our healthcare professionals in death by circulatory criteria. Regarding international collaboration, I mentioned before, according to the World Health Organization, this is based on reciprocity and solidarity. So we are talking about international collaboration for knowledge exchange. Of course, you will see the numbers in my last slides. We are exchanging organs with Kuwait and Saudi, and also we are transplanted Kuwait patients in UAE. So because of thanks to a national bilateral agreement, Kuwait recipients can be listed in UAE, and of course, organs from Kuwait also are being transferred to UAE to be transplanted. Okay, so let's go for numbers. So what you can see here is the donors per million of population rate, donors per million of population rate. So it's how we compare between countries, regardless the size. You can see here, we started with 3.9 donors per million of population in 2029. Last year, we achieved 13.1 donors per million of population. This is the highest in the GCC countries, and we are now equal to some European countries, or above of some European countries. So 468 here in the left, cumulative since 2017, 468 the total number of donors, 1,500 organs retrieved. You can see here in the right, only in 2025, we have 149. 52% of the donors are coming from Dubai, following by Northern Emirates with 32%, and then Abu Dhabi with 15.4%. The 3 main nationalities, Indian, Filipino, Bangladesh, that of course that correlates with the demographic of the country. And in the left, you can see some operational KPIs when we have still a DNC rate near to 45%. The family conversion rate is 42%, which is one of the highest as well in the region. Family conversion rate is all the families that say yes from all the families that we approach. And then 42% is almost similar to other countries in Europe. And then still we have challenge with our conversion rate, which means from all the referrals and death by neurological criteria, how many cases we achieve to convert, only 29%. And this is something about donor optimization and donor maintenance. Regarding transplant, from the beginning of the program, 1,300, this is only disease, this is organ transplant. So 1,300 number of transplant recipients, 1,400 organs transplanted, 59 combined transplant. This is an increase of 31% transplant if we compare 25 with 24. Last year only was 451. The majority was kidney with 250 kidneys, following by liver with 148. And you can see here on the right the number of transplant by center. In the left, you have living disease, 62% currently of the transplant. This is cumulative. For sure, if we analyze only the last 2-3 years, maybe the percentage for disease donation will be higher, but cumulative, 62% of the transplant happening are happening from deceased donor. There are some, thank you. And then this is the evolution of the organ transplanted from deceased donor from 2016. So you can see here from 2022, 2023, the exponential growth. And then I highlighted in yellow kidney as one of the main organs that we transplanted. GCC, international collaboration. So the first one is about Kuwait. About 116 organs has been retrieved from Kuwait and bring to UAE. And we have been transplanted about 153 recipients, between mainly liver, lungs, and few kidneys. And then from Saudi, we have been sharing with them about 257 organs. Majority of them are heart and lungs. And as I mentioned before, this is aligned with the vision of the country and, of course, the aim of our current law. So, as a final remark of the National UAE Organ Donation and Transplant Program, this is a unified and collaborative approach with the local health authorities and the health operators. The key about the in-hospital critical care support units, and of course, combining models with the as an organ donation organization, deploying doctors and nurses inside of the hospital. Something relevant I didn't mention before, the unified determination of death by neurological criteria. So all hospitals follow same standard and same clinical protocols. And this is an additional element that brings trust and confidence in the system. What are the next steps? I mentioned about the health insurance coverage. So this is by law, and we are in the pipeline for implementation. DCD donors, we know that between 45% to 50% of the donors pool is from donor after circulatory death. So we are working towards to implement that. And we believe in regional self-sufficiency. So the aim is to implement the GCC transplant network in collaboration, of course, with all our neighbor countries. I think I always like to say that things happen because of people. So I just would like the last two slides to present the people that they are behind all of these efforts. So what you see here is all these doctors and nurses who work 24/7 from the National Center. Of course, our nurses also accompany all of these charter flights or retrievals that happen in Kuwait. This is just one sample of our conference when we are invited. This is Dubai Health Authority that when we are invited to present Hayat or present the new developments of the UAE organ donation program. This is the national agency. So we have many people behind the scene that they are working also 24/7 for the quality assurance program, for the standards, for capacity building, for awareness, and of course the leadership. Thanks to the leaders is possible to achieve all of this and implement the program in the country. Thank you very much.
Thank you very much, Dr. Maria, for an excellent update. And we are proud to the extent where UAE reached in kidney transplantation. And thank you very much for your team for making us reach there. I have one question for you, Maria, from the audience. So what is the main factor and the key that help increasing the rate of disease donor in UAE, especially between 2020 till 2025?
Yeah, thank you, Dr. Amna. So I have to say that we concentrate all our efforts in the healthcare system, in the healthcare professionals. So we acknowledge that public communication and engagement and awareness is important, but all strategies have been focused on introduce and embed organ donation into the healthcare practices inside of the hospital. So organ donation has to be seen as a regular services or regular practice for ICU healthcare professionals. So how we do that? Based on training to them, capacity building, standards, implementation of standards, KPIs, peer visit with hospital visit with peers reviews, let's say, or peer expert in ICU, in organ donation. So everything that we have been done is aimed to all our healthcare professionals feel confident, knowledgeable, and with a positive attitude for disease organ donation. Transparency is important, so we keep them informed about what is happening with the system. We communicate them when there is a donor and then organs were retrieved. We update them what is happening with the system. Good communication and transparency is important too.
Yes, I agree with you. Maria, the second question from the audience is, are there priorities for children and those who have access problems?
Thank you for that. This is very important because I didn't mention our organ allocation rule, kidney allocation rule. So I mentioned we have a committee that committee in a quarterly basis determine the rules for organ allocation, adjust and review. And yes, we do have priorities for kidney transplantation in the country, which is highly sensitized. We have non-vascular access. We have pediatric is a priority also, together with combined transplant, or even living donors who, for any reason, they have a kidney failure, so they will have a priority for allocation. Yeah.
With that, we'll end this presentation. Thank you very much, Maria, and we'll proceed with our second speaker. Our next speaker is Professor Dr. Ahmed Mustafa. He's an Associate Professor of Pathology, University of Saskatchewan, Canada, Clinical Director and Consultant of the HLA Laboratory and at Paul's Hospital. And he's the co-lead of Genomic Health Authority Specialist in Transplant Immunopathology, with over 20 years of experience. So Dr. Ahmed is going to talk today about beyond antigens, molecular HLA matching to forecast rejection risk in kidney transplantation. Dr. Ahmed, the floor is yours.
Okay, thank you so much, Dr. Amna, for this nice introduction. And I think now I'm not a guest anymore. This is my 6th consecutive year to participate in this educational meeting. And I can see now we are almost 900 participants, which is a record. I haven't seen it in the past year. So this is actually a proof of success. So I think you can now see my screen. So without further...
Yes, we can see.
So this is just like my disclaimer slide, and I'm just like to let you know that the work I'm presenting today have already been published as of last month. As you can see here, it's just published in January 2026, and in the next 20 minutes, I will summarize to you what we have found so far. So you know that our field is kind of like a new field. It is started in 1958 by the Nobel Prize winner John Desay, who was one time in the lab and asked for a blood sample because he noticed that some of the patients who are going through transfusion get some reaction. So what he did, he actually isolated the white blood cells, and then he put, at this time, he didn't know that white blood cells express HLA. So he started to put 1 drop of white blood cells on the slide. And then he asked for another blood sample from people or from patients who have been multiple transfused, because he noticed that they always have sometimes have a reaction. And he isolated the serum. And then he, at this time also, he did not know that serum contain our HLA antibodies. And then he started to mix the white blood cells with the serum. And then under the microscope, he visualized that sometimes the cells get agglutinated and sometimes did not agglutinate. But what he noticed that the patient who had agglutination are the patient who usually get some sort of reaction after blood transfusion. So this was actually the discovery of the HLA. And from his discovery, we now know that HLA antibodies bind to the HLA antigen. So here we can see that, for example, an HLA antibody A1 can bind to the HLA-A1 antigen. The HLA DR7 antibody can bind to the DR7 antigen, and the CW9 antibody can bind to the CW9 antigen. However, we now know that actually antibodies does not bind to the antigen. Antibodies bind to a specific epitopes found into the antigen, which is called the epitopes. And you can see here, like this specific antibody will bind to the epitope that is matching its structure. So what does that mean? This means like if I take like 4 different HLA molecules here, the HLA-A2, the 23, and the 24, and the HLA-68. If you have a single antibody going to recognize the HLA-A2, this antibody will bind now to the star present in the A2, which is the epitope, but it's also going to cross-react and bind to the 23 and the 24. This means that now antibody does not recognize a specific antigen. Antibody actually recognizes an epitope. So basically, in this type, it is one antibody that has been formed, and this antibody has been cross-reacted with multiple other HLA alleles. The same one here and this one. And you can see here that it continued, that most of these antibodies are cross-reactive, but also at the last here, you can see that some of these antibodies have a specific alleles that they bind to. So how this research started, like if we are taking this and as an example, if you have a donor who is expressing the HLA-B18, which is an antigen, and then this B18 has 11 different epitopes. Now, if we have a patient who is HLA-B7, now this patient will see the donor B18 as 11 different epitopes. So this patient will form 11 different antibodies against the patient. But actually, when we see the full typing of the patient now has the B52 and the A33, and then these epitopes that are present in the patient HLA antigen is actually sharing with the donor B18. So now, because they are shared between the donor and the patient, so the patient will unlikely going to form HLA antibodies against themselves, and this patient will unlikely going to form antibodies against the donor. So although we have one antigen mismatch, there is no epitope mismatch between the donor and the patient. So this means that now molecular matching, or at least I convince you that molecular matching overcomes, or is now the conventional, overcome the conventional antigen mismatch. So in this research, what we did, we used what we call the HLA applet registry, which is a free website, and you can put your patient typing, and you can put multiple donors so that the patient can compare with multiple donors to find the best match. So for example, here, if you have a patient who is typed as HLA-DR beta 1 1101, and you can see that this patient have 4 different epitopes. Now, if you have two patients to compare with, if you have two donors to compare with, you can see that one of the donors is DR beta 13, the one is DR beta 12. So now there are one antigen mismatch, but actually there are donor 1 is better than donor 2 because donor 1 has only one epitope mismatch, but donor 2 has 4 epitope mismatch. So if we have the option to choose between these two donors, then donor 1 is definitely better than donor 2. And this is actually one of our reports. We already went to translation of this research, and now it's become clinical. So if we take this as an example, you can see here that when we compare to the conventional antigen mismatch for locus A, there is 2. For locus B, it's 2, and C is 1, and so on. But when we use the epitope mismatch, it actually gives you a more crispy idea, because now you can look at and compare the difference between epitope mismatch. But this is one of the very interesting findings which we found, which I already explained, that, for example, here, the DR beta 1, there is one antigen mismatch between the patient and the donor, but when we did the epitope mismatch, there is 0 epitope mismatch. And the same scenario has been reversed when we looked at the DR beta 3, because there are 0 antigen mismatch, but there are 6 epitope mismatch. So this is definitely can tell us that epitope mismatch is more critically or more crispy in detecting the rejection or the path of rejection. And this work has been published in multiple conferences. Eric is my medical student who started this project. He went to different workshop and different scenario in San Diego and also in Las Vegas in ASHI. So he presented this work multiple times. Additionally, this work was also presented in the Canadian Society of Transplantation, and it won the first poster presentation. And also, it was presented in the Transplantation Society in Turkey, in Istanbul last year. And this is a picture with my Turkish friends who was interested in implementing this work in their lab. So now I'm going to switch gear a little bit to give you the second part of this project, because now we know that the developing of antibodies is not as simple as I mentioned. So let's take an example here. If we have a donor kidney cell, and this donor kidney cell express the HLA, now the patient antigen presenting cell will recognize this mismatched HLA through the B cell receptor. If we are taking this as a B cell, then what happened is this HLA is going to be internalized into the antigen presenting cells, and it's going to be chopped into multiple pieces. And then when it's chopped, it becomes peptides. And then this peptide will be presented in the context of the HLA class 2 of the antigen presenting cell. The next step, this antigen presenting cell will activate the CD4 positive T cell, and then this CD4 positive T cells will activate the plasma cells, which is in turn going to form the antibodies. And if this happens, this will result in antibody-mediated rejection. But also, the CD4 positive T cells can also activate the CD8 positive T cells, which become the cytotoxic T cells, and this will result in cell-mediated rejection. But now, if we take this as an example, the box at the bottom, this is what we call the B cell epitope, because the B cells is recognizing the mismatched antigen. The box on the top, we call it the T cell epitope, because now the T cells is recognizing the mismatched antigen. And this was actually the hypothesis of our work, that we need both the B cell epitope and the T cell epitope so that they can both work synergetically together to predict the risk of this individual. So in this case, and I don't want to go in much detail, we use what we call the PERSH, which is a software that can give you, or an algorithm that can give you an idea about the scoring of the B cell epitope. And it is basically, we know now that HLA is a very complex structure. So not every epitopes in the HLA is actually immunogenic, because some of these epitopes are actually hidden. and is not exposed to the antibody. So the PERSH actually calculate the scores of the HLA that is on the surface. And again, not every single surface can form an epitope. It has to be a concave surface, because antibody prefer concave surface over the convex. So now this algorithm can give you a score of the structure and the geometry of the HLA, and actually the accessible molecules of the HLA. The other algorithm that we use, which is the T-cell epitope, which is, I'm going to show you a small diagram on how it works. So basically here you have your donor kidney cell which express the HLA molecule. The red is actually the hidden epitopes, and the green is actually the surface epitope. So you can see here, this one time will be isolated from the kidney cell. It will be taken by the antigen presenting cell through the exposed epitope, which is on green because it's on the surface. And then once it internalizes, this internal epitope will become exposed now, and it become released. And now this epitope will be bind to the HLA molecule, and it will activate the CD4 positive T cells. So this is what I was mentioning about B cell and T cell epitope. So the T cell epitope, we refer it as PERSH-T. So now we have a program that actually can calculate to you the amount of epitopes that are binding. So for example here, if you have the mismatched HLA of the donor, this will become internalized and break into, like for example, in this case, 5 different epitopes. And now not all these 5 epitopes will be bind to the context of the patient HLA molecule, because we have something now known as MHC restriction. And then it will end from this 5, only 3 will bind. So this patient will take a score of 3. So the more the score this patient will take, the more is likely that they are going to activate more CD4 positive T cells, the more they are going to proceed with more rejection. So we started this project with 594 patients, and we followed these patients for over 10 years. So here, from out of the 594 patients, 104 patients developed donor-specific antibody. And then you can see here that some of these patients develop a single donor-specific antibody, but also some of them develop double donor-specific, and some triple, and some of them, more of them are more than 3 different donor-specific antibody. But you can see here that the majority of them develop antibodies against the DQ, and then the DR, and the last was the HLA, which is the class 1. So the first thing, because this was already being published earlier, we wanted to compare between these 2 groups, the group who have developed donor-specific antibodies and the group who did not develop donor-specific antibodies. And we noticed that their applet registry score is high, because now they express more applets, so they actually resulted in more donor-specific antibody formation. And now in the next step, we wanted to look at the PERSH-B and the PERSH-T, which is the most recent algorithm for detecting this scoring system. And we found that the PERSH-T2 actually correlate with the finding that we found with the applet registry. And also it confirmed that the more score you have, the more likely you're going to form donor-specific antibody. And also when we looked at the PERSH-B score, we found that the more PERSH-B score you have, the more likely you are going to develop donor-specific antibody. And then when we looked at locus-specific, we found that every patient who developed a locus-specific antibody, their applet registry score was high than the group that did not develop antibodies. Like for example, here we look at the locus A, locus B, C, DR, DQ. All of them were, you can see here that the scoring of the applet registry was higher. When we looked at the PERSH-T2, it actually correlates with the applet registry, but you can see here that locus A was not significantly high in the PERSH-T2, but actually you can see that there is also still a trend or non-significant trend increase of the scoring for these patient who developed donor-specific antibody. And the same scenario when we looked at the PERSH-B, but again, you can see because of the number of patients who developed donor-specific antibody, again, is the locus C, and the locus DR was not that much. So the results were not significant, but it is still showing you that there is a trend. But what we actually notice is when we combine the class 1 and the class 2, it was consistently between the different scores. So the high score of the class 1 or the high score of the class 2 are the patients who are most likely going to develop rejection. So what we did is we divided this patient into class 1 and class 2 because now we know we want something that is consistent between the three algorithms, and we defined a cutoff. So for example here, if your cutoff is above 22.5 for the applet registry, you are going to develop rejection. If your score is above 30.5 for the PERSH-T2, you're going to develop rejection, and 5.5 for the PERSH-B, you are going to develop rejection. And then the same scenario we did with the class 2. And then we started to do risk stratification for these patients. And we found that the patient who have the three scores high, like the PERSH-T, the PERSH-B, and the applet registry, these are the patients who were high risk. And then the patient who had the scores are all low, these are the patients that are low risk. And then we have a risk in the middle, and these are patients who have 1 or 2 scores are high and 1 score are low. And when we stratified this according during the time we looked for these patients, we actually found that the high risk group, which is seen in the purple line here, are the group that develop rejection for class 1 and also develop rejection for class 2. And you can see here that the low risk group who had all their scores were low, they did not develop rejection. And then sorry, they did not develop donor-specific antibody. And then when you looked at the rejection, it actually matched. Like all the patients who have high score, these are the patients who develop antibody-mediated rejection. And then when we published this paper, some people argue that, okay, maybe these different in this group were because of their tacrolimus trough level, and maybe they were not adherent to their medication, but we found that actually the trough level of tacrolimus was similar between the group who developed AMR and the group who did not develop AMR. And then our next hypothesis is that maybe we can also predict the T-cell mediated rejection using the scoring system. And what we found actually that the PERSH-T2, which actually looks at the T-cell epitope, is the only scoring system that can predict the T-cell rejection, because it's mostly going to activate the T-cells. But the applet registry or the PERSH-B did not correlate with the T-cell mediated rejection. So in summary, molecular mismatch scoring informs alloimmune risk in kidney transplantation. The applet registry, the PERSH, predict donor-specific antibody. PERSH-T2 uniquely predict T-cell mediated rejection. And then high-risk group based on algorithm cutoff show that the lowest donor-specific antibody and the ABM are free survival. So epitope-based algorithms have a strong clinical utility for risk stratification and outcome prediction. So at the end, I would like to thank all the people who have been hardly working on this project. And I'm only here to present it. So the work started with our medical student, Eric, and then it was continued by our pathology residents. And then it was wrapped up with my graduate student who finished and wrote the paper. And also, I would like to thank all my lab and the collaborators from different universities and the funding agency. I can stop here and happy to answer all your questions. Thank you.
Thank you, Dr. Ahmed. It's always interesting to listen to your presentation. There are a few questions for you from the audience. Okay. Is epitopes genetically determined? And what is the reason behind the epitope, and if we can consider it as a receptor?
I already showed that we thought that the antibody bind to the antigen, and this is why we call the antibodies by the name of the antigen. But we know now that it is as the question is as a receptor. But we, instead of the word receptor, because receptor means that anything bind to the receptor and make a signaling. This is not like a receptor. It is basically an epitope that can bind to the specific structure of the antibody. It's the idea of the same idea as the key and the lock. So if you put your key in a different lock, it is not going to open the door. But if you put the key in the right lock, it is going to open the door. So this is basically the idea of the epitope. And it's not genetically inherited. It is in the structure of the HLA. So, for example, if you have two individuals who have HLA-23 and the other one is HLA-23, both of them will have the same number of epitopes, even they will have the same structure of the epitopes.
Is it fixed or changeable?
No, it is not changeable. No, it is fixed.
Okay. The next question is epitopes internalization is temporary or permanent? And if the internalization theory has role on other B or T cell receptors?
Well, if I understand this correctly, internalization, the epitope is not internalized, but the HLA antigen itself is internalized, like the whole molecule. And then when it becomes internalized, the enzymes in the cell actually breaks this HLA molecule into small peptides. And then this small peptide is actually, some of these small peptides contain the epitope. And then this epitope is the one that going to bind to the specific or to the specific HLA molecule. I hope this answered your question, or at least from my understanding of the question.
I think so, yeah. In your practice, do you consider DSA to HLA DP antigen relevant?
Okay, this is actually a really good question. So in order to answer this, which is outside this topic, but when we do the donor-specific antibody for the DP and then we buy the beads from the company, the beads actually contain massive amount of DP. So for example, you can have if you can have a mean fluorescence intensity of 15,000 MFI of the DP. And then when you do a cross match, the cross match become negative because the DP on the cell surface is not represented enough, similar to what in the beads. So the beads are very highly sensitive, but in real life, they are not very highly expressed. So I know a lot of labs and a lot of centers that actually cross the DP even with 10,000 and 15,000 MFI. So DP is, although some people develop donor-specific antibody, but a lot of patients have been living with very well with donor-specific antibody DP without forming antibody-mediated rejection.
And the last question is, how did B and T cells interact?
So this is actually the link, because in order for any individual to form any kind of rejection, like antibody-mediated rejection or T-cell mediated rejection, they need the two link for both of them to interact. So the first stimulus is your B-cell receptor is going to bind or going to recognize the HLA antigen. And then after it become internalized, now the second step is the T-cell T-cell receptor is going to identify the foreign peptide present in the context of HLA, and then it now become activated, and now it either activate the CD4 or the CD8, and it depends on which pathway is activated, it can result in rejection. In a lot of the cases, you can find the two pathways are activated, and it can result in both AMR and cell-mediated rejection.
There are a couple of questions in the chat. Does induction therapy, depletional or non-depletion, affect the score?
No, the risk score is actually permanent. Like we identify this risk score even before transplantation. But what we have found is patient, and this is actually what we are using it for clinical, patient who have high score, we intend to give them induction, and also we keep monitoring them for tacrolimus level more than the individuals who have low risk, because we know that once they become non-adherence or their trough level of tacrolimus decrease, this is the patient then they become, because they are already at a high risk. So a high risk and non-adherent, they are the most likely going to develop rejection. Because now if you have two groups of patients, one of them is low risk, one of them is high risk based on this scoring system. And that if the trough level decreases in both these two groups, the high risk group is going to form a rejection. The low risk group might not develop rejection. And this is what we found. And this is how we are using this scoring system to adjust the induction and to adjust the maintenance immunosuppressive as well.
بس أنا موعدي الساعة 10:10.
Thank you, Dr. Mustafa, for your presentation. It was an excellent presentation. This is the comments also we received from the audience. Thank you very much.
Thank you.
Now-
We reach 1,000 now.
Yeah. Yes.
Okay, thank you.
Thank you. Nice having you always. We'll proceed to our next speaker. So our next speaker is Dr. Ahmed. Dr. Ahmed Fathi. He is a professor of internal medicine and nephrology, head of nephrology unit, Alexandria, faculty of medicine, consultant renal transplant physician, fellow of Sheffield Kidney Institute and International Society of Nephrology. Dr. Ahmed is going to talk today about immunosuppression management in critically ill patients, balancing between infection and rejection. Dr. Ahmed, the screen is yours.
السلام عليكم ورحمة الله وبركاته.
السلام ورحمة الله.
Thanks, Professor Amna, for your nice introduction. Thanks for the gathering. Thanks for the invitation for the very prestigious meeting. And as Dr. Ahmed Mustafa just mentioned, mashallah, your 1K and attendance. I remember last year when I was there, I was impressed by having more than 500. And this is really a very strong indication of the success of the meeting over the years and the success in the test of time. I hope to tell you something that can help in our daily work. And this is a very practical scenario after the very nice presentation of Professor Ahmed Mustafa with the very high immunology background. And I can quote his impression of having the immunosuppression related to the intents of iplet mismatch, whether the internalized form or whether the exposed form or whatever. And this will definitely have its burden on the total patient immunosuppression. And the point is how we should go to minimize the risks, especially when the patient is in a critically ill situation, though the balance between the infection and rejection is a very critical point. And let's start by a couple of cases that we have just faced the last few months. This was a Sudanese 45 years woman with an unknown OKD, original kidney disease, and she had a transplant from her husband, and there was positive pre-transplant DSA plus a poor match with 210. That's why she received this desensitization for 5 sessions of plasma exchange, IVIG, and 2 doses of obinutuzumab, and she had induction with the steroids and ATG. She had maintenance on the triple TAC, MMF, and steroid, and early post-transplant course was very effective regarding the renal function, but she started to present with increasing level of anemia. Her hemoglobin actually went down to below 6 grams, maybe 5 and a half, and she was transfusion dependent. She received weekly 2 bagged filtered RBCs. Maybe we reached more than 18 bagged RBCs. And the CBC film was normal with a reticulocytic count of 0.2. Her platelets were normal. The graft function was stable all through the course. No source of bleeding. Fecal local blood was negative. TSAT was okay. Ferritin is okay. Even folate and B12 were normal. ESR is high. And the hemolysis workup was negative, almost with a bit of increased LDH, but negative bilirubin and haptoglobin. ANA as well was negative. So we proceeded doing viral panel, all was negative, CMV PCR was negative, EPO level was high. She had a bone marrow biopsy that initially suspected to be MDS, but it was negative by cytogenetics, and the Epstein-Barr virus was negative, the COVID PCR was negative. So we go for the parvovirus, and it was very highly positive, and the bone marrow rereading proved that this is a pure red cell aplasia, and this was a pure red cell aplasia associated with the parvovirus infection. And we proceeded with the patient, giving her IVIG, reduction of the immunosuppression to 1 gram MMF instead of 1.5 gram, and the TAC level kept at the lower target. She received IVIG for 5 doses, and she took another, because of financial constraints, she was not covered because she was not Egyptian, and unfortunately she did not show initial response. So we managed to find another way for sponsorship, and she received another full dose of IVIG, and with some reduction of the immunosuppression, and we managed at last to reach with hemoglobin to 10 grams after control of the parvovirus. So as you can see, this is a persistent viremia with a refractory anemia and a high immunological risk with a positive DSA, and she even received frequent blood transfusion. And the management was very critical. She was lucky, alhamdulillah, that she did not reject with the reduction of the immunosuppression. Maybe the IVIG was a bit of protective effect, and this is to be discussed. The second patient is a 16 years old male who received a kidney from his mother, and he was positive CMV IgG, and he had a prophylaxis with valacyclovir, not valganciclovir, which we use commonly in such patient, and he presented with an AKI, creatinine 2.2, and some form of diarrhea. First PCR was done, and we thought it could be related to the MMF. We reduced the dose of MMF a little bit, and then the patient started to have increasing kidney function with the creatinine reached from one baseline of 1.1 to 1.8, and he had a Doppler of RI 0.8. He started on IV fluids and pulse steroid, and the biopsy was done, and the biopsy shows acute tubular injury with a C4D positive 3+. That goes with an ATN-like acute antibody-mediated rejection, and the patient was started on plasma exchange, IVIG, and 2 doses of rituximab, and the creatinine went down to 1.4. Unfortunately, a couple of weeks later, he presented with severe diarrhea and increasing renal function to 2.5 again. He was so ill that he was admitted to the ICU, and he received IV fluids and resuscitation. And then we did the PCR for CMV again. It was positive. And though it was positive in a low copy number in the quantitative form, but with the severe diarrhea, we thought, and with the recent receiving of the plasma exchange and the rituximab, we thought this might be related a positive actually disease, not only an infection, and he started the antiviral with the valganciclovir, and fortunately enough, he improved. With those 2 cases, we just introduced what's going on, what's critically ill patient, and how critical illness in kidney transplant recipient can change our plan of management, and how can we manage the immunosuppression in such a patient. Of course, a critically ill patient is defined in different scores. Maybe you know all the SOFA, the multi-organ dysfunction score, and the Apache 1 and Apache 2. But the SAPS is the simplified one, which took in consideration the Apache score and simplified the renal function beside the vital signs, as well as the electrolytes, the bicarb, and the Glasgow Coma Scale, and then according to the age of the patient and the type of admission and whether the patient has an associated chronic or acute illness. And then you come up with the score of your patient. And the more the score is higher, you know that your patient is more critical. And this is very important for nephrologists to adopt, because unfortunately, most of us as nephrologists, we still look for the kidney, sometimes maybe more than the patient. So understanding these different types of score and the aggressiveness of the score for the patient life and his expected survival might make us less resilient with the score with the patient kidney and looking for the patient survival better. So I really advise understanding the scores and try to use them in all kidney transplant recipients by the nephrologist, not only by the intensivists. And in our situation, there is like 10% of kidney transplant recipients, they have some life-threatening complication that may require ICU admission, and these usually occur in the late post-transplant period, which is more than 6 months later. And this can be either infective or non-infective, and usually is related to the acute respiratory failure, which can be from pneumonia, viral, bacterial, or atypical pneumonia, or even fungal. It can be from shock, like bloodstream infection with sepsis, Krebs-C maybe, or urosepsis that causes bloodstream infection. Acute kidney injury may be, again, surgical site infection or collection or infected hematoma or urinoma or lymphocyte, and sometimes it's even can be coma secondary to bacterial or viral meningitis or even cryptococcus, nocardia, and tuberculosis, especially if coming from endemic area. So we have to be very aware with these possible etiologies for patient presentation. And the graft survival really depends on the pre-ICU graft function. So if you have a patient with a good kidney function and he presented with a severe disease, this might help to that the graft might survive out of this disease. But if it is already impaired, don't try too hard to harm the patient with an already lost or partially lost graft. Again, the disease severity and the toxicity of the antibiotics and the needed investigation, like if you need a contrast injection or whatever. And the transplant itself is not the main predictor of the short-term survival. Almost 50% of the patient discharged with a good graft and free from dialysis, and 40% required renal replacement therapy, and hospital mortality in this situation might reach to 30%. So it's very critical situation. With the drug-related toxicity, we have to understand the drug-induced neutropenia. When the neutropenia occurs frequently in our patients, especially when we use our immunosuppressive drugs, on top is the MMF and maybe the Prograf as well, and the combination of both together, the effect of other factors that might lead to this neutropenia, and as well the use of granulocyte colony stimulating factor that can be very helpful in this situation, and we should not refrain from using it fearing of the graft function if the patient is really severely neutropenic. Definitely infection can be presenting by severe sepsis or even septic shock, and it is very challenging in the setting of balancing immunosuppression and the treatment. This can be related to perioperative condition, like for a patient who had a catheter, for example, and repeated catheter-related infection for a long time. Those patients might have a missed infective endocarditis, for example, or a patient with a polycystic kidney that was not nephrectomized, or a VUR, vesicular ureteric reflux, that can cause repeated UTI post-transplant, and definitely patient can have an attacks of infection, either surgical in 50% of patients, either related to the surgical or urological or wound complication. Even this can go up to mycotic arthritis that lead to a problem within the vascular anastomosis. Pneumonia is on the top. Bacterial pneumonia, Pseudomonas, Klebsiella, CMV pneumonia and pneumonitis, the PCP, especially after the stop of the trimethoprim, cotrimexazole, which usually lasts for the first 6 months, and even acute graft pyelonephritis can occur, which is the second site to have infection after pneumonia, bloodstream infection, and even by fungal bacteremia, or fungal sepsemia or fungemia. Infection can lead to severe sepsis or septic shock and can be very difficult to diagnose and treat. And there are some other infections like the C. diff with chronic diarrhea, the nocardia, pneumonia, and even the brain abscess with the nocardia, and the Cryptococcus pneumonia and meningitis. We have a case that was reported previously from a Cryptococcus meningitis, and a disseminated TB if the patient is coming from an endemic area and is not on prophylactic treatment. So this is how critical can be the patient and the infection that can lead to the sepsis, and the immunosuppression management in those critically ill patients have those rules that we have to be aware with. Do not delay admission to ICU even if the patient looks like he's holding his vital signs yet. Routine assessment of the cardiac function is very important in those patients because they might have depressed cardiac function from the sepsis and from the drugs. Consider bacterial pneumonia number 1, acute graft pyelonephritis number 2, and bloodstream infection number 3, and evaluate the BCP, especially if we stop the trimethoprim or the septrin. Consider immunosuppressive drug-related toxicity. If you have a neutropenia, avoid nephrotoxic drug and contrast agents as much as you can. You can use MRA instead of CT angio, for example, or CT with contrast. Use Doppler sonography on the kidney. Look for thrombosis. Look for evidence of mycotic aneurysm, and close therapeutic drug monitoring of the immunosuppressive, and consider discontinuing some immunosuppressive. We start by stopping the anti-proliferative, decreasing the dose of the TAC, and you might cover with steroid. And you can use the GCSF, as we mentioned, and provide a full code ICU management based on good short and long-term outcomes. Do not lose hope with those patients, although they might present very aggressively, but they can survive through it, inshallah. And this is how you can differentiate. I'm not going to read through this table, but you have to look for, and maybe you have to copy it and put it under your desk, because it's very, very important to differentiate. This is the always puzzling scenario. Is it infection from an over-immunosuppression, or is it a rejection from an immune activation? And definitely you can understand that these are two different pathways. So the investigations that can help, like the complement factors, like the viral load that you can do, you can use even the gene transcripts that can help to differentiate. As you might know that the gene transcript now have been involved in the diagnosis of antibody-mediated rejection along with the C4D and the DSA and the histopathology. And especially for elderly, it's another issue, because they might develop acute rejection and they are more likely to die from the infection rather than the rejection. And we have to classify and personalize, and this is a very nice paper of personalization of the immunosuppression according to the patient. And this can be classified according to the patient's scenario to high and low immunological risk. And according to this high or low immunological risk and the risk of occurrence of acute rejection, you can modify your immunosuppression within the bottom line for our situation. The maintenance immunosuppression in our situation is usually by the steroids, the azathioprine, the MMF, cyclosporin or tacrolimus, sirolimus or everolimus, and sometimes the belatacept. And each of these are associated with the profile of the side effect. And the major part is the antiproliferative that can lead to myelosuppression and enhanced infection, and the combo of the MMF with the TAC, which is the highest with the viral infections in particular. And this is the net state of the immunity of the patient, where you can look for what's going on, whether what increases the infection risk versus what increases the rejection risk. And again, don't be overzealous for the graft and forgetting about the patient survival. So you have to look for what is the source of infection, what is the immune suppression used, what is the recipient-related factor, whether the leukopenia or a non-compliance or genetic immune response for the patient, what are the surgical issues early and late related to the operative, what are the barrier integrity that the patient already had, and hence you can balance these points together. And this is the algorithm that you can go with. Is the infection severe or life-threatening? If it's yes, low probability of infection resolution without decreasing immunosuppression, so you have to stop the immunosuppression or decrease aggressively. So on the other hand, infection is not so severe and the patient can survive through, and there is a moderate or high probability of infection resolution without decreasing immunosuppression, don't decrease the immunosuppression to keep the graft on the best possible outcome. Then you can go through whether the patient had a recent attack of rejection, so he is at a higher rate of loss of the kidney. What is the immunological risk estimated of rejection in the next 3 to 6 months? Is it moderate to high or is it low? Then you can go through what's going on. But take care that whatever the answer of these later question, if the infection risk is high and it's severe and it's life-threatening, in immune suppression reduction might be required with a coverage of something like steroids plus or minus intravenous immunoglobulins that can solve the problem in such a situation. A therapeutic drug monitoring is essential for dose optimization. You might look for the lower limit of tacrolimus, for example, 4 to 5 instead of 7 to 8. You might even do an AUC, not only the trough level. The MPA-TDM, although it's not very much established, but sometimes it can help in this critical situation to reduce the dose without an added risk of infection. And of course, the using of the pharmacogenetics can be very important. Like, for example, if you know whether the patient have a TPMT or new T15 that can lead to what's going on the azathioprine, for example, and leading to severe immunosuppression. We have to mention here that we have to take very careful monitoring for patients who are receiving azathioprine and preventing them from receiving co-treatment with any hypouricemic agents like oxysteroid, because of the very aggressive interaction that might cause severe bone marrow suppression. The same is for the CYP3A5 and 3A4 for the polymorphism associated, and these are the many of the genetics that can help to understand upfront of the dose modification to prevent over-immunosuppression and hence infection. These are some of the biomarkers that can help in understanding, and we've mentioned them before, most of them, but for example, the cell-free DNA can help you to tell that this is a rejection, not an infection. Interferon gamma predicts rejection, and as you might know, this is the visual abstract that showed the impact of infection-related immunosuppression reduction in kidney transplant outcome, considering temporal dynamics of immunosuppressive requirement. And definitely immunosuppressive reduction due to infection between 2 and 6 months both the higher risk of rejection and worse graft survival, and tailored immunosuppression reduction should be developed according to the type of infection and the temporal dynamics of immunosuppressive intensity. That's to say, you have to understand what's going on with the infection risk, with the patient rejection profile and the risk of rejection, and with the pharmacogenomics or the trough levels or the use of different types of drugs to help against that. And these are examples of the clinical feature associated with each patient population, whether it's solid organ transplant, an immunocompetent solid organ, or immunosuppressed solid organ transplant recipient. Which immunosuppressant is a culprit? Lymphocyte depleting agent definitely have a higher incidence of CMV infection. Our patient who had CMV did receive an ATG. Steroid and OQT3 have a threefold higher risk. Definitely, we don't use OQT3 as you know, but ATG is still on top. Interleukin 2 receptor antagonists reduce incidence of acute rejection without increasing infection. MMF is more than azathioprine in causing the infection, and maybe TEC and cyclosporin are a bit of controversial. When we have a severe pneumonia, whether it's an early or late severe pneumonia, what are you going to do? Reduction of the dose of MPA is on top of the priority, and targeting lower level of the TEC is an important thing. And the clinical outcome, as we mentioned, might be much related to the patient comorbid situation and the immunological added risk, as well as the patient progress during his ICU stay. And these are the standardized approach of the patient with severe pneumonia, the microbiological diagnosis with an invasive approach. Doing a bronchoalveolar lavage or fiberoptic bronchoscopy might be helpful if needed. Empirical antibiotic therapy using a combo of the Septrin, Moxiflox, and Ganciclovir, if less than 12 months, because of the high incidence of these organisms. More than 12 months, usually we omit the Bactrim. The steroids can be used to cover with reduction of immunosuppression or discontinuation upon admission to ICU. Nutrition have to keep the enteral feeding. Fluid management is important, but you don't over-infuse the patient to avoid a lung congestion, especially if the urine output is low. Definitely hemodynamic monitoring and the ventilation. Try the non-invasive. If failed, you might go for the invasive ventilation, and the ECMO is the last resort. We might have viral infection, and the KDIGO have got what you have to do with the herpes simplex virus 1 and 2, the herpes zoster, and the shingles, and the CMV infection, whether pneumonia or whatever, the PK polyomavirus from the immunosuppression. As you might know, we don't have a lot to do except reduction of the immunosuppression, plus or minus some use of C2-vifir or leflunomide, or even quinolone, which is not of proven value. Then the fungal infection. Don't forget the fungal infection with the special puzzle of adding antifungal that interfere with the level of the immunosuppression and might cause decrease in the level of tacrolimus, and this might lead to an added risk of rejection. The voriconazole increases significantly the CNI and the mTOR inhibitor level, so this might increase the infection risk and non-resolution. We have to take very care and monitor of frequent monitoring. And then for patients with PCP, definitely you have to go for the IV trimethobium sulfamethoxazole if available at your locality. Parasitic infection is still there. Strongyloides can be life-threatening, and you should not miss this as well. Sepsis is severe, and you have to go through it, and you have to manage the patient when in sepsis aggressively, and it's always the management without a consensus. So it's a patient per patient scenario to address the critical situation of each patient. And I'll stop here, and I'm happy to take any questions. Thanks for your attention.
Thank you, Dr. Ahmed, for your excellent presentation. There are a few questions, Dr. Ahmed.
Yes, I'm there.
Okay, so how do you address BK virus not responding to decreased immunosuppression and IVIG? I'm sure you encountered this.
I think we've mentioned that with this situation, some people use cidofovir, some people use leflunomide, others use some quinolones, although none of these is approved actually. So the mainstay is reduction of immunosuppression, IVIG. If no response, I don't think that you have another alternative, and it poses an added risk of the frequent of the next coming graft, although it does not preclude transplantation. Definitely a mode of change of the immunosuppression, like shifting from MMF based triple therapy to mTOR with low dose of CNI, like low dose stack with everolimus, might be helpful, as we know that it showed better result with viral infection than the classical triple combination.
Dr. Ahmed, we know some patients are still resisting this maneuver. So what do you think about IVIG?
Yes, I think the question mentioned first resistant to reduction and IVIG. Definitely, we start by reduction of immunosuppression, then IVIG. This is true. But if they failed IVIG as well, and shifting or switching the immunosuppression to an mTOR-based protocol, I think there's little to be done.
So if you are going with IVIG, how many doses would you give?
From our experience, especially with the case that I've just showed in the parvovirus initially, we received actually two full doses of IVIG. The first one was interrupted a bit because of the financial constraint and did not show good result. The second one, we gave the full dose of 2 grams per kilogram body weight over actually not 5 days by 0.4 gram, but it was even shorter based on the hematology people consultation, that we can give it over only 3 days or 4 days with a higher level of IVIG per each session, and this actually led to persistent clearance of the viremia, alhamdulillah. So yes, we give the 2 grams, the full dose of the 2 grams, and you can use them on 3 days instead of 5 days per kg.
Thank you very much, Dr. Ahmed. Thanks a lot for being with us.
Thank you.
Now we'll proceed with the next lecture with our next speaker. Our next speaker will be Dr. Luay Eid. He's a Chief of Division Kidney Center of Excellence at Al Jalila Children's Hospital, Clinical Professor at Mohammed bin Rashid University and Dubai Medical College. Dr. Luay is going to talk today about identification and management of atypical HUS after renal transplantation. Dr. Luay, the screen is yours.
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Thanks, Dr. Amna, Dr. Fahia, the organizing committee, for the invitation. It's my pleasure to be with you today and other speakers. So I will share my screen. Just tell me if. Yeah. You can see it clearly?
Yes, we can.
Okay. So thanks again. In the next 20 minutes, I'm gonna talk about an interesting case that we managed at Kidney Center of Excellence at Al Jalila Children's Hospital. We have an active transplant program started 2018. And last year we achieved a new target with the help of my colleagues that we reach up to 20 kidney transplant between disease and living donor. So hopefully things will move smoother and will expand our program. So these are the objectives I'll try to cover through my talk. So I'll start with the case. Actually, it's an 18 years old. Now she's 20 years old. And the funny thing that I just transferred her to Dubai Hospital to continue the care there. She is a known case of atypical HUS secondary to VGKA mutation, which all of you know that it's not a mutation that did not respond to C5 inhibitors, or usually do not have any effect on plasma exchange or plasma infusion, which is the usual treatment for atypical HUS. She was treated initially at SKMC, then she shifted her care to us in 2019. She had a disease donor kidney transplant on 20 February 2024, and her course was slightly complicated with the severe pneumonia, prolonged mechanical ventilation, and blockage of the double J. So that she required ICU admission slightly longer. On the second or third day of transplant, she had signs of activation of TMAs with low platelets, low C3, high LDH, and positive blood film. So she received ravulizumab loading dose on 22nd of February, and then maintenance till October last year. So if you can see here, these are the anyway, I don't know. Okay, so the platelets dropped significantly, the hemoglobin the same, slightly increase in the LDH. Other screening were all normal, including the complements and the other factors. So she received on the 24th of, so she transplanted on the 20th of February. On 24th, she received Altumeras or ravulizumab. And you can see that there was a significant improvement of the platelets. As we all know, that platelets is the first to improve after any C5 inhibitors, then come to the others like hemoglobin, the LDH, and the kidney function. So this is for the creatinine, dropped significantly, and again for the C3 normalized after a few days. So I just want to highlight that we are among other colleagues in GCC countries that started our kidney transplant. This is adult and pediatric. Of course, Saudi is the leading in this field, with many hospitals doing that, UAE and Qatar in the middle, and of course Oman and Bahrain at the end. So all GCC countries have an active programs. If we're taking Saudi as an example, this is data from 2022. They did at least 12 cases with atypical HUS, and they received the C5 inhibitors, and the National Guard about 5 cases. So it's not uncommon, and we need to keep a very low threshold and aware about the signs and symptoms that can the disease either recurrent or a new manifestation of the disease itself. So before going to more details, I would just like to highlight the pathophysiology and the abnormal dysregulation of the atypical HUS. It's a dysregulation of the complement system. We know that we have 3 systems: classic, alternative, and lectin pathways. The problem here happening in the alternative pathways with common pathway ending into, like from C3 to C3b, and C3 convertase go to C5 convertase, which will divide the C5 to A and B, which are responsible for the TMA's picture, endothelial damage, and platelet activation and others. So sometimes we have genetic mutation in a good number of cases. Well, that is why we are saying it's atypical, because it's not produced by Shiga-toxin. And this is either loss of function of mutation or gain of function, so that there is a dysregulation of the complement system. The common pathway is the C5, and we are introducing these C5 inhibitors, whether in the previously eculizumab and now ravulizumab. It works at the terminal complement pathway. So the 3 main pathology that causing to the triad of the HUS is we have endothelial injury that lead to thrombosis and ischemia with multi-organ will be involved, including the kidney and other organs. This thrombosis can lead to consumption and thrombocytopenia, and of course, if this process is continued, this will lead to anemia, which is secondary to mechanical fragmentation. So to have a TMAs, either we have a primary hit, which could be an intrinsic factor, either due to genetic mutation or to antibodies, or extrinsic triggers like what we facing. Of course, transplant is one of these things. Other is like malignant hypertension, pregnancy in other patients with HELLP syndrome and other medications. All together with the primary and secondary causes can lead to the TMAs. There are thresholds between different patients, which can different according to their response to the internal and external triggers. And this threshold will tell you when the patient will show the manifestation. And of course, a patient with a genetic background, the predisposing factor will be having a lower threshold to show the disease, and as compared with a patient who has no genetic mutation. What are the risk factors for manifestation renal transplant? Just to highlight that these are all risk factors for recurrence of the TMAs, including genetic variants, age of onset. The younger the patient shows the manifestation, the higher the chance that the patient will have a recurrence, family history, kidney transplant, pregnancy, and other causes of secondary TMAs like due to medication or autoimmune like lupus. So when we are transplanting a patient, there are certain factors that play an important role and that can cause either a new onset of the TMAs or a recurrence of already presence of TMAs in a transplanted patient. Genetic abnormalities, whether it's mutation in one of these genes, antibodies, or others. And of course, other precipitating factors, including the immune suppressive medication, including calcineurin inhibitor, surgery infection, delayed graft function, and of course, rejection altogether will lead to the pathophysiology of the TMAs. Keep in mind that we have around 40% of patients who are diagnosed with atypical HUS. Still, we are not, 40% of them will not have a genetic background. So like in this patient, our case, she's known to have the DGK mutation, which is again not responsive to C5 inhibitors. And the genetic test did not show any of these genes, but still 40% of these cases still could show atypical HUS without a genetic background. Again, another 30% of the patient could have no identifiable trigger, which can show the HUS itself. So some studies in pediatric and adult showed that around 20% of the patient who had recurrence of HUS after graft usually have some genetic mutation. In adults, it's around 50 to 60%. The risk for recurrence increase with genetic background or triggers, and usually sometimes both factors playing together to reach to that point. So the TMA recurrence after transplant, it could be a recurrence of the original disease. So you have a native kidney failed as a result of TMAs, and it recurs in a renal transplantation. Or de novo, a new onset of or developed for the first time without any evidence of the disease before the transplant. De novo TMAs raises about up to 40% of renal transplant recipients. What are the de novo triggers for TMAs in a kidney transplant? Either rejection, especially antibody-mediated, genetic abnormalities, immune suppressive, calcineurin inhibitors, dysregulation in the C3 glomerulopathy or C3 glomerulonephritis, viral infection, and also misdiagnosis. So the patient has, and we see that maybe adult colleague that misdiagnosis initially reached the end stage renal disease and then got transplanted, and once the transplant patient, the TMA will show. So This is a nice study to show that there is the effect of the TMAs, whether it is isolated or renal involvement or with a systemic on the graft survival as compared with the normal population. You can see that patient who has systemic disease or renal involvement has lower graft survival post-transplant as compared with the patient who did not show any TMAs manifestation post-transplant. French study here again study the same to see the effect in pediatric and adult patient, and of course show that post 1 year kidney transplant, the survival reduced significantly, especially if the patient was not placed prophylactically on C5 inhibitors. Among all the genetic mutation, the high recurrence rate for the disease post-transplant is complement factor H and complement factor I, up to 80%. And of course, C3 glomerulopathy also with C3 abnormalities having a high chance of recurrence. So I remember it always as high, which is factor H and I, and of course that will affect the long-term outcome for also the survival for the kidney transplant. These are this table of summarizing all the studies that involve patients who received eculizumab previously, either prophylactically or after the transplant, and summarizing the outcome and the recurrence of the HUS post-transplant. Here, if you can see that even a patient who received C5 inhibitors, as compared with the native kidney, it takes time for the complete TMA response. So the ideal way nowadays to include this medication in the induction therapy to not delay the response, number one. Number two, to not wait until the manifestation of TMAs happen post-transplant. And again, since most of the publications were about eculizumab, now ravulizumab also showed in the latest clinical trials a good response as compared with native kidneys and transplanted kidney at 52 weeks, where complete remission of the TMAs more or less the same percentage. The GFR may be not optimal, but we know that it takes time for the GFR to improve as compared with the native kidney. So another study subdivided into three groups. Group 1 who received eculizumab treatment initiated at or prior to transplant, around 88 patients, and group 2, which is subdivided into A and B. Group 2A, HUS diagnosis pre-transplant, and HUS diagnosis in post-transplant. And we can see here in group A, as compared with the two groups, the GFR is better, where they received prophylactically the C5 or eculizumab inhibitors. But again, pre-transplant, if we diagnose the patient with HUS, which very important to have highlight this before the proceeding with the transplant, still they have a reasonable good outcome of the GFR as compared when the patient diagnosed post-transplant. So here on the other graph on the right side, you can see that the patient who received prophylactic eculizumab did not require, or the minimal requirement for dialysis for other reasons, as compared to the patient who diagnosed post-transplant and then received the eculizumab, they required dialysis quite for some time. So some consideration where we are thinking about HUS management in a transplanted population, selection of the donor. There is a relative contraindication to use a living related donor for the transplant, because especially if we don't have a genetic background, even if the genetic test is negative, sometimes the manifestation will happen with the trigger like big events like transplant. So we need to be careful. It's not an absolute contraindication. So preferable to have living and related donors, especially if genetic test is negative. On the other hand, prophylactic C5 inhibitors to be considered in all patients with atypical HUS due to known pathogenic mutation. That's by default. And in patients who is having a biopsy-proven diagnosis of TMA in a native kidney, whom a genetic variant has not been identified. So that as a prophylactic. Last thing that I would, there is no clear evidence when we have a patient showing TMA symptoms and signs post-transplant for how long we need to continue these C5 inhibitors. This is a nice study to show like a proposal for how long to do it. So if we have a pathogenic mutation and recurrence in the previous allograft, of course, these are patient who has factor H autoantibodies or factor I. So the recommendation is to give them lifelong treatment. On the other hand, if we have the genetic mutation showed VUS, then we can do further analysis for microdeletion and others. And if it's pathogenic, of course, we have to do a lifelong. If it's benign, then we have maybe to discontinue that between 6 to 12 months, depending on the patient response. If other factors are not there and the patient having low genetic mutation with low recurrence rate and very well controlled even with antibodies and in remission, then it is reasonable to discontinue that maybe 6 months to 1 year post-kidney transplant. And by that, I would summarize my talk about multiple factors play a role in TMA risk post-transplant, and patients with atypical HUS have a higher risk. TMA post-transplant portend poor graft outcomes, and of course, plasma exchange, plasmapheresis fail to prevent graft loss. I think more analysis about new data with the new medication is something we need to consider for future analysis. And I would like to thank our grateful team, nurses, doctors, coordinators, and dietitians who helped and taken care of the patient. I'm open for questions. Thank you.
Thank you, Dr. Luai, for interesting case. There are a few questions from the audience. In case of atypical HUS with negative genetic testing, how we can predict recurrence after transplantation without genetic data? And would you prefer listing such cases for deceased donor or live donor transplant?
So that's a good question, actually. So it is very unclear. The first thing if we usually advocate for living donor, but with a negative genetic background, still, as I show in one of my slides, there are 40% of the cases we don't have any genetic diagnosis, which can, the genetic factors are evolving over years. So maybe later on we will find something. But as I said, it's a relative contraindicated. If the patient is stable, then we can proceed with a living donor. Otherwise, it should be as a diseased donor. We need to keep an eye if the patient was not placed on C5 inhibitor pre-transplant, then maybe we include that as part of the induction, especially if we know that the treatment or the failed graft is because of the TMAs. This patient is at high risk. Otherwise, we can just monitor if at any time post-transplant they have signs of TMAs, then we can introduce the treatment. But ideally now the protocol everywhere, if the patient is just put it in this way, straightforward, has positive genetic, failed graft because of TMAs, then they need a prophylactic treatment and part of the induction therapy, and to continue that for certain times. If it is a high risk recurrence, then for life.
Right. So in your case, the one you have presented, would you recommend the treatment or would you stop it at this stage?
Actually, I stopped it from October and she's stable. And then I think it's reasonable to monitor her, although that she's still at high risk because her younger sister, 5 months old, presented the same way with HUS. and her genetic test came DGKA. There is no other background. So still she's at high risk to have some recurrence, but I think it's reasonable after 1.5 years or 2 years almost of hair transplant to try and see without the treatment.
So when you say stable, you are measuring complements or there are other factors?
So like there is no signs of TMS activity. So her platelets, hemoglobin, blood film, everything looks normal. The
Remission.
normal. Her kidney function is stable. And there is no proteinuria. So all these parameters are normal. She's not hypertensive.
Right. Right. Okay. So there are no more questions. Thank you very much, Dr. Lai. Now we'll proceed with our next speaker, Dr. Abdul Basit.
السلام عليكم.
وعليكم السلام. A well-known speaker in our conference, Dr. Abdul Basit is Professor of Internal Medicine and Nephrology. He is former Associate Dean of Ras Al Khaimah University, visiting Professor of Harvard Medical School, and scientist at Brigham and Women's Hospital in USA. Currently, he is Deputy Director of Academic and Training Affairs and Director of Residency and Internship Program at Faqih University Hospital. And Dr. Abdul Basit is going to update us today about post-transplant diabetes. Dr. Abdul Basit, the screen is yours.
Thank you. Thank you very much, Dr. Amna, for the kind invitation and giving me the opportunity to be one of your speakers every meeting. And this pleased me and helped me to update my knowledge on each topic you assign me for. So this is the framework of my talk. I will try to give everyone like 4 minutes, the first 6 minutes, so I hope I will be on time. So let's go directly. So what is what do we know about the prevalence of diabetes post-transplant? When you go to the literature before 2018, you will find the prevalence is variable between 5 and 60%. Why? Because until 2018, there were no consensus whatsoever from any transplantation society or the WHO about the definition of post-transplant diabetes. To each center was publishing based on his own definition. So starting in 2018, both the WHO and the American Diabetic Association have come together to a conclusion about the reported incidence and the prevalence with a proper definition. So it reduced to 39% at 1 year, 10 to 30% at 3 years. The importance of this is, what is the importance of getting to know post-transplant diabetes? I'm not speaking here about already existing diabetes, because it affects both not only graft function, but graft survival, and not only morbidity, like a cardiovascular for the patient, but also mortality. So it is very beneficial to identify the high-risk group and handle them in modifying their immunosuppression. And this figure can tell you about the cardiac event in people with no diabetes, new post-transplant diabetes, and diabetes, and you can see how serious it is to acknowledge. And also regarding the mortality, you can see the mortality in those people are high in those who already have a pre-existing diabetes or have a new onset post-transplant diabetes compared to those who have no diabetes. I saw the program, and I saw that Dr. Amna and the organizing committee have given the topic of SGLT2 inhibitor to Dr. Ala, diabetologist in the Bio Hospital, and this will help me to go more better about the pathophysiology, because what happened in all the talk, most of the people focus on clinical part or diagnosis, management, and a good deal of them sometimes, because they are too busy, they don't go through the basis and understand what's going on and how this can happen. And this, by definitively, will help any doctor when he understand the genetic and pathophysiology to tailor his management. The guideline is good to help people in management, but actually there is no one prescription who fit all, and individualization or precision medicine is the future. So you need to deal with each patient as a separate case entity by itself. So the genetic factor, there are 5 types of genetic factor here related to post-transplant diabetes. So everyone think post-transplant diabetes. I'm sorry, my voice is not clear because I have a long-term flu after Umrah. But anyway, I hope it's not affecting my talk. So everyone think it is related to immunosuppression, but there are another many factor, including genetic factor, like tacrolimus, which is the most famous immunosuppressive metabolism, T-cell activation, genetic variation, interleukins, and inflammation. So TAC has been reported as the highest risk factor of post-transplant diabetes. And as it is metabolized by cytochrome B450, so any abnormality in the metabolizing cytochrome will affect the TAC level and affect the diabetes. Also, it had been found there is a strong correlation between the metabolizing cytochrome for tacrolimus in case of presence of gene polymorphism or mutation and the post-transplant diabetes. So also the promoter of the cytochrome 24A responsible for TAC metabolism contain vitamin D receptors. And so any deficiency in vitamin D may affect also the development of post-transplant diabetes as the cell vitamin D receptor is expressed on the beta cells, and it helps secretion of insulin on the beta cells. So low serum vitamin D was associated with an increased risk, not only for post-transplant diabetes, but in general population. A second genetic factor is we call it PPAR gamma. It's pre-exosome proliferative activated receptor. Simply, it exists in certain food like green tea, blueberry. It has this PPAR gamma. And this is responsible for conversion of the bad white fat into the good brown fat. So it helps because the white fat is the storage fat, brown fat is the burning fat. So it helps browning of the white fat. And it also exists in some medication like ARBs, like telmisartan or arbisartan. And any mutation in this PPAR gamma independently associated with post-transplant diabetes, especially those who are treated with tacrolimus, and this has been proved with a meta-analysis involved almost 75,000 patients as a cases, and the control when there is a polymorphism in this PPAR gamma, it contributes to post-transplant diabetes. The third gene is related to T-cell proliferation and activation through the TCF7. Unfortunately, this TCF7 is also not only controlling the differentiation and proliferation of T cells through the Wnt signaling pathway, which is an old, highly conservative and complex mechanism of intracellular communication, but also controlling pancreas development and the maturation. So TCF7 is one of the of the gene responsible for development of post-transplant diabetes, especially the T allele. And this has been proved in a group of a study presented by meta-analysis for almost 500 patients when they have this T allele in TCF7 responsible for proliferation of T cell. It is associated with post-transplant diabetes. The last one is interleukin 17. Interleukin 17 actually is a promoter or the stimulator in a vicious circle or all the inflammatory cytokine like TNF alpha, interleukin 1, interleukin 6. And this inflammatory cytokine lead to recruit both neutrophil and macrophage and lead to induction of inflammation and insulin resistance and lead to diabetes. The final one is nuclear factor of activated T cell. Any polymorphism is associated with, so it is not only the medication, but also there is a genetic background and having in mind that post-transplant diabetes affect patient survival and the graft survival, it will be very good if we can predict it's happening early before transplant through gene-wide associated study. So we identify those who have a genetic risk, and we can handle them by modifying the immunosuppression to minimize the risk of diabetes, or at least choose proper donor with good match, so it minimizes the immunosuppression, minimize the risk of diabetes. So I wanted to highlight this part. And going to more simple part, we have some conventional risk of developing post-transplant diabetes. We know it before the transplant, like old age, African American, obesity, family history, adult polycystic kidney disease, some infection like HCV, CMV. And there are some transplant specific. Everyone knows this. I don't need to go through them. The most important factor of them is the immunosuppression and the number of mismatch. And one of the things, some of the people come to us and say, oh, we have diabetes, and once we develop renal failure, the diabetes disappear. Why? Because 25 to 40% of insulin is secreted through the kidney. So when the kidney fails, so mild degree of diabetes improve due to accumulation of insulin. So when the patient got transplanted, the excretion of insulin go back to normal, and this will help returning of improved pre-transplant diabetes. In addition to many factors post-transplant, which lead to increased insulin resistance, like post-transplant infection or post-transplant obesity due to steroids or immunosuppressive drug, especially calcium urine, especially tacrolimus, and I will come to this later on. This slide, it looks out of topic, but it's very important for me because Harry Haran, in this is important New England paper, screening 60,000 patients, have come by a conclusion that 50% of transplant patients have serum creatinine, apart from deceased donor, have a serum creatinine more than 1.5 milligram per deciliter, which puts them all as a stage 3 CKD. A stage 3 CKD. So all the transplant who have serum creatinine above 1.5 milligram, which represent almost half of the transplant cohort in USA, have CKD stage 3. We call it T-CKD stage 3, transplant CKD. What's the value important of this? So what is applied in a people with CKD non-transplant will apply in this 50% of the transplant population to them. And all of these factors, I will not go explain for the sake of time, but I will show you how much factor in a patient with a CKD non-transplant or CKD transplant have factor which can lead to insulin resistance, including intracellular signaling of insulin, aldosterone, gut microbiome, adipokine, vitamin D deficiency, metabolic acidosis, physical inactivity, uremic toxins, inflammation and oxidative stress, suppressor of cytokine, ubiquitin protease system, and anemia. All of those factors which exist in a CKD, pre-transplant or non-transplant, is existing in a T-CKD or transplant chronic kidney disease or failing kidney transplant. So what is apply on a CKD non-transplant causing insulin resistance apply for the transplant causing insulin resistance. So once the serum creatinine grow up above 1.5 and the eGFR drop below 50, then all these factors will contribute to development of post-transplant diabetes. We have some diagnostic challenges because, post-transplant, you have a patient who already have anemia before transplant, and hemoglobin A1C is unreliable because of anemia. You have patient who might receive the blood transfusion during the transplant. So you will have many challenges post-transplant in addition to certain immunosuppression, which inhibits the bone marrow, like MMF. So you have many challenges which affect the diagnosis of diabetes post-transplant. So the guideline, they all them went to oral glucose tolerance test. Also, actually, to be honest, not much people who follow transplant is using it. But they have put three reasons. A patient should be screened for hyperglycemia with a formal diagnosis being made once the patient is stable with immunosuppressive regimen and absence of acute infection. So you cannot basically, from clinical practice, diagnose post-transplant diabetes in the first 6 months. And the second thing, oral glucose tolerance test, due to the thing I mentioned about hemoglobin AC, is the preferred test. Also, I'm not sure how many people are using it. And immunosuppressive regimen, also, even if it can cause post-transplant diabetes, like tacrolimus, it has to have a priority over, respectively, of being high associated with high risk of post-transplant diabetes. This is the consensus came from ADA guideline 2018, and it is not updated until now. And the diagnostic criteria for post-transplant diabetes, pre-diabetes, it will show in the table next slide, but we have to put in our mind that hemoglobin A1C, especially in the first 6 months, is not adequate to reflect the level of hyperglycemia due to the reason I mentioned, due to pre-transplant anemia or blood transfusion, or the impact of immunosuppression on suppression bone marrow. And this table, as it applies for diabetes, it applies for diabetes non-transplant, it applies for transplant, but the most important in transplant is the oral glucose tolerance test, which especially 75-gram oral glucose tolerance test, which I don't see many people in the practice using this. So, having mentioned that, we have to put in mind impaired fasting glucose or impaired glucose tolerance are very important in the progression of the patient itself, because they are considered as a pre-diabetes and a risk factor for micro and macrovascular complication in post-transplant. And as I said before, as you have impaired fasting glucose or glucose tolerance, ideal is to use oral glucose tolerance test. This is the gold standard, which the people, unfortunately, is not using it. Even impaired glucose tolerance itself is independent risk factor for post-transplant diabetes and cardiovascular disease. So, according to the present evidence, the diagnosis of post-transplant diabetes is kidney transplant recipient by hemoglobin A1C is not really currently accurate, especially in the first 6 months, and also if the patient develop a creatinine increase, which represent more than 50% of transplant cohort with a creatinine above 1.5, and they have eGFR around 50, and this is with starting deficiency of erythropoietin and anemia. Okay. However, as we do it, we have to respect it, but it has to be confirmed by oral glucose tolerance test. So one more thing about the demography or the pathogenesis is that people who develop early hyperglycemia post-transplant have up to 5-fold higher risk of developing post-transplant diabetes. This is number one. Number two, patient above the age of 45 have almost 3.5 increased incidence and the prevalence of post-transplant diabetes, like 3 times, you can say. And every 10 years post-transplant, you have 1.5 time fold increase in post-transplant diabetes. So we have to keep this in our mind. Any patient above 40, and every 10 years of post-transplant, you have almost 3 times was above 40, and you have 1.5 time. So you have to screen this thing. And I showed early, it is impacting both graft survival, it is non-diabetic versus diabetic, and patient survival, non-diabetic versus diabetic. And again, there are meta-analysis who showed the graft failure between those who have diabetes and those who doesn't have diabetes clearly show that these people who has diabetes have not only graft failure, but they have increased mortality. So immunosuppression, I focus about the mechanism, just to orient the people rather than keeping. I will give a small hint about treatment, but it is very famous. Tacrolimus has a pleiotropic effect in inducing diabetes, because tacrolimus induces its effect through blocking of FK 506 protein. This FK506 binding protein is expressed on pancreatic beta cell. So when you use it to suppress the T cell, you suppress the beta cell on the same time. So keep this in mind. This is how it works. And it helps through certain mechanisms. I will not go to detail of it because it's too basic. And it also decrease the transcription of insulin promoter. It's called CAT, chloroamiphenol acetyltransferase, which is responsible gene for producing insulin, and also can cause apoptosis. So it could suppression of beta cells through FK binding, 506 binding receptor over beta cells. It inhibits the insulin promoter, enhance insulin secretion. It can cause apoptosis of beta cell. It suppresses the release of insulin from the pancreatic cell, and it increases at the peripheral level in the blood in insulin resistance. So however, the good thing about the TAC effect on glucose metabolism is completely reversible as early as 4 days post-stopping the TAC. Okay, so cyclosporin, as I said, it does the same thing, but it's almost 20% compared to tacrolimus. Exactly the same mechanism, because both of them have calcineurin inhibitor, but 20% compared to the tacrolimus. And again, Rapamune also, it inhibits the synthesis of GLUT1, and GLUT1 is responsible for proliferation and insulin production of beta cell. And of course, all of us know glucocortisol. So we'll go about treatment, and I will focus only on GLP-1 in a brief way. I need to give the people some idea. I like to explain to people. Sometimes you see a patient who is 150 kilograms and he doesn't have diabetes. And sometimes you see a patient who is 60 kilograms and have severe diabetes. How does this happen? It depends on the volume of beta cell. The volume of beta cell is variable individually from one person to another, from 0.6 gram to 2.1 gram. I have one of my relatives, almost 120, 130 kilogram, 75 years old, no diabetes. And I meet people, especially who is coming from Southeast Asia, at the age of 25, who weigh 65 kilogram, and they have diabetes. This goes back to the size of the beta cells. If the size is small, so they are more prone to develop diabetes. But if the size is big, even if the patient is big, they don't develop. And this explains how people who you might see people with morbid obesity, but they don't have diabetes. And this small amount of beta cell of islet of Langerhans. This is the islet of Langerhans. Sorry, this is the weight of all islet of Langerhans. And this islet of Langerhans, it contains up to 1 billion beta cell. 1 billion beta cell. So the human pancreas, which is almost 91 grams, ranging between 40 and 180, for those who are lucky, approximately they have 1 billion beta cell. So this can explain, and insulin is secreted up to 1 to 3 units per hour regularly, but if the patient is eating too much or increasing in weight, the excretion can go up to 7 units per hour. So this is very important. People point explain why some obese patients are not diabetic, or thin ones are diabetic. And I wrote this paper published in January 2019. It was an article review. And I defined the future of treatment of diabetes, whatever in transplant or non-transplant, on 2 things. First, we have to focus on improving end organ complication, mainly cardiovascular and the kidney. Number 2, we have to rest beta cells and try to work away of beta cells. Because, you know, if you go to more and more in diabetes, you see some center early in diabetes, they treat people with type 2 diabetes with insulin right away to rest beta cell. When it is rested, it recover and proliferate, and the diabetes can recover if it is mild, or need a small treatment if it is more severe. So this was the 2 major strategy. I spoke about them in this article. If you go current opinion and nephrology and hypertension in January 2019. And it turned out to be the right thing. Everyone is following it now. This summarizes, I will not go in detail, all the anti-diabetic in the market and where it works. But I focused on 3 things. Metformin, and I said what is doing in your right hand, GLP-1 agonist, what is doing, and SGLT2 inhibitor. This 7 years ago. If you focus now about treatment of diabetes in transplant or non-transplant, all is focused about these 3 things, because they proved, in addition to their anti-diabetic effect by reducing hemoglobin A1C, many other beneficial effects in protecting heart, kidney, and liver. As I said, we have to focus on end organ protection, cardiovascular and the kidney. But now, both of them, SGLT2 inhibitor and GLP-1 agonist, are protecting the liver, and GLP-1 agonist coming to the market now, approved in UAE now for treatment of MASH. And just to you know, just a small reminder about the mechanism and how it comes. So it protects the heart here, and FDA approved through the studies, and it protects kidney. It is FDA approved, and now it is approved in treatment of fatty liver. That's the GLP-1. FDA approved for treatment of heart, select trial. FDA approved for the liver. FDA approved flow study for the kidney. So what is about GLP-1? Efficacy. It is very significant in reducing hemoglobin A1C and fasting blood glucose and weight loss, not only in kidney, but also in liver transplant. 2, GLP-1 are generally well tolerated, with side effect primarily limited to mild, moderate GI issue. They are considered safe for renal transplant recipient and appear do not appear to significantly alter tacrolimus pharmacokinetic. And it shows that lower risk of transplant failure up to 49%, and lower risk of mortality over 5 years by 31%. It's magic. And so this agent, not only one of its mechanisms, in addition to the mechanism I just mentioned rapidly. It helps reverse the tacrolimus effect on the beta cell, which I explained earlier. It helps reverse the tacrolimus effect on beta cell. And this is one more mechanism which does not exist in non-transplant, exists in transplant. And it is very safe. I use it very safe. And you can see here, this just come in Lancet. And they used this study. I'm almost done. 2 slides, I'm done. So in Lancet study, it is a retrospective study. They went almost through a very, very dedicated study here. And they end up started by having like more than 50,000 patients. They end up by 18,000 patients. And it shows that there's 40% lower incidence of death and 31% lower mortality in people when they are treated with GLP-1 agonist. Okay, one more cell. This is my research group in Brigham and Women Hospital, where I'm working this as a scientist. And we have come by a very nice experiment. This study took 5 years, and it published of the cell metabolism. It is 31 impact factor. It's number 3 among 128 endocrinology journal after the Nature. Okay, and this shows that the GLP-1 can act as a T cell negative co-stimulatory molecule. So it enhances the immunosuppression. It helps the immunosuppression. So it helps protecting the graft. And it prolongs allograft survival in animal model. It minimizes the alloimmune response. And it reduces the T cell lymphocyte infiltration. Not only this, it was found in animal model that it is have anti-tumor immunity in colorectal cancer in animal. And my friend, Dr. Paolo Vaiorina, is a recurrent speaker in my conference, established a company to use it as an anti-cancer medication. And this is one more for the thing. So 2 words about metformin, and I am finished. Okay. So again, on focus on medication with potential of end organ damage. The problem of metformin, it can cause lactic acidosis. And I just said when I started the talk that half of the cohort in the United States have a serum creatinine more than 1.5 milligram per deciliter, which is eGFR around 45-50. So when you have a patient who has this serum creatinine, it is better not to use it in a patient with a transplant if they have the serum creatinine more than 1.5. And even the FDA put a black box warning because it will increase the lactic acidosis, which have a negative impact in the people. And wisely, for those who have an eGFR above 45, better to limit its use by 1,000 milligram a day, no more. And if the eGFR drop below 45, below 30, stop it completely. And if you have a patient sometime who are following a transplant in a large clinic, we have people who come one day with 1.5, and in the next visit is 2, and the visit after is 1.9. So they have labile kidney function and unstable kidney function due many factors, mostly non-compliance. Sometimes they forget they take the medication, as they are dehydrated, they're taking non-steroidal. So those who have a plain serum creatinine, go away from metformin as low below 60, because this can come to you by a sudden drop of eGFR to 30 for whatever reason, and then they will have complication. So generally speaking, 45 is a cut-off point. If it is 30, stop it. For those who are labile, stop by 60. And we have to put in mind that concomitant use of metformin and MMF is not really very, it's usually associated with more gastrointestinal side effect. So you have to watch the patient very carefully, but there is no drug-drug interaction between metformin and MMF. And this is the last slide before I close. Metformin did not prove any cardiac protection, especially in published in a United Kingdom prospective diabetes study, only in a subgroup of people who are overweight. That's it. So to close, a transplant recipient who have hyperglycemia should not be confused with post-transplant diabetes because they are receiving a huge amount of steroid post-transplant. Diagnosis should not be confirmed except after stable graft function, maintenance, immunosuppression, absence of infection or rejection, and this is mainly after 6 months. Patient with post-transplant hyperglycemia have 4 to 5 times risk of developing post-transplant diabetes. So if you have a patient who developed hyperglycemia post-transplant with a steroid, we keep open eye on them. And the people above 45, we have to look after them. And we need a gene-wide association study to identify high-risk group so we can tailor our immunosuppression. But this is not applied yet. We hope in the future. 50%, as I said, of transplant patients have a serum creatinine more than 1.5, which puts them in a CKD stage 3. It is risk factor for developing a diabetes. Careful in using metformin. Empagliflozin is effective in controlling TAC-induced hyperglycemia. When you put EMBA in experimental trial, it seems I missed the slide here. They brought the beta cells in a vitro, and they put on the beta cells tacrolimus, and they measured the insulin. They found that the insulin has decreased too much, and then when they added on the experiment EMBA, this effect of TAC on decreasing insulin and inducing apoptosis was disappear. It was reversed by empagliflozin in an experimental model. Sorry, I missed the slide. Okay, and finally, GLP-1 agonist is now proved to antagonize the impact of tacrolimus on islet beta cell and to minimize the kidney the transplant kidney injury, and in experimental model proved to have immunosuppressive effect and anti-cancer effect. And thank you. I put the picture of this man who is the one who did segmental pancreas transplant, first hand transplant, first face transplant, and this is Professor Ghanem, the leader of transplant in the Arab world. Thank you.
Thank you, Dr. Abdul Basit, for interesting updates. There are a couple of questions for you. Right. So, in Arabic ethnic background, any specific HLA typing have been identified as a risk for post-transplant diabetes?
For my knowledge, no.
Right. What is the effect of GLP-1 on absorption of immune suppressant?
It has been, it has been shown as not affecting, there's no drug-drug interaction, and it doesn't affect the absorption of tacrolimus. Other immunosuppression, I have no knowledge. Only tacrolimus, it doesn't affect the absorption of tacrolimus.
In era of GLP-1, what about obesity paradox in CKD, dialysis and transplant patient?
Yeah, GLP-1 is very safe in dialysis patient. Of course, the obesity paradox, it says, the word paradox, for those who doesn't know, people who have obesity have a better outcome on dialysis compared to people who are not non-obese. This is the meaning of paradox, obesity on dialysis. Obesity have better outcome on dialysis. But using GLP-1 agonist on dialysis based on publication and personal experience, there is no problem. And but unfortunately, from my personal experience, I use only semaglutide. I don't use the combination GLP-1 and GIP, which is Manjaro or Zepbound. I use only either semaglutide or Wegovy, and just have a patient who have 22 kilogram reduction, his BMI above 50, and I think I registered him with you, Dr. Amna, for transplant. And I managed within 3-4 months up to 1 milligram only Ozempic. He reduced 22 kilogram of his weight. We are keeping going until we reduce his BMI to 32. But it's completely safe based on limited publication, because still there's no wide use yet. And the personal or individual experience based on me, I have few number, I have no problem.
What is the risk of acidosis and GIT side effect when metformin is combined with GLP-1 from your experience?
No, GLP-1, it doesn't have impact on acidosis. GLP-1, it doesn't have impact on acidosis. Maybe the question will be if it was SGLT2 inhibitor. I didn't mention SGLT2 inhibitor at all, as Dr. Ala will speak about it, so I didn't touch it at all. It's known that SGLT2 inhibitor, especially in a Japanese population, which they publish about it very early, can cause subclinical ketosis. So if you add it to metformin, you might increase this. But with GLP-1, GLP-1 doesn't cause acidosis at all.
Why pancreatic transplant is not popular as liver and kidney transplant?
This is no. I worked in pancreatic transplant. So earlier when they did pancreatic transplants, they have two main mechanisms. The man I showed his picture, I said Professor Jean-Michel de Bernard, who is the first who made the first segmental pancreas transplant. They used to take the pancreas and cut the tail, and then they inject nutrient material to cause sclerosis for the exocrine alkaline secretion of pancreas, which is almost 2 liters per day, and to keep the tail only to produce insulin cell. The side effect of this is not 100% successful, and it causes fistula if some of the cell is still secreting alkaline phosphatase. This limited the segmental pancreas. The next step, because the pancreas have a good amount of alkaline secretion, so they anastomoses the pancreas to the base of the bladder. So the alkaline secretion go to the bladder, go with the urine. But this was associated with cystitis and hemorrhagic cystitis. And I remember when I was a fellow in France, I did an audit paper to be published, compared segmental pancreas to bladder derivation pancreas, and I found both of them are catastrophic. And I compared them to digestive portal vein or portal vein anastomosis and connection to gastrointestinal intestine directly, not to the bladder and not segmental pancreas. The data was beautiful, but the center refused to publish it because the complication of segmental pancreas and the bladder-based pancreas was too much, so they didn't publish despite the effort. So this is why the pancreas transplant is not as famous as popular, because initially, until like 20 years back, segmental was too complicated, bladder derivation was too complicated, portal systemic derivation is more active, and there is always a problem when they do harvesting from cadaveric, when they take the liver and the spleen, there is always some time where, if you go to the anatomy, the tail of the pancreas is sleeping on the kidney and connected to the spleen. When they do harvesting, they injure the pancreas. So the amount of pancreas harvested suitable for transplant is much less compared to the kidney, which usually you take double organ from the same patient. So you lose a lot of pancreas during the harvesting process. I hope I answered your question by this.
Thank you very much, Dr. Abdelbasit. So from diabetes, we'll go to our diabetologist, Dr. Ala, next speaker. Dr. Ala Din Bashir. He's a consultant endocrinologist and internist at Dubai Hospital, with 23 years of experience in endocrinology, diabetes, and internal medicine. He's a clinical professor of endocrinology at MBRU and adjunct professor at Dubai Medical University. He's honorary professor of medicine at Sinar University in Sudan. And he's going to update us today about SGLT2 role in kidney transplant. And Dr. Ala is our partner in combined diabetic nephropathy clinic. So Dr. Ala, welcome to this talk.
Thank you very much, Dr. Amna, for inviting me to this platform. And I'm quite interested actually in nephropathy, the diabetic kidney disease, and transplant patients. Quite intimidated having my talk after Professor Abdul Basit. It was an elegant talk, and I'd like just to add to have a couple of comments. Just on metformin and GLP-1. Metformin has been used previously since ages in management of diabetes and in transplant patients because of the safety profile of metformin that we have known in general diabetes. And when we started doing the transplant, we know that there is no major side effects until the eGFR drops below 45, then we have to reduce the dose. The studies of metformin in transplant patients, as Professor Abdul Basit mentioned, did not show benefits in cardiovascular benefits. However, there is a meta-analysis that showed improvement in death-censored graft survival. Otherwise, there is no major benefits. With regard to the GLP-1, until recently, maybe 2 years ago, there were no studies at all. But over the past 1.5 years, there were retrospective studies and meta-analysis that showed improvement, cardiovascular outcome, and in graft survival as well with GLP-1. Now, when we talk about the SGLT2, I think this is the main talk I'm going to talk about. And I'll start with this case. We're not going to go into details, but this is one of my patients in the clinic. He's a 72 years old, known to have type 2 diabetes, quite eventful history, type 2 diabetes, hypertension, dyslipidemia. He had an ischemic heart disease in 2011, and he underwent PTCA with PCI to the left anterior descending and the circumflex. He developed then heart failure with reduced ejection fraction, and his ejection fraction is 30 to 35, and he has severe pulmonary hypertension as well. He had a history of renal stones, and he had nephrectomy in Germany in 1980. Then he developed CKD. It's partly because he has as well adult polycystic kidney disease and diabetic nephropathy resulted in dialysis. And then he underwent a kidney transplant in Russia in 2024 with live unrelated donor. His kidney functions post-transplant is showing a creatinine of 0.8, and he's on Myfortic, Prograf, and prednisolone. And if you look at this patient, if this patient did not have a transplant, probably with the nephropathy, with the history of heart failure, I would say, well, SGLT2 is indicated, and I'll start immediately SGLT2 inhibitors in this patient. But once a patient has a transplant, then we ask ourselves a couple of questions. I would say, does my management differ in this patient if he was an established diabetes from before, or he just developed diabetes after transplant? So is his diabetes new or was there before transplant? Would my management plan differ or not? And the second question, I'd say he had an ischemic heart disease. He has heart failure. Should I start SGLT2 inhibitors? Is it safe in this group of patients or not? And I would say, should I follow the guidelines and start metformin and then consider GLB SGLT2 as second line, or it is indicated as first line in this patient? So to answer this question, I'd like to take you through evidence for SGLT2 inhibitors in transplant population. And I'll start with probably one of the its earliest, 2022. It's a large study from from Korea, and it involved around 2,083 kidney transplant recipients who already have diabetes. And out of this group of patients, they tried to look retrospectively at 226. That's around 11% of the patients who have been prescribed SGLT2 inhibitors. And the primary outcome they looked for in this retrospective study is to look at a composite outcome of all-cause mortality, death-censored graft failure, and doubling of serum creatinine. Just to make it clear, death-censored graft failure is graft failure due to any other cause other than death. So this is the primary outcome. They tried to look at a composite of all these together, and then they tried to look at the dip in EGFR post-transplant. So what did they find? What they found is that the mean age is around 62. Sorry, the mean follow-up was around 62 months. And they found that SGLT2 inhibitor group had a lower risk of primary composite outcome. And that has been reduced significantly by 57%. If you look at the hazard ratio was 0.43. So the risk reduction was around 57% in primary composite outcome. And if you look at the p-value is quite significant p-value. When you look at the death-censored graft loss alone, it has been reduced by 69%. And the doubling of serum creatinine was reduced by 55%. So the results were amazing. And what was interesting is that they found in their group of patients that the initial, when they started SGLT2 in this group of patients, that initial dip, they did not show in transplant patients. This is actually related to this study. There were 2 or 3 other studies that showed, again, transplant patients do show this initial dip in SGLT, in EGFR. So what they concluded that SGLT2 improved the composite all-cause mortality, death-censored graft loss, and doubling of serum creatinine. And they suggested that SGLT2 inhibitors can be used safely as it has beneficial effects in preventing graft function in diabetic kidney, in kidney transplant patients. So this is the one of the initial studies. Then later was followed. This is in 2024. Another larger retrospective study that included 50,000 diabetic kidney transplant patients. And what they did, because the number is huge, they did propensity matching. So they pulled some patients with SGLT2, around 1,970 patients. They matched them with regard to age, race, ethnicity, medication use, and even most of their laboratory tests. And they tried to look at a primary outcome. The primary outcome this time was the all-cause mortality. And if you look, the all-cause mortality in those receiving SGLT2 compared to a propensity-matched group was reduced by 68%. So all-cause mortality has been reduced by 68%. Not only that, if you look at the MACE, which is major adverse cardiovascular events, which is myocardial infarction, cardiovascular death, and stroke reduction, was actually reduced by around 52%. And the major adverse kidney events were reduced by around 48%. So the main cardiovascular and kidney events has been reduced significantly in those who are receiving SGLT2 compared to a propensity matched group. So another one, again, a propensity match study, again, from the first group that did the first retrospective study. And this time, they looked at major adverse cardiovascular events, which is MI, cardiovascular death, hospitalization for heart failure in a propensity matched group. And if you look at the major adverse cardiovascular events, which is the composite of all of them, it has been reduced significantly. And if you look at the p-value is 0.002, quite significant. Not only that, myocardial infarction has been significantly reduced, as well as hospitalization for heart failure in the group using SGLT2. So the authors concluded that SGLT2 significantly reduced MACE in kidney transplant recipients with diabetes, and the reduction is more pronounced in cardiovascular death and myocardial infarction, and that these findings would highlight the potential role of SGLT2 inhibitors in treatment in kidney transplant recipients. So having these studies done, what we thought in our center is to look into our data. We had data on a small group of patients, like a prospective study. We're still collecting the data, but the initial data showed safety, and we did not look at major cardiovascular events. But we thought, let's go and do a meta-analysis on SGLT2 in transplant patients. And just for people, the meta-analysis, actually, there are many steps for meta-analysis. Initially, you come with the idea, you look at, discuss the eligibility and the outcomes that you want to study. And based on the eligibility and outcome studies, you need to select the right studies and the right design of the studies, and you start doing your data collection. Once you collect the data, you do assess the risk of bias in each study that you select. And there are many ways of doing it. Statistical methods, there is something called the Joanna model, and there is something called Robin 1 and Robin 2. One is for randomized controlled trials and one for observational trials. And after you select your studies and you start doing the analysis, you do sensitivity testing for your results, and you assess whether there is heterogeneity in the results or not. And after you do that, you try to see bias, if there is bias in your results, by multiple tests as well. One is called Eggers regression test, and the other is called the funnel blot test. So what we did, we went through all these steps. And the eligibility for the study is not just only kidney transplant patients. We looked at SGLT2 in solid transplant patients. And we included patients more than 18 who underwent kidney, heart, liver, or lung transplant, who had either pre-existing diabetes or developed post-transplant diabetes later, or they have a mixed diabetes status. The intervention is treatment with SGLT2, regardless of the agent, EMPA, DAPA, CANA, any of them, following transplant. And we looked at the initial studies. We actually looked at multiple designs because our outcomes were quite different. So the primary outcome was the all-cause mortality, and we assessed it using the hazard ratio. And the secondary outcomes did include graft rejection and renal outcomes, eGFR, proteinuria, cardiovascular outcomes, MACE, and we looked at drops, changes in blood pressure before and after, metabolic changes, A1C, and weight before and after. And we also looked at safety outcomes. We looked at acute kidney injury, diabetic ketoacidosis, genital infections, and UTI. And we tried to look at SGLT2 users versus non-SGLT2 users. For improvement in outcomes, we looked at some observational studies to look at before and after transplant as well. So we did collect the data using all the sources, Medline, PubMed, Scopus, and Cochrane library. And then we had two of the authors who reviewed, and then if there is any conflict between them, a third author will come and agree on the inclusion of the study. We have extracted the data and we put it in an Excel sheet. And during the process, we have excluded a good number of patients. We initially identified more than 2,000 studies. We ended up with around 41 studies that were included in the meta-analysis. The studies included more than 16,000 solid organ transplant recipients. And most of the studies were on kidney transplant, but we had 6 studies on heart transplant, 2 on liver transplant, and 1 in lung transplant. So more than 16 solid organ recipient, 3 randomized controlled trials, 25 pre and post designs, and some comparative cohorts. And these were the Excel sheets, and you could see how extensive the data has been collected for the 41 study. So what were the results? We had the mean age is around 49.6 to 67 years. That's the range. They were predominantly males, 60 to 80%. And many of them were type 2 and some were post-transplant diabetes. We have assessed the risk of bias by using the Robin1 for non-randomized controlled trials and Robin or Rob2 for randomized controlled trials. And most of the studies actually having at moderate to serious risk, reflecting the observational for the observational study. However, the randomized controlled trials overall had low risk of bias. And this is how we assessed the risk of bias. We put the studies and we look at each criteria, the classification of the intervention, confounding factors, and each point you see whether the study would fulfill it or not. So we did it for all the studies. So what were the results? The primary outcome in our population was the all-cause mortality. And if you look at the all-cause mortality in solid organ transplants in our study was around 48% reduction in all-cause mortality in the SGLT2 group. So quite significant, with a significant p-value 0.001. And this is the forest graph for the primary outcome. If you look at the all-cause mortality, and this is the studies that whether in the kidney or the heart, and you can see the the diamond shape is 0.52 with a confidence interval between 0.34 to 0.81. And that was a quite significant outcome. If you look at the secondary outcomes, which is MACE, major adverse cardiovascular events, whether they are kidney recipients or other solid organ transplant, SGLT2 inhibitors has reduced the major adverse cardiovascular events by 55% in solid organ transplant and 54% in kidney transplant recipients. The blood pressure, when we compared it for all solid organ transplant recipients, there was a significant reduction from before and after the organ transplant, and that was the same as well for solid organ for kidney transplant. And if you can see, the results of the graft and renal outcomes were quite significant. In kidney transplant recipients, the SGLT2, there is a mild decrease in eGFR, while in other solid organ transplants, that was not quite significant. That's figure A and B. If you can see in the first one, where there is liver, kidney, and heart transplant, you can see there is no significant change in eGFR, where there is a mild reduction in patients with kidney transplant. The effect on proteinuria is there is almost 16%, 18% reduction in proteinuria in SGLT2 group. So when we look at the safety outcomes, the safety outcomes using comparative analysis and relative risk reduction, we found that there is no significant association between SGLT2 use and acute kidney injury, and that SGLT2 was associated with possibly increased risk of genital infections, and that is seen in transplant and non-transplant recipients. So our conclusion was that the SGLT2 might offer a clinically relevant benefit in different organ transplant populations. There is evidence that supports cautious use in SGLT2 in solid organ transplant, especially those at risk of cardiovascular disease. And this study actually suggests it can reduce the cardiovascular risk. It can reduce the all-cause mortality with no significant increase in acute kidney injury or other side effects. So we will definitely require more studies, prospective studies, or randomized controlled trials in each solid organ separately to come with a final conclusion. So based on the evidence I presented until now, I think the evidence is in support with what the UAE guidelines have suggested, which has been published around 2 weeks ago, where we suggested that use of SGLT2 and GLP-1 as first-line therapy in this group of population. Metformin can be used as well in this group of patients, but remember that metformin would reduce or would improve graft survival, but it doesn't have cardiovascular benefits or benefits in all-cause mortality, unlike SGLT2 and GLP-1, where the emerging evidence would tell us that it improves graft survival, and at the same time, it actually improves MACE and major kidney outcomes. When you start SGLT2, GLP-1, or metformin as first line, either separately or together, then any further adjustment in glycemic control, you can go for DPP-4 inhibitors. If you're not using a GLP-1, you can go for sulfonylureas, pioglitazone, or insulin, and then you can combine them and add later insulin. Just one last point to mention here, that when we talk about use of GLP-1, SGLT2, and metformin in post-transplant patients, we're talking about patients who had already evidence of stable graft function. In the early month after transplant, insulin is the treatment of post-transplant diabetes. And this has to be clearly mentioned. If 3 to 6 months, or 6 even in some other books, they say 6 to 12 months post-transplant, then we can use oral agents. And with that, I'd like to thank you for listening, and I would like to thank Dr. Amna again for the invitation.
Thank you, Doctor, for an excellent paper which you have presented. I have few questions for you, Dr. Ala, from the audience. Is SGLT2 safe in children? Is there any evidence of its safety?
Until now, there is no evidence there is no enough data to suggest use of SGLT2 in pediatric population. However, if we look at the other class, which is GLP-1, we have evidence that it is safe from age 12 and above.
What do you think about SGLT2 in non-diabetic CKDs?
I think we have enough evidence for use of SGLT2 in non-diabetic CKD. We have strong evidence for IgA nephropathy and other glomerulonephritis. And I think the only part of not diabetic, of CKD that has not been studied is polycystic kidney disease. They have almost always been excluded from studies of SGLT2 inhibitors, given their higher risk of urinary tract infection or the difficulty in eradicating infection if it occurred.
Right. In fact, the next question was about PKD, SGLT2. Right. So there is a comment. Don't you think that the study duration is short for death-censored graft survival and all-cause mortality, considering SGLT2 use in transplant is relatively new?
Yes, actually, the studies this is a meta-analysis that look at different studies for more than 2 to 3 years, the mean duration, 60 something month. So in this, patients post-transplant are at a very high risk of death and graft loss. So if you manage to start this within 6 months, and you see that there is no graft loss compared to those who are not using SGLT2 inhibitors, you already have enough duration and evidence. Especially, we had studies where there is propensity matched group. So a group who are matched with regard to age, ethnicity, duration of diabetes, comorbidities, and everything. So at the end, you see that significant drop. It means it is working and functioning.
Right. Since there is an SGLT2 inhibitor and there is GLP-1, so which one would you prefer as a mode of treatment for post-transplant diabetes?
Well, this usually I think of it based on the patient in front of me. If I had an obese patient, a patient with established atherosclerotic cardiovascular disease, I'd probably, and normal kidney function post-transplant, I'd probably go for GLP-1 first. But if there is any evidence of heart failure or drop in EGFR, I would consider SGLT2 before GLP-1. And in just want to comment that in patients who are not transplant recipients, we might even go for a combination at the same time. But when we look at transplant patients, they're more frail, fragile. So I don't usually start a combination, but I see them in 3 months, then I add the other agent. I always prefer that my patients would be on 2 drugs that provide cardio and renal protection.
Thank you, Dr. Ala. There are many comments of the presentation being excellent and beautiful study. Thank you for being with us for today.
Thank you very much again, and thank you for the invitation. Shukran.
Thank you. Thank you. With this, I'll conclude our first session for the morning, and we'll have a prayer and lunch break, and we'll gather again at around 1 o'clock. Thank you very much for everybody around.
Assalamu alaikum.
Assalamu alaikum.
We can start. Dr. Ahmed, you are ready?
Yeah, I'm ready.
Good afternoon, everyone. Thank you for being with us till now. My name Dr. Fakhriya Al-Alawi. I am a consultant nephrologist in Dubai Hospital. We'll continue our second session for today for this transplant meeting. Thank you that you stayed, everyone, till now with us. Our next speaker is Dr. Ahmed Shaban. Dr. Ahmed Shaban is a consultant nephrologist in Tawam Hospital in Al Ain. He's a professor of internal medicine and nephrology. And today he will speak about interesting and challenging topic, which is transplantation in elderly. Dr. Ahmed, the screen is yours.
Thank you so much, Dr. Fakhriya. Thank you for inviting for such nice meeting. I would like to share with you one of the challenging issue, actually, as we know that the growing patient with age is increasing in dialysis, and many of them, if I would not say most of them, they are very interested in kidney transplant. So I will start by some case scenario that one of the 72-year-old male with end-stage renal disease with diabetes, hypertension, dyslipidemia in hemodialysis for 6 months. And he asked about the possibility of kidney transplantation, and he was asking whether kidney transplantation is better than hemodialysis. Another scenario that 62-year-old diabetic woman on hemodialysis for 4 years, and she complained of occasional chest pain during hemodialysis after cardiac workup. The cardiologist believes that she has asymptomatic cardiovascular disease. What do you think? Which one of the following screening tests for cardiovascular disease is recommended? Is routine measurement of cardiac troponin is enough? Quantification of coronary calcium score, CT coronary angiogram, cardiac MRI, or going for myocardial perfusion scintigraphy. As we know that the elderly patient, one of the major leading cause of morbidity and mortality is cardiovascular disease. In my objective, I will go for a small introduction, then renal transplantation. Older patient, is this better than hemodialysis? How come often I compare it with a younger patient? What about the living donor kidney study in the older patient? What about the readmission mortality, quality of life, and economic factors, frailty, and the protocol for the immunosuppressive medication in older patient, as well for cardiac evaluation, focusing in the elderly patient. So in the USA and other places in the kidney transplantation, there is increasing patient over 65-year-old. Till now, we don't have a clear definition about the elderly patient. Some data they say more than 60, some data more than 65, and other data maybe in the Far East say more than 70 years. And this, they continue to be transplanted in a lower rate than the others. Older patients also are less likely to be listed and to be removed from the waiting list due to multiple factors: strength, selected criteria, decreased interest, as well limited utility of the kidney transplantation. This recent paper speak about the projecting of end-stage kidney disease incidence and the prevalence in the United States. As you can see, the number is increasing in the projected in the next decade. It's from 11 to 18%. So some of the data from the opt-in and SRT are, as you can see, that the patient waiting in the kidney transplantation is increasing in number. And mainly when here, I would like to focus about elderly patient. When you see the patient of 65-year-old, the number is also high and maintained to be the same. And majority of them, they are male patient. Adult patients are willing to accept extended kidney, I can say with low profile, that the elderly patient usually they are willing to accept this kidney comparing to the other patient. What about the mortality for this patient waiting? They are in the waiting list, and the majority of elderly patients, they can have high mortality where they are still in the waiting list. What about if you remove this patient from the waiting list? As you can see, the mortality also will increase in this patient. Some of the new data speak about the first kidney transplant, the first or repeat kidney transplantation. And this is from actually United States renal data when they look to more than 2.5 kidney patient with kidney failure. The elderly patient actually, unfortunately, they have less chance to be repeated or to go for the second kidney transplantation. In general, when you are talking about kidney transplantation in elderly patient, this recent data from Spain when they tried to look to study more than 250 patients, and they classified to 4 groups: less than 60, 60 to 65, 65 to 70, and more than 70. What they found that the mortality on those patients that mainly when they go more than 65, as well the kidney failure and the graft survival is less when you compare it to the patient less than 60. As well, they thought that those patients, they have more surgical complication, mainly in the early surgical complication. Another data from the registry data, when they looked to more than 1,400 patients, as you can see, and they follow up those patients up to 10 years. As you can see here now, the survival was not bad actually. When you looked here, the survival was achieved in 92, 87. So after 10 years, the survival rate was in the range of 64, which actually acceptable. Most of my data actually based on registry data. Now, when we see about renal transplantation, elder patient is better than hemodialysis, is very important, yeah. I will share with you a few of registered data. One of the registry data, when they look to more than 5,000 patients, elderly receiving kidney transplantation, what they found that the graft survival as the patient survival is definitely better than patients who are staying in hemodialysis, as the survival rate is around 60% for living related, better than cadaveric, and better than the patient who are still in the waiting list, and much better for those patients who are not selected for kidney transplantation. You might notice in the early kidney transplantation that the intraoperative or early post-operative, the mortality is higher in the elderly patient comparing to the young patient. Again, here in the same issue, when you compare living donor to deceased donor, even in elderly patient, the graft survival as well, the death sensor graft survival is much better for the living related compared to the hemodialysis. Another data, registered data, when they look to more than 4,500 patients, elderly patient more than 65-year-old, to look for their kidney transplantation in 5 years, comparing to the patient staying in hemodialysis. As you can see, the patient who are in the transplant is much better or significantly better for graft as well patient survival comparing to those patients who remain in the hemodialysis. Again, existing the limit of kidney transplantation, even extremely old donors, if you reach to the donor even more than 80-year-old, and when you compare it to the patient who are still in hemodialysis, they are much better for the graft as well the patient survival. Let me share some of the data if we want to compare this to the younger patient. I know this is unfair to compare a dialysis and the age, but here what we look here, we look to the survival, which unfortunately usually known the patient above 65-year-old, the survival is less when you compare it. But here we compare also for the daily graft dysfunction, we compare it to the early infection as well, we compare it to the rejection rate. So this is the data actually from the Australia and in New Zealand, when they look to a huge number of patients, as you can see, and more than 10,000 patients, and they try to compare. And what they found, actually, they found that the patient who receive living kidney transplant they having up to 5 years better survival than the cadaveric, but the rate of delayed graft dysfunction as well rejection rate was almost comparable by the elderly as well the young patient, and this was actually in the first 5 years. Another data actually, this one single center study, when they looked to more than 270 patients, when they tried to study this patient up to 5 years, observing the survival of the graft as well the delayed graft dysfunction, it was almost comparable between the two groups. What about European data? One of the registry European data, when they looked to more than 145,000 patients, as you can see here in the graph, the number of transplant even is less in the patient, but still it's growing when you compare it to the older day. So what they found here, and let me say in this way, that those patients, the major cause of a graft failure on those patients, actually, it is actually the age, is not the rejection rate or others. So what they found also in the same thing, that the death sensor graft failure, it's actually increased in the patient with elderly patient. So I can summarize from this 3 data that the rejection rate was almost not equal, if not less. Living related is better than the cadaveric. As well, the survival, of course, because of the age is less, and the major cause of graft loss is actually due to the death rather than to the rejection or the others. Yeah. Another systemic review here, this is another European data. I have too many slides, but I'll try to summarize it. Again, here when they look to the survival rate for those patients in the first 3 years, it was unfortunately less in the elderly compared to the young patient. But when they try to go for delay graft function, acute rejection rate, what they found here that the acute rejection, delay graft dysfunction, and the graft loss was almost similar between the two groups. Yeah. Now, when we speak about living donor study in the elderly patient, I know the rate is usually less. Many centers, probably when they have a donor, when they have a recipient more than 70-year-old and the patient have a living donor, most of the time, unfortunately, be denied, for kidney transplantation. Let me share this data from Japan, when they try to compare actually living kidney donor to comparing to non-living kidney donors. As you can see, the number in here, as you can see, is increasing in the last 2 decades from 3.2% to up to 24%. So the number, as you can see, is increasing. So when they looked here to the Kaplan-Meier estimated of death census graft survival comparing elderly to non-elderly who receive living-related cancer transplantation. As you can see, it's not bad. It's good, actually, almost similar. But when you looked for the patient survival, which expected, if you transplant patient about 70-year-old comparing to the patient less than 60 or 50-year-old, the survival, of course, because of the age, will be better for the patient less than 50-year-old. Another interesting data from Korea, actually, from the registry data, when they look to the 5,000 patient kidney transplantation, when they try to compare the living kidney donor comparing to the deceased kidney donor, and they compare it to 4 groups. For the living kidney donor, more than 3,000 patients, comparing to 2,000 patients in the deceased kidney donor, and they compare it elderly versus young and elderly versus young. So what I can summary here, that the survival definitely was better in the elderly living related comparing to the cadaveric patient, but not for the young patient, and this because of the age. But when they look to the early delayed graft dysfunction or rejection rate was almost similar between the young as well the elderly. Now, one of the major issues we can face actually with the patient with the kidney transplantation is the readmission and the mortality as well quality of life. So I'll go one by one. So what about the readmission? Readmission, one of the registry data when they looked here to more than 22,000 patient kidney transplantation, and they tried to look to the early admission or frequent admission. So what they found that the early admission and frequent admission was more common in the elderly patient comparing to the young patient. And when they focus mainly in the early admission, the main cause of this patient was fall with a fracture. And what they noticed in this patient that the graft failure was higher in elderly comparing to the young patient. And again, when you look here to the odds of early hospital readmission after kidney transplantation, it is more in the elderly comparing to the young patient. This speaks that this patient, when before they go to the kidney transplantation, they have to be properly prepared and to reduce the morbidity. When we look to the causes of mortality, actually, mainly in the first year or the 2 years post-kidney transplantation, this data from Italy, they found infection rate usually as the major cause of death in this patient, followed by tumor, cardiovascular disease in the range of 14%, CVA 7%, and unknown 14%. And they speak about also about the proper preparation for this patient before they go for kidney transplantation. What about the quality of life? Definitely the quality of life is improving actually post-kidney transplantation. And this is the data, when they look to around 30 patient kidney transplantation, and they try to focus in 6 themes here to identify how they can measure the quality of life for restoring vitality of youth and persisting through prolonged recovery to boosting sickness. You can see prioritizing graft survival, which can lead at the end to improving the value of kidney transplantation. So definitely the quality of life will be much better when you transplant elderly patient. What about the economic factor or the cost? This is a very important point. This is also a difficult issue how to measure the cost for any patient, But here in this study, actually, they tried to compare it. They found kidney transplantation elderly patient is more cost effective when you compare it to the patient who remain on dialysis. But what they found that if you have a transplant patient more than 70, you are losing this benefit of the cost effective because probably from the readmission and the other complication would happen. And those patients who remain actually in the wait list for more than 2 years, I mean, again, you lost the benefit of the cost effective. But in general, I can say that those patients who are eligible for kidney transplantation, the elderly, they benefit from transplantation comparing to the dialysis. What about the fertility and mortality in kidney transplantation? This is another major issue. I mean, before taking patient with more than 17-year-old, you have to look to the fertility in this patient. In this data, they looked to more than 537 patients, and before transplantation, they tried to measure the fertility score, as you can see. So the majority, I can say, up to 30%. What they found? They found those patients with higher fertility, the mortality high. And this speak very important that to prepare or to have a proper selection for your patient. But I can say probably proper preparation for this patient before they go for kidney transplantation to improve the fertility, as the fertility is related to the degree of mortality. One of the major surgery, it's not related to the kidney transplantation. This study, when they looked to more than 7,000 patients who are going for major surgery, abdominal surgery, and they try to improve the fertility of the patient, and the outcome was actually good. I mean, unfortunately, we don't have similar data. I'm not aware about it in the kidney transplantation. What about infection after kidney transplantation? As I mentioned, that it's a matter. Yeah, it's matter. So this one of the data, one of the study. I mean, when they try to compare older patient more than 65-year-old comparing to the patient less than 60 year, and try to find what's the most common infection can happen, and mainly in the first 6 kidney transplantation. They found that UTI, it is as well CMV is high on those patients comparing to the other patient. But when they look to the other parameter like pneumonia or sepsis or C difficult or others, they are comparable between the two groups. What about the post-kidney transplant lymphoproliferative disorder, which is actually a major issue? It's actually from this registry data, which was taken in more than 25,000 patients. They found that the tumor is higher than compared to the adult. And this is because probably the selection of those patients, they got to go highly sensitized patient, those patients that survive more when you compare it to the patient with elderly patients. But elderly patients, when they develop malignancy, usually the mortality is really, and well, the graft failure is high. So this is in general, I mean, when they looked here, to the relation that definitely for those patients who survive the post-kidney transplant for a longer period, they might have more tumor for this patient, comparing mismatch, comparing to the matching people. Patient with EBV negative, they are higher. Patient with develop rejection, and definite, because this is because they receive immunosuppressive medication, they are high risk for malignancy, What about the immunosuppressive medication? This is another major issue and very important issue, actually, that we cannot, probably apply the same protocol for immunosuppressive medication for elderly comparing to the young patient. So I can summary here from one of the registry data, comparing elderly to the young patient, that elderly patient, that the induction therapy in most of the data that show that IL-2 receptor, IL-2 induction and triple immunotherapy like CNI, tacrolimus, steroid, MF, and they found those patients without steroid they have much better in the form of less fracture as well, less tumors. And they've noticed also this patient who receive mTOR inhibitor, they have higher mortality as well, graft failure, as well the cyclosporin, and heavy induction with rituximab or ATG also, it is associated with higher mortality in those groups. So let me speak about the cardiac evaluation in the last few minutes. So this is very important that one of the major limitation or restriction for elderly patient going for kidney transplantation is the cardiac evaluation. I still remember in the more than 2 decades, we are so strict for this patient that before they go transplant, they have to have a strict cardiac clearance. But recently now we have too many data, looking, for example, if you have a patient with they look to he's going for kidney transplantation, and the patient is asymptomatic of coronary heart disease, even is at high risk patient. And in this study, they try to compare echo, comparing to stress test, to nuclear, and to comparing to the coronary angiogram. And when they try to look to the 5-year survival, as you can see, the 5-year survival was similar for those patients who underwent, a screening versus an invasive screening. Again, this is one of the data published maybe more than 10 years ago when they tried to manage patients with coronary heart disease with advanced chronic kidney disease, whether conservative or invasive strategy, the outcome up to 10 years was almost similar between the two groups. If you focus on the KDIGO guidelines, usually the decision will be left for the cardiology, but how strict you have to this patient. If the patient is asymptomatic, maybe just routine, test can be go the patient. If the patient high risk, that's still the nuclear scan, and they have to be in by cardiac cath. And as I mentioned, that is not so strict like in the past, but you have to identify the patient who are at high risk comparing non-high risk. What about the guidelines, about kidney transplantation in elderly patient? This is few guidelines from the KDIGO guidelines, as with the Canadian guidelines, as with the European guidelines. How can I summarize all these guidelines about kidney transplantation? I can say one thing that consider age and other comorbidity, including frailty, and my impact on the decline. But in general, we recommend that age is not a contraindication for kidney transplantation. This is, that's not to be strict against those patients for going kidney transplantation. Yeah. So my conclusion, although the geriatric population increase, we will see an increase in the number of eligible for kidney patient for renal transplantation. Older patients can benefit from transplant compared with dialysis outcome. Older patients have decreased over patient survival due to their age. Approach to immunosuppressive medication, older patient need to be modified. Special program that transplantation in older patient is high rate is needed. We must continue to improve our care for older patients with end-stage renal disease against preventing kidney transplantation, and definitely we need further study in the future to improve the outcome of this patient. And this is actually most of my data based in the registry data. And thank you so much for your attention and for any comment or question. Thank you.
Thank you, Dr. Ahmed. Thank you a lot for the nice presentation. You had almost covered everything related to transplantation in elderly, started from their disease and ending by malignancy and medication and cardiovascular risk. Thank you for that. I will just see if there is any questions about it. There is one question. Do you support any reduction in the immune suppressive medication for elderly transplant patient?
Yeah, definitely. As I mentioned, and from the registry data, that they need special protocol in the elderly patient. Since the infection rate is usually high and the leading cause of death in the elderly patient, we need to modify it. From the registry data, what they suggest that in the induction, you can use IL-2 receptor induction, try to avoid like the big gun, like when I say thymoglobin or amitsumab, and the maintenance CNI with low dose MMF, and in some data, as I mentioned there, that that steroid withdrawal has great impact actually in the survival malignancy as well for the fractures. And what they know, it's also from the registry data that those patients who receive mTOR inhibitor or cyclosporin, the graft as well the patient survival was less. Definitely we need a special protocol, and I'm sure too many centers, they are following the special protocol for elderly patients. Yeah, thank you.
Thank you, Dr. Ahmed. There is another question. You just spoke about fracture risk, but And the question, is there any prophylaxis recommendation for osteoporosis and fracture risk? Anything you recommend for those patients?
Well, definitely, actually, this will start when the patient are still in the waiting list or they are in dialysis. You have to try to move all the comorbidity regarding calcium, phosphorus, PTH. This is very important before transplantation. After a transplantation, definitely this patient, they would require actually calcium as well, vitamin D. And as we go by the KDIGO guidelines to do the PMD, the dual bone screening. I might not say annually, but they need special attention. Yeah, this is a very important point. And as I mentioned before, early admission is mainly in the elderly patient. It has been noticed in the registry data is fall related to this associated with the fracture, which actually can associated with the graft failure as well, patient survival. Yeah, definitely. Yeah.
Thank you, Dr. Ahmed. Thank you a lot. We'll move to our second topic. Our second talk is clinical cases. It will be presented by Dr. Ramzi Abu Ayyash. Dr. Ramzi is a consultant nephrologist and head of department in the Mediclinic City Hospital in Dubai. And he is an associate professor in MBRU in Mohammed bin Rashid University. And the second speaker for the same session will be Dr. Rishab. Dr. Rishab, he is our transplant physician colleague in Dubai Hospital. He is American board certified transplant physician. Both will be talking about nice, interesting cases. We'll start with Dr. Ramzi. Dr. Ramzi, the screen is yours.
Thank you, Dr. Fahriya. Good afternoon, everyone. I'm trying to share my screen. Can you see it?
Yes, Dr. Ramzi.
Excellent. Okay, so short case, a classic case, but rare case. So that's why I decided to talk about this this patient. So this is a young Italian man. He's 43, and he had a history of IgA nephropathy. Biopsy proven in 2003, and was dialyzed in 2016 for 1 year before receiving a kidney transplant from his mother in 2017. Sorry, just to reduce this. Yeah. Status CMV, EBV D plus R plus, and classic immunosuppression, the anti-CD25, calcineurin inhibitors, mycophenolate, prednisolone. So this is a bit the timeline. So as I told you in 2017, living-related kidney transplant, a good match, basiliximab, mycophenolate, tacrolimus steroids. He had the early CMV reactivation, treated without problem with valsite. And in May 2018, his creatinine was going up slowly to 190 for the nadir of 120 initially. So I did the kidney biopsy for him that showed like kind of mild fibrosis and some vascular toxicity of the CNI. And then I changed the regimen for so I stopped mycophenolate for everolimus, combination with low-dose tacrolimus and steroids. And this was quite helpful because his creatinine went down from 190, the average, to 140, and stable for many years, till now, by the way. In December 23, after a short trip to Romania, he came to see me because he was feeling very tired, had palpitation, and some intolerance to effort. And on the lab test, everything was stable except the hemoglobin. It was 5.5. The baseline for him is like 14. So of course, the initial so it's a symptomatic anemia. We admitted him. We received 2 irradiated PRBCs, and then the initial workup, to rule out hemolysis, GI bleed, any reactivation of the viruses. His erythropoietin was very high with a very low reticulocyte. We discussed with the hematologist who did the bone marrow aspiration and biopsy, and this came back for a severe erythroid hypoplasia actually pure red cell aplastic anemia. And the flow cytometry did show any aberrant T cell, B cell, or any increase of myeloid precursors. So this was the initial workup, and the question, what other tests should we do for this patient? I will continue, so we'll not discuss this now. So finally, we have the result of the parvovirus B19 that came back positive for IgM, negative for IgG, and a positive PCR. This was like a few days after his admission. We did repeat the transfusion with the irradiated blood cells, and I changed his regimen since we have this PRCA, the pure cell anemia, aplastic anemia. I stopped everolimus and I changed tacrolimus to cyclosporine. So sorry, I stopped the everolimus without. We kept it only on CNI and steroids. Since there is cases of PRCA under tacrolimus, everolimus, and mycophenolate. This was not didn't change really his anemia, and he actually in February again he was admitted for more red cell PRBCs transfusion. And we checked again, the parvovirus B19 was still positive IgM, and the PCR was still high. So this is after even like 1 month or a little bit more, 6 weeks of the change of immunosuppression. Anyone has another opinion about the immunosuppression? Or maybe we'll talk about it later. So we admitted the patient, of course, for IVIG. We gave him the usual recommended dose is 2 grams per kilo. And I will show you the follow-up later on. Just to quick information regarding the pure red cell anemia. Actually, I find out that there's a lot of cases, causes, I mean, of pure red cell anemia. Autoimmune disease, tumors, mainly thymoma, viral infection, of course, the parvovirus B19 and other viruses, lymphoproliferative disorders, some stem cell transplant, idiopathic also drugs, mycophenolate, erythropoietin, or Ethiopia, I think it's well known, like 20 years back, I think it was like recognized as found out that we have antibodies against erythropoietin. And other treatment, even INH, azathioprine, and even tacrolimus. That is a long list, actually. And the congenital one, what we call hereditary pure red cell aplasia. So parvovirus is a very common cause of pure red cell anemia, but it's very rare, actually, situations. Here in Dubai is the first time I have this case. So parvovirus is the smallest DNA virus. It's spread by respiratory droplets, and it was discovered in 1975 by an Australian virologist. She found out this particles and the serum number 19 of panel B. So that's why they called it parvovirus B19. In post-transplant, the data we have at 1 year, approximately 10% of kidney transplant can have measurable parvovirus B19, but very rarely actually it's symptomatic. That's why sometimes it's underdiagnosed. Usually it's what we call initial, before that's a fifth disease. In children, it's responsible of like the skin rash, and we call this slapped cheek rash. And some arthritis, aplastic crisis, of course, and hydrocephalus with an infection in pregnant women, which is a very life-threatening situation where there's a risk of 40 to 50% of death of the fetus. So for the bone marrow, why we have this anemia? Actually, this parvovirus B19 infect the pro-erythroblast, and this infection make this swelling of the, let's say, the pro-erythroblast becoming giant one, and these giant pro-erythroblasts cannot progress to erythrocyte or reticulocyte. And at some point they are broken, destroyed, and there's like apoptosis. And then the virus is released, and again, it's another cycle of reinfection, and that's how patients have sometimes chronic B19 infection. And on the blood, we can see this, that these giant proerythroblasts on with the arrow. So the treatment, there is no specific treatment actually for parvo B19. In healthy patients or people, there's no specific treatment. In immunocompromised patients, there's different suggestions. So either we give IVIG only, or in kidney transplant patient, I mean, or IVIG with change of immunosuppression, or just reduction of immunosuppression. So this actually was suggested in this big series of 128 patients. And for the IVIG, we don't have a specific protocol, but most of the studies centered they use approximately a dose of 2 grams per kilo, either split in different doses or in different several days, or in a couple of days, 1 or 2 days, approximately 2 grams per kilogram. And the efficacy is quite good. We can see that the patients recover approximately after 3 weeks from the IVIG. Most of them, by the way, but actually there is a risk of relapse. Approximately 34% may have a recurrence of pure red cell anemia after transplant. And the mean period for relapse is 4 months approximately. There's different cause for these relapse listed here, like a failure to eradicate the virus initially, or the IVIG not effective enough, or the fact we reintroduce the immunosuppression as before. And that's require again another treatment with IVIG. The other option is foscarnet. Foscarnet showed the interesting benefit in parvo B19 PRCA. In this series of 68 patients with B19 PRCA, 11 received foscarnet, 10 responded completely, only 1 didn't respond to foscarnet, which is a quite interesting result in case IVIG is not working. So back to our patient. This patient actually corrected his hemoglobin 2 months after the first 1 shot of IVIG at 2 grams. So in April 2024, and the last follow-up this year, his hemoglobin is still stable, and we are back now to a regular immunosuppression, combining tacrolimus, mycophenolate, and steroids. That's all. Thank you.
Thank you, Dr. Ramzi. Thank you a lot. It is really a nice case. We had similar case maybe around 7 or 8 years back. And at that time, it was really challenging to diagnose because the reported cases of parvovirus at that time, it was not like now. It was very few, but it is really a very nice case. Just before going to Dr. Rishab's case, there is one question from the audience that do you want or do you have to rule out bone marrow suppression because of mycophenolate before thinking of viruses?
So yes, I mean, this is discussion with the hematologist, but this actually, all the other cells were completely normal. So it's like a really pure lack of precursor of the erythrocytes. The reticulocyte count were extremely low, and all the other, the platelets and the white cell count were normal. So of course, I mean, we always discuss this with the hematologist, and this is discussion and decision to do the bone marrow is based on the opinion of the hematologist. But I think it's worth to do it because to confirm the diagnosis and to rule out other causes, potential causes. As I said, I showed the main common causes of PRCA, but there's a very long list actually. I was surprised to see this, and yes, of course. But the fact that we received this serology of B19 IgM positive.
Yes, exactly. Yeah, this is more diagnostic.
It was orienting the diagnosis. The PCR takes long time. I mean, long time. We don't have it immediately. So, but the fact that IgM was positive, that was very very consistent
Mhm.
with parvovirus B19 PRCA, yes.
Yes, thank you. Dr. Rishab, any comment about Dr. Ramzi case before
So,
talking
Yeah,
about
Dr.
any-
Ramsey, so parvovirus B19 is, if you have aplastic anemia in transplantation, parvovirus B19 should always be checked. I mean, before even jumping to a bone marrow, you checked out of all the viruses, but pure aplastic anemia with nothing in the platelets and nothing in the white cells, parvovirus is a reflex test that should be done.
So thank you. Yeah, I say that actually is a good point. Actually, the bone marrow was done with the result we had for parvovirus B19 IgM positive. We didn't have the PCR. The serology was there. We had it. But again, as discussed with the hematologist, he felt that there is potential need to do it. It can be debated, should we do it or not? But the serology was already known for this patient. But finally, it was done, and so that's confirmed finally the diagnosis. Yes.
Thank you, Dr. Ramzi. Now we'll go to Dr. Rishab case. Would Dr. Ramzi stay with us since it is interactive discussion? If you have any comment later about Dr. Rishab case, Dr. Rishab, please, the screen is yours.
Thank you, Dr. Fakhriya. Can you see my slides?
Yes, yes.
Yes. Okay. So myself, Dr. Rishabh, I'm one of the consultant transplant nephrologists in Dubai Hospital. So I have an interesting case which I've labeled as cholestatic conundrum. So this is a 20-year-old Yemeni patient who migrated to Dubai with his father in 2018. He was diagnosed with end-stage renal disease secondary to nephrolithiasis, NPHP1 mutation, and was on peritoneal dialysis when he migrated to Dubai. He was being followed in Jalila, and 4 years after his migration, he got lucky and was transplanted with a diseased donor kidney on the 10th of June 2022 at Jalila. Though he had a DSA, his final cross-match was negative, was induced by thymoglobulin, and then maintained on triple drug immunosuppression. Now, he had some delayed graft function immediately following the transplant. The kidney was transplanted with 2 arteries, so a vascular thrombosis episode was ruled out. The initial Doppler showed poor perfusion, but as per chart review, seems like it improved later on. The diagnosis was believed to be ATN. The patient required hemodialysis support for roughly 10 to 12 days. During that time too, he had some pruritus, which was suspected to be drug allergy. As per chart review, they thought it was tacrolimus or Septrin. Septrin was discontinued, switched to pentamidine for PCP prophylaxis, and the patient's symptoms improved. With regards to the kidney, he got biopsied when his DSA titer started to rise up a month later, possibly memory response. And on the biopsy, he had mixed rejection. He was treated with an intensive treatment protocol involving pulse steroids, IVIG. He was plasmapheresed, given bortezomib and rituximab, and the graft function seems to have stabilized after that. So this is what followed in the next 2 years after his transplantation. So as you can see, he was having monthly DSA surveillances done, and the DQ MFI remained about 7 to 14,000. He had 2 biopsies following this, and both the biopsies showed no rejection with some progressive IFTA. However, his creatinine, as you can see on the slide, improved after he got the transplant, had a little peak during the rejection episode, but then stabilized. Now, some of the other significant history that happened to him was in May 2023, he was admitted with severe itching with massive scratch marks all over his body, believed to be secondary to amoxicillin, which was stopped. At that time, he was in his labs noted to have severe direct hyperbilirubinemia. GI was consulted. They put him on cholestyramine, calamine, and antihistamine. His tacrolimus trough levels were high, so they were reduced, and the patient's inpatient status actually improved. His hyperbilirubinemia resolved, and he was discharged home. Now, another episode like this happened again in June 2024. This time, he had some upper abdominal pain along with the direct hyperbilirubinemia. An ultrasound was done, which showed an obstructive calculus, which was promptly dealt with. He had an ERCP done on 5/6/24 with a sphincterotomy and sludge extraction, and then that was followed by laparoscopic cholecystectomy. The patient's hyperbilirubinemia improved, his symptoms resolved, and he was discharged home. So this is the time when the patient was transitioned to our adult clinic in Dubai Hospital. So my first interaction with him was in October 2024, where his graft function remained stable and he was doing well. We arranged for him to be followed up with us once his charity approval was done. Now, he continued to follow with us, was doing okay on all fronts. Then he comes in May 2025 to the clinic, and that's the interesting presentation that I'd like to discuss today. So the kid comes in with generalized itching all over his body. He says he ate a Fresno sandwich and then started this severe itching all over his body to the point where he was excoriating his skin. He had some mild diarrhea, mild fever, but didn't record any temperature at home. Denied that he had started any new medication and had no drug exposure. He said that the itching was as severe as his previous episodes, so he was referred for an admission under our service for further workup. So his labs at the time of admission revealed a stable creatinine, stable electrolytes. His liver function was actually normal, except the alkaline phosphatase, which was high, which had been persistently high for him. Improved a little bit after the transplant, but he'd been running in the 300 to 500 range. Viral serologies were all negative, but he had direct bilirubinemia. His total bilirubin was 3 and direct bilirubin was 2.78. Hemoglobin remained okay. The tacrolimus was had a very fluctuant course. At the time of admission, it was 9.2. His hemoglobin A1C was 4.7. His PTH was 43. His urine analysis revealed a little bit of bilirubin and +1 protein. His UPCR was 136 milligram per gram. So we went ahead, and this is actually what his bilirubin and his tacrolimus levels are. So as you can see, the first spike that happened in 2023 was immediately following his transplant. This was believed to be related to the tacrolimus, and then the dose was reduced and he got better. He had a second spike, which apparently got better on its own. Then the third spike that he had is when he lost his gallbladder. And this fourth spike that you see is when he was admitted with us for workup of this hyperbilirubinemia. As I mentioned to you, most of these spikes came when the tacrolimus level was on the higher side. So tacrolimus was reduced and he symptomatically got better. Even now, he was admitted with a tacrolimus level of 9, which was promptly reduced. However, his bilirubin continued to go up. So these are some of the media images that I have. This was secondary to severe excoriation, and he kept scratching himself, and he had scratched all over his body. So you can imagine how bad this itching for this kid was. Now, we did a repeat imaging for him. So his ultrasound abdomen showed some mild hepatomegaly, but there was no dilation of the intrahepatic biliary radicals, mild splenomegaly, and remember that he had a gallbladder removed. So his current medications included a tacrolimus of 3 milligrams in the morning and 4 milligrams in the evening, a mycophenolate 500 twice daily, prednisone 5, allopurinol 100, and levothyroxine. So we decided to admit the kid, like I spoke, and antihistamine was added. He was given topical calamine lotion overnight. We thought maybe this is a drug allergy of some sort, so the allopurinol was discontinued, and we adjusted his tacrolimus to achieve a lower trough level. So the question is, where do we go from here? So a few of the thoughts that we had when we were discussing this case was to get a dermatology consult. It's very rare to get graft versus host disease in renal transplant cases, but it does happen. So we thought maybe we should get dermatology on board, get a skin biopsy. Now, the kid has had allergy to a lot of medications. So he's had allergy to sulfur medications. He's had allergy to amoxicillin. So we thought of getting allergy immunology on board. Maybe this is something, allergy that's causing this. We decided to get GI back on board, maybe do an MRCP, consider a liver biopsy, because he keeps having this hyperbilirubinic episodes. We also discussed whether we should take him off CNIs and put him on an mTOR-based regime. But with the DSA burden, that was questionable. And the last thing we, after literature research, thought maybe we should switch his tacrolimus to cyclosporin and see what happens. Now, we got the dermatology consult. They ended up doing a skin biopsy, and luckily there was no evidence of graft versus host disease, because this is pretty bad if it happens, difficult to treat, and poor prognosis. So this is the surgical pathology report from the derm biopsy, just showed pustular folliculitis. and then showed epidermal parakeratotic scaling, but luckily no graft versus host disease. We got an allergy and immunology consult done. The IgE levels remained high. They did a dust mite allergy, which was confirmed. And they started him on SLIT therapy, which is sublingual immunotherapy, and they gave him antihistamine. We got gastroenterology involved as well to see what we could do about this hyperbilirubinemia. So besides the ursodeoxycholic acid, gastroenterology recommended that we check a genetic panel and actually suggested that the patient undergo a liver biopsy and an MRI, both of which the father refused to do. So we looked up literature, and tacrolimus has this cholestatic component to it. And I found a few papers where it's been mentioned that this is actually a very rare episode that happens. But in literature, it's mentioned numerous times with multiple case reports reporting that high tacrolimus level can actually induce severe cholestasis. Now, what is the mechanism for this? So there is some literature in rats which seems to suggest that it inhibits glutathione, and that's primarily the reason how it causes cholestasis. And to a lesser extent, it also inhibits bicarbonate. And this is the mechanism of how tacrolimus can induce severe cholestasis. So we had a multidisciplinary discussion with the GI team and with allergy immunology team. And after extensive literature review, reading through these case reports, we decided to switch him from tacrolimus to cyclosporin, which is what most of the literature was suggestive of. And we found good success. So as you can see that the bilirubin, after we made the switch from tacrolimus to cyclosporin, rapidly dropped. And his itching improved and the excoriation marks on his skin resolved when he followed up in clinic. Now, what threw us off was that the custom gene panel that was sent out on request of the gastroenterologist actually came back positive for UPS 53 gene mutation, which was homozygous and was likely pathogenic. And this causes cholestasis, a familial intrahepatic form of cholestasis, which I was not aware of. So I thought this is something that we should share with all our fellow nephrologists to be aware of. And it's an autosomal recessive disease due to mutation in this USP53 gene. Now, we are all aware of NPHP1 mutation. So we know that this is homozygous deletion of NPHP1, and this is present on chromosome 2, and it causes juvenile nephrophthisis. It's an autosomal recessive ciliopathy, and it causes end-stage kidney disease by the age 13 to 15, which is exactly what happened to our patient. Sometimes can be associated with retinitis pigmentosa, or can have some neurological issues, and the name of the syndrome essentially changes if it's associated with any one of these factors. The symptoms are early polyuria and polydipsia, and unfortunately, there is no direct treatment that exists. So these kids ultimately end up with renal failure, and transplant often works pretty well with them. This progressive familial intrahepatic cholestasis 7 is a rare autosomal recessive disease that is caused by mutation in this USP53 gene present on chromosome 4. It manifests usually in infancy with cholestasis, severe itching, jaundice, and a normal GGT level, though has mild elevated AST and ALT levels. In our case, actually, this kid had no presentation like this before he got the transplant. So somehow something in the transplant triggered him to start having these repeated episodes. One of which we thought was medication induced, but this genetic panel showing that he is homozygous mutation for this, we believe there may be an underlying factor involved here. So the good part is that some of the patients seem to show resolution with age, but our kid so far has had no such respite from this. Keeps having episodes after one after the other. Now, I tried to find a unifying diagnosis, and in my literature research, I found that there is progressive familial intrahepatic cholestasis 13, which actually has both liver and renal involvement, because this familial intrahepatic cholestasis 7 doesn't have a renal involvement, and NHP1 mutation doesn't have a liver involvement. So the only PFIC 13 has both liver and renal disease, but this young kid doesn't have this mutation. Sorry, my slides are stuck. Right. So basically, I wanted to highlight this case because it is a rare case where, unfortunately, the kid ended up with two distinct rare autosomal recessive diseases present in one patient. I think that this is a second hit phenomena. So he had a genetic predisposition, and somehow the transplant or the medications of the transplant had precipitated this cholestasis. So my suggestion is always keep an open mind and look for red herrings sometimes, because the answers are not always easy or straightforward. Thank you.
Thank you, Dr. Rishabh. Thank you. It's really a challenging case, yes. Dr. Ramzi, do you have any comment about this case?
Well, very nice case, Dr. Rishabh. Yeah, it's good that you shared this with us, because, as you said, it's very rare. So I never had this before, but I'll be more open-minded, as you said.
Right.
Request for genetic testing.
Yeah, I've never experienced that. And actually, the discussion we had with the GI team was they were surprised that this was not sought after during the first time when he had this picture on the pediatric side. So that was the thing. So I was not aware of this disease. I'm sure a lot of us are not aware that tacrolimus can actually cause cholestatic picture. That was new to me. And then the other thing was that when I switched into cyclosporin, actually, if you read literature, even cyclosporin can precipitate this at high levels. So it's not an easy answer. I hope the kid does okay, but I don't know what the next step would be, especially with his DSA burden. An mTOR is not going to be an effective therapy for him. So if he keeps having these recurrent episodes, I'm not sure what the next best option from a nephrology standpoint would be.
Yeah, it would be interesting to see the teams with liver transplant, if they have this kind of problem, to maybe it's more encountered in liver transplant. I don't know, in the literature, maybe to have a look on this.
Yeah.
Dr. Rishabh, there is one question. Since you are saying it is autosomal recessive, the parents...
Consanguineous marriage.
Yes. Okay, fine. But we didn't do any genetic testing for them, isn't it?
No, not for the parents that I'm aware of. So the only two genetic testing is one for the kid which showed the NHP1 mutation, and then this is the second genetic testing that was done by GI, and it showed this cholestatic mutation as well.
Sure. Thank you. Thank you, Dr. Ramzi. Thank you, Dr. Rishabh. Really very nice, interesting cases. I hope, as you said, we should be open-minded for all differential diagnoses, especially in transplant recipients. Thank you a lot. Thank you.
Thank you, Dr. Fakria.
Thank you. Now we'll go for our next speaker. Next speaker is Dr. Wissam. Dr. Wissam, I think she is a well-known figure in histopathology and kidney transplantation histopathology. She is always with us, and thank you for that, Dr. Wissam. She is a well-known figure as I mentioned, in the histopathology of kidney disease, and she is assistant professor of pathology and the director of histopathology lab in Ben Suef University Hospital in Egypt. Dr. Wissam will share some of her experience in nice clinical pathological cases. Dr. Wissam, the screen is yours.
Dr. Wissam is just connecting to the audio, so it just take 1 minute.
Sure, we'll wait.
Assalamu alaikum.
Alaikum salam, Dr. Wissam.
Hey, I'm sorry, I had some internet glitch. Okay, can I share my slides?
Yes, please.
Yes, please.
Can you see the slides now?
Yes, we can.
All right. First of all, I would like to thank you for the chance to participate, as every year in this growing very successful meeting. Second, I know this session should have been a joint session between me and Dr. Amna Al-Hadri, but due to some miscommunication from my side, actually, so I'm going to present it alone today. Okay, I will basically present a couple of cases, and through these cases, I will try to discuss the latest BANF report or the latest BANF recommendations as per the clinical scenarios. I first want to say that the latest BANF report is actually not a new classification. There was nothing added. We just had, it's more or less a clarification of what was reported before for all legions. And this is what I'm hoping that we can establish today with the cases. So the first case was a female transplant patient who presented on day plus 15 by serum creatinine of 2.36 milligram percent and protein creat ratio of 1.2. Her original disease was lupus. Her operation was actually uneventful. Her post-operative course, however, got complicated because after her creatinine landed to 0.9, on day plus 12, her serum creatinine started to increase to 1.9 with initial thrombocytopenia and increased D-dimer. So patient received pulse steroids and creatinine levels improved as well as the hemolytic profile. However, 2 days later, her serum creatinine started to rise again, reaching to 2.29 milligram percent, so a biopsy was obtained. Now, this is her biopsy. I started with the glomeruli. Now, this is a lupus patient with her hemolytic profile. There was a large concern from the transplant patients. She could be rejecting. She could have a recurrence. Although we know that lupus usually is not a disease with a high rate of recurrence. However, it was still a concern. So you see, this was her glomeruli, and the patient has what we call evident glomerulitis. And as you see here with the arrow, and glomerulitis is basically inflammatory cells with endothelial cell injury as well. We can see it as swelling. And on the other side, you can see also with the arrows, actually her glomeruli were full of inflammatory cells. Now, this was a major issue in the latest month, that we needed to standardize reports for glomerular disease, especially if we want to really be able to distinguish whether what we're seeing in the glomeruli was rejection versus non-rejection glomerular injury. And why? Because immunosuppression would modify disease morphology, and recurrent diseases post-transplant actually presents with different features than in the native kidney. So in the last meeting, or the latest updates, was that the meeting developed the first specific guidance for reporting on these diseases to try to address these challenges. And the report was that we pathologists should apply native kidney principles, so we diagnose under standard definitions. However, we don't know whether the validity of the scoring systems, example for lupus nephritis as our case, whether they will be valid and we can establish them for the transplant kidneys or not. We should use ancillary investigations like immuno and electron microscopy. And we need to attribute the G scores, as we're seeing here in this patient. This is the G score with caution, because if we have a recurrent GN, then this could explain the glomerulitis. And as you are aware, that lupus, and within lupus activity, what is actually glomerulitis, or the glomerular inflammation with the presence of neutrophils, is also one of the activity indices and a sign of inflammation. So we had the differential diagnosis of whether a very early recurrence of lupus activity or whether this is an antibody-mediated rejection. This was actually straightforward to exclude because we already performed immuno for the patient, and the patient had an EM. And as you can see, her immuno was negative for immunoglobulins. and her electron microscopy showed no deposits. So we were not dealing definitely with recurrence, although it was a weak possibility. Again, I stress because of the very early post-transplant period. So we go back to the transplant biopsy. What was there other than the glomerulitis that we've seen? Now look at her arteries, and this is what we call a V lesion or rejection of the arteries. And as you can see again with the black arrows, these are all lymphocytes beneath the endothelium. But the patient did not have any tubulointerstitial inflammation. So we have now a biopsy with no tubulitis, no inflammatory cells, but a V lesion, which is basically or always have been attributed to T-cell mediated rejection. We have MVI, which is a G-score of 2, a peritubular capillaritis score of 1, and her C4D was positive, C4D 2. So how would you like to diagnose this patient? Whether this is a pure active antibody-mediated rejection or a mixed acute active rejection with T-cell mediated rejection, antibody-mediated rejection. Because in BAMF 2019, the V lesions have been included under the antibody-mediated rejection, this have created a lot of debate and confusion among the transplant society together between pathologists and nephrologists, and whether these V lesions how they should be interpreted and to which category should this transplant biopsy relate to. So in 2022, as I mentioned, the latest report was basically affirmative of the lesions and to try to explain these lesions into clinical phenotypes. So when we have V lesions present, the recommendation is to go back to the antibody-mediated rejection MVI flow chart and evaluate tubulitis and whether we have tubular inflammation or interstitial lesions or not. Any diagnosis, if we have any diagnosis of antibody-mediated rejection or MVI phenotypes reached, whether it is TSA negative or C4D negative, so it's a probable ABMR, then we're going to classify this as a mixed rejection. It's an antibody-mediated rejection MVI diagnosis plus T-cell mediated rejection grade 2. If we have a tubular interstitial inflammation, which meets the threshold for a T-cell mediated rejection, then and we don't have any evidence of antibody-mediated rejection, then this is a pure T-cell mediated rejection. What if we don't have a diagnosis of MVI and we don't have any tubular interstitial inflammation, or it just meets a borderline? How should we interpret this V lesion? The recommendation is that we interpret this V lesion again as an active T-cell mediated rejection process. And this is actually very important because as I mentioned, we have been in a lot of debate because of this. And V lesions are mainly lesions defining for a T-cell mediated rejection process. So it was very good that it was really clarified within the latest report. And the reason why we don't have tubular interstitial inflammation is mainly attributed to the patients receive anti-rejection treatment, which easily any pulse steroids can get rid of the inflammation noted within the tubules and in the interstitium. However, the arterial or the vascular lesions are more resistant, and so they require, and so they persist within the biopsies. And of course, as I mentioned, diagnoses can coincide. And so this was one of the major things. This was a gray area and the mixed phenotypes and the V lesion, and the recommendation that when we have both criteria which are met, like our patient, which has a microvascular inflammation, her C4D is positive, and we have already excluded any form of lupus recurrence, and she has a frank V2 lesion, then the diagnosis is mixed active rejection. This is an acute T-cell mediated rejection, BAMF type 2B, arterial, associated with microvascular inflammation, C4D positive, which would be consistent with active antibody-mediated rejection. My next case was a male patient who was 24 years old. He received a living-related renal transplant with initial delayed graft function. They attributed it at the time for a long ischemia type. However, on day +5, patient's serum creatinine climbed to 9 mg/cent after declining to around 4, and he started to be oliguric. His original disease is unknown. This is a patient who presented with CKD5 and bilateral atrophic kidneys. His maintenance therapy was tacrolimus, MMF, and steroids, and so a graft biopsy was obtained. Of course, with the differential diagnosis of mainly that we are dealing with a rejection process. This is his biopsy, and as you can see on the left, the patient had evident tubular injury, so you can see with all of these costs, but also within the glomeruli, see that we have very busy glomeruli with a lot of endothelial swelling, with a lot of intracapillary thrombi, with a lot of glomerulitis. And on a higher power with the silver stain on the right, you can see the fibrin thrombi filling the capillary lumina, almost including them. You can also see the inflammatory cells here, the neutrophils, which we introduced. So this is a full-blown thrombotic microangiopathy. However, the patient's C4D was negative, which takes us to the dilemma of when we find a TMA within a biopsy. So the diagnosis of my initial diagnosis was an acute thrombotic microangiopathy. The patient had patchy tubular necrosis and microvascular inflammation. His C4D was negative. And so we recommended correlation with DSA levels. However, there was no DSA detected. So we need to deconstruct thrombotic microangiopathy, or that when we are faced with thrombotic microangiopathy within the transplantation context. We know that TMA has a complex differential diagnosis and that etiology in the post-transplant settings are numerous and they can coexist, whether it's a ischemia reperfusion injury, whether it's an antibody-mediated injury, whether it's an infection which gave the patient TMA, whether it's a CNI inhibitor, or it's a recurrent disease due to genetic factors, specifically in a young patient when we don't know what was his original disease, and that we could be dealing with a form of recurrence. Within, from our own experience and within most of the literature which is also published, thrombotic microangiopathy actually highly correlates with antibody-mediated rejection. But we need evidence of antibodies. And as you can see with this patient, we did not have any evidence of antibody, whether it's C4D in the tissue or his DSA were not detected. Also, it was the stress in the latest month was that we needed a call for clarity. So the TMA working group proposed that we need to separate histological TMA from clinical TMA findings to facilitate better communication and research. So this means that we're stressing on the fact that we can, as pathologists, we can have histological TMA, and that you might not find evidence of hemolysis, which are present in the patient clinically or serologically. But the fact that the patients could have no clinical presentation of thrombotic microangiopathy with no low platelets or anything, this does not exclude the fact that we could have a TMA which is present on histology. And of course, within these scenarios, the central role of collaboration is very, very important. We need a multidisciplinary discussion is crucial to determine the best therapeutic approach, as there are no morphological criteria that we can definitely distinguish between causes. As pathologists, I can only say that this is a thrombotic microangiopathy, and I cannot actually specify what is the etiology of this TMA. So infection, it would be very difficult to know. If it's a recurrence, we have no way to say. CNI actually induced TMA, although it was a big issue years ago when we started, because we did not know the strong connection between antibody-mediated rejection and thrombotic microangiopathy. We still retain the fact that CNIs cause thrombotic microangiopathy, but this would be a diagnosis of exclusion after we thoroughly exclude any other causes, and mainly, as I said, ABMR. So back to our patient, post-biopsy, the clinician wanted to be careful, so he gave the recurrence in case that this is an ABMR. His TAC levels were reasonable, so CMI toxicity was not high on the list. So patient received IVIG and plasma exchange, and his creatinine landed to 1.1 and remained stable, and the patient was discharged. On follow-up 2 months later, the patient serum creatinine was around 2, not really significantly increased, but he developed a protein ratio of 900 and DSA were detected, but with a low MFI according to the lab. However, 3 weeks post this presentation, his serum creatinine increased to 2.3 and his protein creat ratio increased to 1.5, so a second biopsy was obtained. This is his second biopsy, and as you can see now, I want you to look at his glomeruli, and you can see within this glomeruli, we still have some evidence of red cell fragmentation, a lot of endothelial injury here as well. This is a trichrome stain, and you can see how thick the capillary walls are with a lot of peripheral duplication. As you can see here, other glomeruli was really shrunken and ischemic. This glomerulus on the left has still inflammatory cells, so it had an active component. There was a component in it. And the glomerulus on the right has only basement membrane duplication with no activity. And this is a very good example of what we call, or to show you what we consider a chronic active form of rejection versus a chronic inactive form of rejection. So we define a chronic active ABMR by the CG lesions, or one of the lesions that we define chronic active ABMR with. And the CG lesion, as you can see here, is the basement membrane duplication. And since 2019, again, it became important not to group all patients with transplant glomerulopathy under the same umbrella, and that patients who has a low CG score or not a lot of peripheral duplication, and so not a lot of basement membrane remodeling, this translates into not a very high form of chronic injury, that these patients, and they still have activity, so they still have a lot of inflammation and endothelial swelling. So these patients actually do not have the same morbid outcome with patients as transplant glomerulopathy as we used to consider it before. And these patients deserve to be treated because we have seen that these patients could stabilize. Their grafts could stabilize, and we can increase the longevity of the grafts. Versus patients, if they have the lesions like the one we see in the PS stain here on the down right, where we only have the capillary wall remodeling, we only have the basement membrane duplication, no activity, no inflammation, no endothelial swelling, and this is what have been included as a chronic inactive antibody-mediated rejection. So this is basically the difference between both of them. In our patients, this patient had evidence of activity, so he is a chronic active ABMR, and also he had evidence of chronicity with the basement membrane duplication. Also, this is a case which gives you an example of the continuity of the lesions. And this is usually what we call the transition between what we consider an active antibody-mediated rejection and chronic active antibody-mediated rejection. So this is the spectrum of transplant glomerulitis or thrombotic microangiopathy. So when you have a glomerular, an acute or an active glomerular lesion, this is what we usually expect to see in the follow-up biopsies, that we're going to see the evidence or the sequel of these active lesions, whether it's a continuous activity like this patient, which says that the rejection process has been ongoing, or whether it's just a chronic insult if all the glomeruli were just had the basement membrane duplication with no activity. The rest of his biopsy did not have considerable IFTA, luckily, but he had considerable also peritubular capillaritis, as you can see here. This is the PTC lesions, and we score the inflammatory cells inside the PTC. And surprisingly, his C4T this time was positive, and this is the positive C4D delineating the peritubular capillaries, but also within the glomeruli, you can see that we do have also linear C4D along the capillary walls, and we see this frequently in patients with transplant glomerulopathy when they still have an ongoing process of activity. It does not say that we have recurrent disease. This is not membranous. This is just simply part of the transplant glomerulopathy process. So the second diagnosis was actually transplant glomerulopathy with microvascular inflammation, MVI score 3 compatible with chronic active antibody-mediated rejection, TSA positive. We did not need to repeat the TSA for this patient because his C4D was positive, and that would be enough. The point of my two cases that we need to come up with what we call a multidisciplinary collaboration for interpreting transplant biopsies, what Banff had called the critical hub, that this is how we reach to a diagnosis, because we're having an increasing complexity of the Banff classification, especially if we want to have this new reasoning frameworks. And all of it underscores the crucial role of the clinical pathological conference. This critical hub needs to be between pathologist, nephrologist, immunologist, and a surgeon. And actually, we have, this is what we do with most of our patients, especially trying to interpret the TSA, whether they are TSA, whether they are non-TSA, the significance of the MFIs that we are having. I would add to this also the genesis, but this is a pre-transplant that we should try, at least if we have any doubt that these patients, especially in young patients, that they could have an underlying genetic disorder, that these patients should undergo genetic screening before they get transplanted to anticipate the recurrence of the disease. But this is all to facilitate a richer, more accurate diagnostic discussion among the entire transplant team, whether nephrologist, pathologist, and for all of this, and to gather all the information together in order to get to a diagnosis. And I will end up with this. Thank you very much.
Thank you, Dr. Wissam. Thank you a lot for this, for sharing of these interesting cases. There are a few questions from the audience. One question, can we have both cell-mediated rejection and antibody-mediated rejection in the same time?
Yes. As I've shown in the first case, this is actually what happens in most of our patients. I want our audience to always remember that although we classify the rejection process, as we classify a lot of diseases, and we try to classify them into T-cell mediated rejection and antibody-mediated rejection, but this is for the sake of to facilitate management. But when you mount an immune response, you don't control it. Our patients do not follow our own classifications. So actually, what we mean by a T-cell mediated rejection or antibody-mediated rejection is a dominant arm of the immune response. So even when we diagnose it as a pure ABMR, you still have definitely some form of a T-cell mediated response, but it's not dominant. And what we classify as a mixed rejection is that when you have both arms of the immune system co-dominant together. So yes, we see it, and it's frequent. It's not an uncommon finding, and it's a major pitfall with the Banff classification that we don't have specific entities for what we call mixed rejection, but maybe not to cause extra confusion. The classification is already complicated enough.
Yes. And the last question is there any guidelines on the timing of biopsy and guidelines of other steps in approach?
There are no guidelines for the timing of the biopsy, but there is always a very, very strong recommendation that we should always biopsy as early as possible. If you don't have a contraindication for biopsy, if there is no patient risk, take the biopsy, then manage the patient as you want. You can start your anti-rejection therapy. You can start, and this is also applicable in the native, you can start, if you're doubting that this is an RPGN, the whole thing. Take the biopsy because management and immunosuppression modulate the histology. And then it's difficult to determine what's really the problem with the patient. The second line of guidelines on the approach, I don't mean what should we do with the biopsy. If this is it, yes, there are guidelines. Every transplant biopsy should be processed for routine C4D. And now also the latest guidelines recommend routine SV40 within the first 3 years post-transplant so that we can try to detect the early PVN cases. If the patient if it's a high-risk patient, meaning a highly sensitized patient, if the patient had a previous attack of antibody-mediated rejection, if de novo DSA were detected, if he had ever a biopsy with C4D positive, then EM is recommended. So that these patients' biopsies should include EM to try to detect early changes for chronic active antibody-mediated rejection.
Dr. Wissam, how to differentiate TMA due to CNI versus TMA by antibody-mediated rejection?
We can't. Well, but let me rephrase it.
Okay.
If I want to attribute this TMA to antibody-mediated rejection, then I need evidence of antibodies. So this is basically how we approach antibody-mediated rejection. We have the morphology, and then we have the evidence of the antibodies. So either the patient has DSA, either the C4D positive, or that we have significant microvascular inflammation, which we can't ignore, like in this patient. So this patient, actually, we had no solid ground for dealing with him as an ABMR in his first attack because we could not detect the DSA, which could happen. His C4D was negative. Patient already had received he had induction. We were very early post-transplant, and sometimes the C4D is not there yet. A C4D could be focal, so it was not represented in the biopsy. So we have so many reasons why we cannot detect C4D, but the patient had significant microvascular inflammation, and this is why we treat it. So as I mentioned, again, when we don't have solid evidence of antibodies, it's then a discussion between you and the pathologist and the immunologist to see what would be the best approach. But I don't have any solid evidence to say that if we don't have antibodies, then this is ABMR and this is CNI induced.
And the last question, Dr. Wissam, in C4D negative TMA, would you check for C1q binding on biopsy to rule out AMR versus non-AMR causes?
No, there is nothing called C1q binding on biopsy. The C1q binded antibodies, which are detected on the SAB and in Luminex, this is not represented in tissue. So you don't, whether the antibodies are C1q fixing or not, or whether they're complement fixing or not, it's still the biopsy could still be C4D negative. So C4D negative does not mean that you have non-complement fixing. And no, we cannot, any demonstration of complement within the tissue does not mean that we have antibodies. Till this minute, it's still the C4D only.
Thank you, Dr. Wissam. Thank you a lot.
Very much.
Now thank you.
Very much.
Now we'll move to the next speaker. Next speaker is Dr. Hormuz Dastoor. Dr. Dastoor is consultant in nephrology and internal medicine with over 27 years of experience in renal care, dialysis, transplantation. Currently, he's working in Sahha Kidney Care in UAE in Abu Dhabi. Dr. Dastoor will speak about IgA nephropathy in the transplant. Dr. Dastoor, the screen is yours.
Thank you. I hope you can hear me.
Yes, yes.
Okay. So let me just begin with a 23-year-old male patient with history of IgA nephropathy who was diagnosed in 2021 with an RPGN-like presentation. The patient progressed to end-stage renal disease after treatment with high-dose steroids and cytoxan. He received a 2 halotype match living-related transplant from sister. So the question that first comes with obviously with IgA and recurrence is, what are the risk factors for recurrence? Number one, is it young age? Is it good HLA match? Is it rapid progression of native kidney IgA nephropathy? Or is it all of the above? So that's kind of like a tricky question. But let's look at the risk factors. Basically, you are at increased risk of recurrence if you are at a young age at the time of presentation, if you have a better DR match, if you have a high serum IgA, if you have elevated levels of abnormally glycosylated IgA, if you have a rapid progression from native disease, like in this patient, and also if you have had a previous allograft loss from IgA nephropathy, then you are at increased risk of recurrence. Now, on the other hand, having a living-related transplant does not increase or decrease your risk of recurrence. Having a history of rejection does not necessarily affect your recurrence. And possibly lower risk of recurrence in patient who is on steroid-based regimen and who received a lymphocyte depleting agent. If we look at the incidence of IgA recurrence in the kidney transplant, if you go back about 10 years in this paper in NDT, you can see that about 190 patients had a history of IgA nephropathy. About 13 of them lost the allograft and received a second allograft. And at 15 years, about half of the patients have lost their grafts secondary to IgA nephropathy. Hence, not only is the incidence of recurrence of IgA nephropathy high, but there is also an increased risk of graft loss. So this is a severe disease. Now, if we look at recurrence over time, this is from another study from Sweden, from the US, you can see that recurrence in the biopsy is found in about 1/3 of the patients with IgA nephropathy. Now, this is different from having deposits in the kidney and having active histologic lesions. Yeah, so up to 1/3 of the patients can have IgA deposits at up to 2 years, but this does not mean that they have the histologic findings of mesangial proliferation, endothelial proliferation, etc. Nevertheless, if you follow these patients long term after they have these IgA deposits, you can see that the incidence of IgA nephropathy is about 25% at 15 years, and up to 1/3 of the patients can potentially lose their graft up to 8 years after recurrence. Now, if you have patients who have recurrence of IgA nephropathy, how do they present? Well, they present as similar as in patients who have not had IgA nephropathy without transplant. So they can present with isolated hematuria. They present the same with proteinuria. 1/3 of them present with hematuria and proteinuria, and up to 40% of them can have an increase in serum creatinine with or without hematuria. What that means is basically if you have a transplant patient whose primary disease is IgA nephropathy, and if they have recurrence of hematuria or they have recurrence of proteinuria, then your most probable diagnosis is probably going to be a recurrence of IgA nephropathy. Now, if we go back to our patient until August of 2025 kind of had a normal serum creatinine of around 100 micromoles per liter. He then developed proteinuria, hematuria. He had worsening of his proteinuria to 1.5 grams. His serum creatinine increased to 122 micromoles per liter. His eGFR was rapidly declining. It was declining from 77 ml per minute to around 66 ml per minute over a 2-month period. Our suspicion was that the patient was having a recurrence of IgA nephropathy, And we did a kidney biopsy on him, and the kidney biopsy confirmed IgA nephropathy with M1, E1, S1, and C1 lesions. So histologically, he has a very active disease. So the question that arises is, what do we do in 2026 for patients who have recurrence of IgA nephropathy in transplant? Now, just to give you a feedback, I know you know this, have you seen this slide multiple times? IgA nephropathy, we now know, is a 4-hit mechanism disease. Hit 1 is where there is an increase in glycosylated IgA. Number 2 is this abnormal glycosylated IgA produces antibodies. Hit 3 is where these antigen antibodies get deposited in the kidney. And hit 4 is where there is inflammation in the kidney as a result of these deposited antibodies. And you can target IgA nephropathy at these various hit levels. You can target hit 1 with steroids, budesonide, Tarpeo. You can target hit 1 and hit 2 with these new BAMF inhibitors or APRIL and BAMF inhibitors or plasma cell inhibitors. You can target hit 4, which is inflammation, also with steroids or with complement blockers or with endothelin blockers. Today, I just want to focus on what we have available. I don't want to go into APRIL and BAMF or plasma inhibitors because in our practice, we don't have that available. So there are not many treatment options for IgA nephropathy in transplant patients, right? There are no randomized control trials. So if we have steroid-based regimens, we could probably use targeted release budesonide. For complement blockers like iptacopan, there is no strong randomized control trials. And the same is true for BAMF and APRIL inhibitors like sibeprenlimab or atacicept. There is some supportive care available in the form of SGLT2, sparsentan, atrasentan, but the evidence of benefit in transplant patients is a little weak. Nevertheless, that should not stop us from using these drugs because if they work in non-transplanted patients, they should work in transplanted patients as well. If we look at the little data that we have on targeted release budesonide, here is some data that the use of this drug did cause a decrease in proteinuria, significant proteinuria, about 60% at 6 months. The problem with targeted release budesonide is the side effects. Yeah, even though it's set not to have side effects, when we use it, patients do develop hypertension, they do develop edema, they do develop impaired glucose tolerance as well as diabetes. Another pathway that we can target is endothelin. Now, some people say that endothelin receptor antagonists are just SGLT2 inhibitors, but I do not think that is that case. And this will only be proven this year when we have the eGFR data. We know that endothelin plays an important role in inflammation in the vasculature. It causes fibrosis and it causes generalized mesangial proliferation, sclerosis. And targeting endothelin receptors with endothelin blockers may help to reduce proteinuria as well as progression of CKD. So I think it is a slightly different from SGLT2 inhibitors. The mechanism of the drug working on the kidney is different, and the target of the drug is also different. SGLT2 inhibitors just work at the level of the vasculature and they reduce proteinuria, not much benefit on eGFR, whereas endothelin receptors compared to SGLT2 also target inflammation. And I think we should see the results of endothelin inhibitors coming out very soon. The data of atrasentan compared to placebo shows that it was able to reduce proteinuria by up to 36%. That is quite significant. Another treatment option possibly we could use in transplant patients with IgA is complement blocker therapy with factor B inhibitor known as iptacopan. And as you all know, that factor B plays an important role in amplification loop, and in C3 convertases, which basically result in C5b9 formation, and that is responsible for kidney injury. By targeting factor B with iptacopan, we can possibly reduce or block this pathway and reduce inflammation. So do we have any data as such? Yeah, we have some data, but not in transplants. But in non-transplants, we know that it reduces proteinuria by 35%. So we know that SGLT2s reduce proteinuria. We know that endothelin receptors reduce proteinuria. We now know that iptacopan reduces proteinuria. So the question I would ask myself and I would ask the audience is, if all of these reduce proteinuria, why do we have to use iptacopan? And I think that's where understanding the mechanism of the disease is very important. Iptacopan targets one of the major contributors to inflammation in the kidney, and that is complement. And besides reducing proteinuria, I think what is important for iptacopan is that iptacopan stabilizes your EGFR at the expense of reducing inflammation. So it's not also an SGLT2 inhibitors. It works at the target of the root cause of IgA nephropathy, that is complement and inflammation. And that differentiates this disease, this drug from other drugs like SGLT2. What happens when you give patients iptacopan? And I think it's very important to understand this, because when we start using this drug, we need to understand what is happening at the cellular level and at the molecular level. And if you follow these patients, you will see that their serum C5b9 should decrease by up to 20%. The complement C3 level should go up by about 20%. And factor BB, which is causing the inflammation in the kidney, along with C3 and C5b9, should decrease by up to 20%. We don't do serum C5b9, but if we were able to do this test, we could show that there was up to a 97% reduction in the urinary C5b9, which would show us the effectiveness of this kind of drug. Now let's look at our patient. We actually decided to start this patient on iptacopan. And why did we start this patient on iptacopan? Because the patient was already on a maintenance immunosuppression with steroids and mycophenolate. We had discussed with him to start him on a higher dose of steroids, but the patient was refusing steroids because of the side effects related to steroids. So we decided to start him on iptacopan. And you can see that approximately 2 months ago, we started him on iptacopan. But what is important is, let's go back in the months prior to starting him on iptacopan. And you can see that prior to starting him on iptacopan, his EGFR was declining rapidly. And his EGFR was declining rapidly, mainly because of the findings on the biopsy. The significant M1 lesions, the E1 lesions, and the C1 lesions were very active, and they were rapidly reducing his EGFR. We were surprised that after starting the drug iptacopan, the PCR, the protein creatinine ratio, did not significantly reduce, right? We saw the trials of iptacopan. We saw that within 4 weeks, there was a reduction in proteinuria, but in our patient, there was no reduction in proteinuria. So that causes some doubt in our minds. So we decided to see if the drug was working. And one way to look whether the drug is working is, I showed you, is by looking at the serum C5b9, and the level is less than 100. That means that the drug was working effectively. It was blocking the complement pathway. Another test that we did was AH50. The AH50 was less than 10. And that also showed us that the drug was blocking the complement pathway. So we knew that at the microscopic and at histologic level, the drug is working, and perhaps it'll just take some time to reduce the proteinuria. So we persevered with this patient, and you can see that our efforts were rewarded, because despite the fact that at 8 weeks he did not have proteinuria, immediately after doing the complement test, we were surprised that his proteinuria decreased by nearly 50 to 60%. So his proteinuria decreased from about 1.5 grams to about 0.8 grams. And this is very significant. And I think in hindsight, we can explain why his proteinuria took a little more time, because this patient also had what we call is the S1 lesions. The S1 lesions are associated with chronicity and fibrosis, and it takes time if for proteinuria proteinuria that is related to S1 lesions to actually come down. If his proteinuria was related only to M1 and E1 lesions or C1 lesions, I would have expected his proteinuria to come down much more faster. But nevertheless, we can see that in this patient who has a very severe IgA nephropathy characterized by severe proteinuria, not responding to steroids, having an eGFR that is declining very rapidly, the patient responded very well to iptacopan, and I think this is a very, very successful treatment with iptacopan. Look at his eGFR. Prior to starting the iptacopan, his GFR was declining rapidly, and within I would say 4 to 6 weeks, we stopped the decline in his eGFR. His eGFR only declined from 64 to 62 ml per minute, whereas prior to that, it was declining at a rate of around, I would say, 8 ml per minute every 4 to 6 months. So in summary, I can say that this is one of the first patients worldwide who has used iptacopan in the setting of recurrent IgA in the transplant patients. We were able to stabilize their eGFR. We were able to reduce their proteinuria. And I think in the long term, if we continue with this drug, we will probably prevent this patient from going to ESRD and requiring a second transplant. Thank you.
Thank you, Dr. Dastoor. Thank you for sharing this interesting case. As you said, the management in post-transplant is really, we have limited option, and there is very limited publication on that. There is too many questions. People are really get excited from the talk. So the first question, what is the risk of recurrence of IgA if the living donor is from identical twin? Any idea about the risk?
From identical twin, as I showed you, what the data was showing is that there was not much significant difference if there was a good HLA, even if there was a good HLA match, right? If there is a good DR match, then for some reason there is an increased risk of a recurrence of IgA nephropathy. We would think that, with a living related donor as such, the recurrence would be maybe a little less, especially with a good match. But as I showed you the data did not show either an increase or decrease in recurrence with a living related donor. Now, if you had a twin and complete a good 6 halotype match, probably the outcomes would be better and recurrence would be lower.
So for your case, Dr. Dastoor, you only used the Coban. You did not use atrasertan, yeah, for your patient?
No, even getting iptacopan is kind of difficult. I think why we use iptacopan is for several reasons. His eGFR, even though it's coming down, is still very well preserved, number one. Number two, the biopsy shows a lot of active inflammation. We know that active inflammation is caused by complement deposition in the kidney. That is why we want to target that active inflammation with iptacopan. If I had a choice, if finance was not a concern, I would start the patient on both iptacopan and atrasentan. But I think the aim right now was just to reduce the inflammation, stop the decline in his EGFR, and to reduce the proteinuria. My actual target was not to focus on the proteinuria. My actual aim with this patient was to stop the decline in his EGFR.
Indeed.
And I think iptacopan was very successful. I was very surprised with the results of this drug in this patient. If you go retrospectively in this patient, before we started iptacopan, his EGFR was rapidly declining at 8 ml per minute over a period of 4 to 6 months without change in his medications, without adding SGLT2 because he was already on it, without adding an ARB because he was already on it. So his decline was attributed to his IgA. And simply by adding the iptacopan after 4 to 6 weeks, we realized a significant stabilization on his EGFR. And then the secondary outcomes, a decline in his proteinuria, etc.
There is a question, Dr. Dastoor. This means that only IgA deposit with inflammation or proliferation will not considered. This is IgA nephropathy, isn't it? Or only if there is microscopic hematuria, proteinuria, this will change the diagnosis.
No, I think microscopic hematuria and proteinuria will come if there are correlating histologic diagnoses. If you have IgA deposits alone, these patients ultimately will develop histologic changes like mesangial proliferation, endothelial proliferation. The question you need to ask yourself is, at what stage do you decide to treat them as IgA nephropathy? Just having deposits, you want to classify them as IgA nephropathy, or having deposits with histologic changes is your definition of IgA nephropathy. Luckily for us, in our patient, he has IgA deposits and he has histologic correlates. That means he has M1, E1, S1, C1 lesions. For us, the diagnosis was very clear. He has active IgA nephropathy with histologic correlates and clinical correlates with proteinuria and EGFR. He definitely needed escalation in therapy. You could probably consider steroids. This patient, we had a chat with him. He did not want steroids because we don't have targeted release budesonide. We gave him an option of iptacopan. It was agreed, and he received it.
Sure. Other question, can you combine budesonide therapy with prednisolone for recurrent IgA post-transplant?
I think not really, I mean, you are basically exposing your patients to an overdose of steroids, right? So either you can escalate the steroid therapy like the testing protocol when you give oral steroids, or you can shift your patients to budesonide. It's up to you, Even the testing protocol is quite good. I would just like to emphasize, people tend to underestimate the side effects of steroids. I have used a lot of steroids in my life, personally as well, and on physicians as well. They're not very good drugs. There is a lot of side effects. Infections, especially, is a major. Acne, hypertension. Me personally, I try to avoid steroids unless I'm forced by the insurance companies to use steroids. And in our practice, we now have a lot of patients who are refusing to take steroids. They're well read, and then we give them an option. Look, you can use complement blocker therapy, or you can consider steroids. And patients are opting for complement blocker therapy. You need to have that discussion with the patient, and you need to get approval from your insurance and give the patients these options. Sometimes people tell me, why do you want to give them a slightly more expensive drug? It's the patient's choice. And if the patient has access to what is best for him, I would leave the choice to the patient and give them what they prefer as well.
Suppose his insurance is not covering and the patient will say, okay, I will use a steroid. how much you will increase the dose, for example, in post-transplant?
Yes, I think that is a good question. There is no standard protocol as such. I can tell you that in the Mayo Clinic, Professor Fervenza has his own standard protocol, which is giving one pulse dose of methylprednisolone, which is around 250 milligrams or 500 milligrams, depending on the size of the patient. And then following the testing protocol, which is around 0.4 milligrams per kilogram per day of methylprednisolone, which is equivalent to 0.5 milligrams per kilogram per day of prednisolone. And he combines it with mycophenolate. So if the patient opts for steroids, he gives them that. But I can also tell you that at Mayo Clinic, they are prescribing at least five prescriptions of iptacopan in his clinic per clinic. So right now, these are the two major drugs which are being used for recurrence of IgA in the transplant setting. Obviously, in the future, we will have much more drugs. But as I said, I didn't want to focus on other drugs today because we don't really have them available. I just wanted to show the participants what we have available and how we are using these drugs and how we are following these patients in terms of eGFR. I'm following them also in terms of proteinuria. And I'm also doing the complement profiling to make sure and to confirm within myself that the drug is being absorbed and working at the microscopic level in blocking the complement system.
Just last questions before moving to the next topic. Low serum C3 and C3 deposition in the biopsy, it reflects activity and treat aggressively, or the infection associated and the treatment is infection control. What is your comment?
Okay, I'm not sure in the low serum in C3, but in IgA, about 80 to 90% of the biopsies will have C3 deposition. And the greater the intensity of C3 deposits, the higher is the complement playing an inflammatory role within the kidney. Okay. It gives us, there is no study showing that these patients will benefit from complement blocker therapy, but we do know that the higher the deposition of C3, the more severe histologically are the lesions. So common sense would dictate that probably these patients would benefit more from a complement blocker therapy. If you are talking about low C3 in the serum, low C3 in the serum can be caused by various different causes, but low C3 in the serum is not typical for IgA nephropathy. IgA nephropathy patients very, very rarely come up with low C3. If you have a low C3 in the serum, you need to be looking for other diseases like lupus nephritis or post-infectious nephritis. C3 plays an important role in IgA, but it plays a role in IgA at the microscopic level and at the histological level, not at the serum level.
Thank you, Dr. Dastoor. Thank you for this interesting topic. Now we'll move to the next speaker. Our next speaker is Dr. Shadia. Dr. Shadia is consultant nephrologist with over 10 years of experience in the management of acute and chronic kidney disease. Currently, Dr. Shadia is practicing as a consultant nephrologist in the Mediclinic in Dubai Health. And Dr. Shadia will speak about finerenone overview in chronic kidney disease. Dr. Shadia, the screen is yours.
Thank you, Dr. Fakhriya, and thank you, Dr. Amna, for having me with you with this very successful, actually seeing more than 1,000 participants, even in the afternoon. This is a great indicator of the success of this virtual scientific meeting. So I will take you away a little bit from transplantation, and we will go check or do an overview of finerenone and chronic kidney disease. We know, like recently, there is an era of new medication to treat patients with CKD in order to avoid reaching end-stage kidney disease and eventually transplantation. I will be focusing in the next 20 minutes on the finerenone and the role of finerenone in slowing the progression of chronic kidney disease. So as we all know, CKD and type 2 diabetes significantly increases the risk of cardiovascular morbidity and mortality over type 2 diabetes alone. And it's not only about diabetes, it's not about chronic kidney disease, it's what we call the cardiovascular kidney metabolic syndrome, where we have this metabolic syndrome with hypertriglyceridemia, hypercholesterolemia, type 2 diabetes, obesity, or impaired glucose tolerance that will lead eventually with time not only to chronic kidney disease, but also will lead to clinical cardiovascular disease and will increase the cardiovascular morbidity and mortality. So let's see how we can prevent or slow the progression not only of chronic kidney disease, but also how we can help our patient by decreasing the morbidity and the cardiovascular morbidity and mortality. So in the new era of a lot of new molecules, so let's focus on the finerenone. The finerenone, it's a selective non-steroidal mineralocorticoid receptor antagonist, which block the mineralocorticoid receptor overactivation. And by this, it can slow the kidney and the cardiovascular disease progression. Because there is a lot of studies that show that this MR receptor, and mainly it's the overactivation of this receptor in the vessels, in the heart, and in the kidneys, which is responsible of the inflammation and later on fibrosis. And by blocking this overactivation, we can block one of the drivers of chronic kidney disease progression, which is the inflammation and the fibrosis. And by this, we can protect the kidney and also protect the heart. So let's see what do we have, what are the clinical trials on finerenone. So we have a lot of ongoing and already published randomized clinical trials on finerenone, on CKD patients with type 2 diabetes, on non-diabetic CKD patients, CKD patients in pediatric populations, in type 1 diabetes with CKD. We have a study on the finerenone on diabetic retinopathy, and we have a study on the combination therapy finerenone with SGLT2 inhibitors. So let's focus on the kidney, and we will be discussing the role of finerenone in CKD patients with type 2 diabetes, the combination therapy finerenone and SGLT2 inhibitors, and we will end by the study on finerenone in patients with CKD with type 1 diabetes. So let's start by a little bit now, we can say old study, which is it's a pre-specified analysis pooled study, which is the fidelity pooled analysis. It's a combination of two big or major clinical trials, which is the Figaro DKD, which is a trial who studies patients with chronic kidney disease type 2 diabetes, and the primary outcome of this study was the cardiovascular outcome, while the secondary outcome was the kidney. It includes more patients with stage 1 and 2 chronic kidney disease with severely increased albuminuria, or patients with moderately increased albuminuria having EGFR between 25 to 90. The other study was the Fidelio DKD study. It's almost the same study, but in the Fidelio DKD, the primary outcome was mainly the kidney outcome versus the secondary outcome, which was the cardiovascular outcomes. It includes patients with more stage 3 to 4 CKD with moderately to severely increased albuminuria. So by combining these two studies, we will have we can study the kidney and the cardiovascular outcomes in patients across a spectrum of a large spectrum of CKD severity. In the Fidelity study, if you can notice here, like 40% of patients had albuminuria with preserved CKD. So they have like CKD stage 1 to 2. 26% of patients has CKD EGFR between 45 to 60, and 33% has EGFR between 25 to 45. What about the albuminuria? You can see the median urine albumin creatinine ratio was 515 milligram per gram of creatinine, and 32% of patients has moderately increased albuminuria, while 67% of patients have severely increased albuminuria. And what are the results of this pre-specified pooled analysis? You can see if we, for the composite cardiovascular endpoint, which is time to cardiovascular death, non-fatal MI, non-fatal stroke, or hospitalization for heart failure, we have 14% relative risk reduction with a number needed to treat of 46. And we have relative risk reduction of 22% for the hospitalization for heart failure. What about the kidney endpoints? We have 23% reduction in the relative risk reduction in the composite kidney endpoint, which was time to kidney failure, a sustained more than 57% EGFR decline, or kidney-related death with number needed to treat 59. But with this pooled analysis, we have in the patients, we noticed 20% relative risk reduction in the dialysis. We have, as we said, it's a huge number of patients, including 13,000 patients. And as you can see, like most of the patients were treated with RAS inhibitor because the study was to add the finerenone on the standard of care treatment, which is the RAS inhibitor. In this fidelity analysis, the finerenone reduced the urine albumin creatinine ratio by 32% between baseline and month 4. And as you can see, this is almost stable and was maintained throughout the study. What about the side effects? For sure, there is some side effects, and we all know that finerenone will increase the hyperkalemia, but the clinical impact was very mild and was not really significantly different between the placebo and the treatment control, with only 1.7% of patients having hyperkalemia leading to permanent discontinuation of the medication versus 0.6% in the placebo group. And there was no hyperkalemia leading to death. So if we really manage properly our patient with a strict a control and monitoring of the serum potassium, we can still have the effect of the finerenone on our patient without having any effect on or slight effect on the hyperkalemia. Now, what if we combine SGLT2 inhibitors with finerenone? In the study, there was only a very small population who were taking both medications. It was only 6.7% of patients received SGLT2 inhibitors at baseline, and throughout the study, 8.5% received SGLT2 inhibitor once during the trial. So if we study this population where we have SGLT2 inhibitors with finerenone, we see that the effect of finerenone on the albuminuria and on the outcome, on the kidney and cardiovascular outcome, is irrespective of the baseline SGLT2 inhibitors use. So a reduction in urine albumin creatinine ratio with finerenone, if we have a baseline SGLT2 inhibitors, was 37%, and if we don't have a baseline SGLT2 inhibitors, was 31%. So yeah, possibly these two molecules has synergistic effect, and we will have an additive result if we combine these medications. And from here come the idea of the confidence trial, which is a combination effect of finerenone and empagliflozin, which is an SGLT2 inhibitors in patients with CKD and type 2 diabetes, using the urine albumin creatinine ratio endpoint study. This confidence is a type 2 study. So the confidence, as I said, it's evaluated like simultaneous initiation of finerenone and SGLT2 inhibitors in people with type 2 diabetes and CKD. We had participants from 185 sites across 14 countries. So we randomized patients either to receive finerenone 10 or 20 milligram plus empagliflozin 10 milligram, or we have second group who were randomized to receive finerenone plus placebo, and the third group who received empagliflozin 10 milligram plus placebo. So it was a randomized, double-blind, and double-dummy, multi-center, 3-armed parallel group phase 2 study. The primary efficacy endpoint was the relative change in urine ACR from baseline to day 10 from combination versus finerenone and combination versus empagliflozin. Secondary endpoint was mainly a urine ACR reduction more than 30%, 40%, or 50%, or a relative change in urine ACR at end of treatment versus 30 days post end of treatment, and a 30 days post end of treatment versus baseline. And we have other secondary safety endpoint, which is the eGFR change and any adverse events. So what are the characteristics of the patients included in the confidence trial? So we had a total of 800 patients. The main eGFR was 67, the main age was 67, main eGFR was 54, HbA1c was 7.3%, main systolic blood pressure 135, 44% of patients were white patients. The 75% were male, 25% were female. The BMI was 29, serum potassium was 4.5, and the medium urine ACR in the study was 579 milligram per gram of creatinine. And if you can see again, most of these patients were treated by the standard of care treatment, which is the ACE or ARB. 22% were already treated by a GLP-1 receptor agonist. 88% of patients were having hypertension, and 28% of patients were having atherosclerotic cardiovascular disease versus 16% of patients having diabetic retinopathy. And what did the trial tell us? That simultaneous initiation of finerenone and SGLT2 inhibitors will give us 52% reduction in urine ACR at day 180. If the patients were treated only by SGLT2 inhibitors will have 32% greater reduction in the albuminuria. If patients were treated by finerenone alone, will have 29% reduction in albuminuria, versus if we have the two molecules together, we'll have 52% reduction in urine albumin creatinine ratio at day 180. And this is a reduction in urine albumin creatinine ratio was consistent in many sub-analysis groups regarding as patients were stratified according to the HbA1c, according to the stage of CKD, according to their albumin level, according to their cardiovascular disease. So the effect persists in the study, having greater reduction in the albuminuria in the combination group. And as you can see, the reduction in urine albumin creatinine ratio, it starts so early. You can see at day 14, more than 30% reduction in the urine ACR. And when we stop the medications at 180 days, if we study our urine ACR at 210 days, you see that the urine ACR levels will for sure increase, but it remains below baseline for all treatment groups. Now, what about the eGFR decline? So as we all know, we have this acute eGFR drop, or the initial drop in the kidney function because of the hemodynamic effects of the molecule. But again, when we stop this molecule, the treatment, the eGFR will go back to the initial level, which means this initial decline, it's only related to the hemodynamic effects of the molecules. Now, again, we don't have unexpected safety signals with the simultaneous initiation of finerenone and SGLT2 inhibitors. Maybe in the finerenone group, we'll have more hyperkalemia, but we have less hyperkalemia if we combine the two molecules. And about the AKI, we're having in the combination molecules, 1.9% of patients had AKI, with only 5 patients who had it, and versus 3 patients in the finerenone and 0 patients in the empagliflozin. And as we said, this initial drop, it's mainly related to hemodynamic effects of the molecule. So we studied finerenone in CKD patients with diabetes. We studied the combination, the simultaneous combination of finerenone with SGLT2 inhibitors. Now let's see if finerenone will help our patient with type 1 diabetes, and which is the FINE-1 study. As you know, we don't have a lot of recommendation for the treatment of patients with CKD and type 1 diabetes. We all know that we have to screen our patients after 5 years of diagnosis. We all know that in patients having type 1 diabetes with CKD and moderately to severely increased albuminuria, we have to add RAS inhibitor, but we don't have a lot of other strong molecules to help our patients with CKD and type 1 diabetes. And if we're gonna see this analysis of the CURE CKD patient registry, you see that we have 27% of patients with type 1 diabetes who can have CKD. And this, like the CKD burden is disproportionately affected females, different ethnicities, those with cardiovascular disease, or even older adults. And in patients, RAS inhibitor is frequently prescribed for patients with type 1 diabetes and CKD. According to this registry, 78% of patients with type 1 diabetes and CKD were prescribed SGLT2, were prescribed RAS inhibitor, and few were prescribed GLP-1 receptor agonists and SGLT2 inhibitors, because we know these molecules are not recommended so far for use in people with type 1 diabetes. And if we're gonna see the prognosis and the mortality risk for people with type 1 diabetes and CKD, we see that we are not doing very well, because if we're gonna study the mean eGFR decline per year in our patients over 15 years, we still have with time, we still have a lot of eGFR decline, and compared to the baseline, our patients are still declining their kidney function, or deteriorating this kidney function, and especially also we have an increased mortality rate. So that's why there is a need, or urgent need, for therapies to attenuate the cardiovascular and the renal risk in people with type 1 diabetes. So here comes the FINE-1 trial design, which is, it uses the urine albumin creatinine ratio as a bridging biomarker and primary outcome, allowing for a short trial duration. So the key inclusion criteria for were people aged more than 18, type 1 diabetes, HbA1c less than 10%, were having clinical diagnosis of CKD, and eGFR between 25 to 90, with urine albumin creatinine ratio between 200 to 500 milligram per gram of creatinine, having potassium less than 4.8, and being stable on a RAS inhibitor for more than 1 month prior to screening visit. We excluded patients with uncontrolled blood pressure, patients who already have symptomatic heart failure with class 1 indication for MRA, or current or previous treatment with SGLT2 inhibitors or GLP-1 receptor agonists. The primary outcome, as we said, is the efficacy. To check the efficacy was the change in urine ACR from baseline over 6 months, and the secondary outcome was mainly the safety. So here the baseline characteristic, it were similar in FINE-1 and Fidelity pooled analysis. So mean eGFR 58, HbA1c mean 7.6, serum potassium 4.6, and the urine ACR 549 milligram per gram of creatinine. And what does this study showed? You see that the finerenone significantly reduced the urine ACR over 6 months in patients with CKD and type 1 diabetes. So if we're gonna compare from baseline to 6 months, you will see a decline in the or a reduction in the urine ACR by 25% in patients treated with finerenone, with again safety profile that was consistent all over the period, all over the study. We're having maybe more hyperkalemia, but again, we don't have hyperkalemia leading to permanent discontinuation, and we don't have a lot of serious adverse events like different between finerenone group and placebo group. So what about the initial EGFR decline? So as expected, we have an initial EGFR decline that was observed following finerenone initiation, but again, this is reversible upon treatment withdrawal, and this was due to the hemodynamic effect of the molecules. And again, so finerenone led to a small increase in serum potassium compared to placebo. It's only 0.14 millimole per liter at month 6. So the medication was safe, and we have a great reduction in the urine ACR in patients with CKD and type 1 diabetes. So the fine one, we are just reviewing this study. It's not approved yet in the EMA and in the United Arab Emirates, but just we are reviewing for the scientific discussion. So the fine one was a global randomized phase 3 trial evaluating the urine ACR reduction with finerenone in people with CKD and type 1 diabetes. It met its primary efficacy endpoint with finerenone significantly reducing the urine ACR by 25% from baseline over 6 months compared to placebo. And again, we have the finerenone was safe, and we have a low incidence of hyperkalemia with minimal clinical impact. Going back to type 2 diabetes and to the international guidelines, so after reviewing all these studies, now we all know that finerenone is one of the 4 pillars of treatment of patients with CKD and type 2 diabetes. Now the discussion will be how to add this medication and which consequences. Should we add the 4 pillars together? Should we add the 4 pillars in a sequential approach? This is for sure. We need more studies to tell us about this and to answer this question. Thank you.
Thank you, Dr. Shadia. Thank you for this comprehensive studies. There are a few questions here. Can we start finerenone without AC inhibitor or ARB background?
Actually, we can, but all the studies were done. If you see, like 98% of patients in the studies were already receiving the standard of care treatment, which is the RAS inhibitors. So I'm gonna say it in a better way. Like sometimes we see our patients are not tolerating RAS inhibitor, like for low blood pressure, for sometimes like an increase in the serum creatinine or a decrease in the EGFR more than expected by the hemodynamic effect. So maybe these patients will try for them finerenone without being on RAS inhibitor. But if you're gonna talk about studies, all the studies and all like the guidelines recommend like we start by maximum tolerated dose of RAS inhibitor, and on the top of that we will add the other molecules.
Sure. Other questions, finerenone can be used in children, and if there is any role in non-diabetic CKD prevention.
Yeah, for pediatric population, I know that there is trial ongoing, but honestly, I'm not aware because we are more adult nephrologists, so I'm not aware about this trial and the results of this trial. Concerning patients with non-diabetic, there is the FIND CKD trial, which is an ongoing trial. The recruitment is done, and I guess like soon, within a few months, we'll have the result of this trial. And I think the results are really promising. And I can tell you that a lot of doctors now, a lot of nephrologists, a lot of physicians are using finerenone in non-diabetic patients with very good results. But per guidelines, for the time being, they are only recommended for patients with type 2 diabetes and CKD. For sure, these guidelines will change when you will have the FIND CKD trial results.
In fact, in our practice, we are using it for some CKD patient whom they are not diabetic, like with IgA nephropathy and with other patients with a proteinuria. But anyway, probably we have to see the long term, as you said, and the clinical trials. Other questions, when to measure potassium after using the therapy?
Yeah, actually, we when we start the finerenone, after 4 weeks, we have to repeat our potassium and adjust the dose or stop the medication if needed if we have hyperkalemia. So if the potassium is like between 5 to 5.5, we can try to either reduce the dose of finerenone or try to add potassium chelators. If the potassium is more than 5.5, we try to hold our medication for a while, reduce the potassium, and maybe try to reintroduce it again. But usually after 4 weeks.
Okay. Is there any initial drop in the GFR with use therapy due to hemodynamic effect?
Yeah, sure. This is an initial drop in the EGFR, and this was shown in the fidelity pool analysis. And this drop will be more when we combine SGLT2 inhibitors with finerenone, as shown also in the confidence trial. But this is really hemodynamic drop, and you can see all the studies showed, like when we stop this medication, the EGFR will come back to the baseline, which is like confirm the theory of the hemodynamic effects of the molecule.
There is one comment, not a question, from one of the audience that confidence trial published in June 2025 showed that among persons with both chronic kidney disease and type 2 diabetes, initial therapy with finerenone plus empagliflozin led to greater reduction in the urinary albumin to creatinine ratio than either treatment alone.
Yeah, sure.
Yes, sure.
Yeah, sure. This is what we like. What I mentioned in my presentation. There is
yes, already had discussed that.
Reduction, but also again, it's the question like we don't have clear guidelines when to start this molecule. We have the RAS inhibitor, the SGLT2 inhibitors, the finerenone or the non-steroidal MRA, and we have the GLP-1 receptor agonist now. So for diabetic patients, and the real question, like we don't know when to the standard of care treatment is the RAS inhibitor. On the top of that, we have to add the molecules. And the big question, what to add first and what to add next, how much we will have to wait between treatments, should we add them all together and like monitor the result? This is the question that needs an answer in the future.
Exactly. Thank you, Dr. Shadia. Thank you a lot. Thanks. Now we'll move to the last topic. Our last topic will be presented by Dr. Malaz Sulaiman and Dr. Amjad Asman. Both Dr. Malaz and Dr. Amjad, they are certified board in internal medicine, and currently they are doing nephrology fellowship in Dubai Health. Both of them are second-year fellows, and they will speak about AI application and implementation in kidney transplantation. We'll start the talk with Dr. Amjad Asman and then Dr. Malaz. Dr. Amjad, the screen is yours.
So hi everyone, thank you Dr. Fakhriya for having me today, and actually it is a wonderful day. Let me just share my screen. It is clear? Is it clear?
Yes, Dr. Amjad.
So thank you Dr. Fakhriya, and thank you for all the audience. I'm Dr. Amjad, Chief Nephrology Fellow, MPRU Dubai Health, and today we will conclude this day program with my dear Dr. Malaz about how now AI is focused on how AI is moving from research into a real world transplant practice. So to understand the value of AI, we must first acknowledge the challenge that we continue to face in kidney transplant. And of course, the global organ shortage remains a major limitation. Waiting list mortality continues to affect many of our transplant. And of course, the traditional models that we use like KDBI, which are largely statistics, they provide a snapshot on one point and at one point in time, but their predictive accuracy decline as a post-transplant event unfold. So AI models now outperform the traditional statistics method because AI they're using 100 or they can handle complex and high dimensional and time dependent data. And actually, and across multiple studies, AI demonstrate 20 to 40% improvement in predictive accuracy with the ORC value of more 0.9. This is from 0.6 to 0.9. This is a major effect and major nice results. Importantly, because these models are dynamically, they continuously update a new clinical data whenever there is available data, they continuously update. So AI application are abroad, but today I will focus more in four major areas, which include graph survival prediction, immunosuppression optimization, imaging analysis, and rejection monitoring. I will begin with the graph survival prediction, where AI is currently most clinically mature. So, as I said before, traditionally graft survival is predicted only once at the time of transplant. Now AI introduced a two-stage approach, which is stage one, which estimates the basic baseline risk using the donor and recipient factors, and which are similar to the traditional models that we are using with the OR around 0.6. The second stage, which is the most important, is using a post-transplant data, particularly a GFR trajectory. And we are not just using just a single GFR, because a single GFR is reflecting a moment in time, but the trajectory captures the direction and speed of the graft injury. So this is allow for early identification of the high-risk patients at time when intervention may still change the outcomes. So in prediction of the variable of the graft survival, the new innovation here is the models move beyond the statistic baseline variable. And as I said, a continuous analysis of longitudinal GFR trajectory, updating the risk with every new lab result, and using early follow-up data alone. This beautiful accuracy is the most around 0.7. This is now increasing to 0.9. The models then apply a linear mixed effect approach to estimate the slope of the GFR trajectory. So if you see here, the most important thing is the GFR trajectory. Besides that, they're using another health system data, diabetes, cardiovascular and comorbidities, BMI, and all the recipient and the donor data. One of the most important tools, which is a real tool that has been implemented and developed at Johns Hopkins. Here, this innovation is the model move beyond the statistical baseline variable and continuous analysis of the longitudinal GFR trajectory. In early follow-up, using early follow-up data alone, predictive accuracy is the modest, it is 0.7, but then this model apply a linear mixed effect approach to estimate the slope of the GFR decline, accounting for repeated and irregular measurement. When the trajectory data are incorporated, predictive accuracy improves substantially, approaching 0.9. And this is the risk estimate is generated in real time and embedded directly into the electronic medical record without adding any extra load on the clinician. Another AI tools which is using in the real world now is the iBox technology. And iBox technology, they integrate large data, including the demographical data, the graph characteristics, the immunological variables, and longitudinal GFR trend to predict the long-term graft survival. This has been validated in more than 7,000 transplant recipients and is now used as a surrogate endpoint in clinical trials, allowing earlier assessment of long-term outcome. Another tools that we use in real time is post-transplant predicted analytics system. Sorry. And this system analyzes national transplant data using machine learning models and integrate directly into the donor network. It support a real-time decision making during organ offers and help reduce the discard of the marginal or hard to place kidneys. So all of these models are really relying on a combination of the factor. GFR trajectory is one of the strongest predictors. Donor and recipient characteristics, systemic health, and a post-transplant clinical event all are contribute. This is why AI outperform a single variable scores. And I will move from this to graft survival, from graft survival to immunosuppression. And this is another area where AI is already influencing a daily transplant practice. One of the biggest challenges is placing the rejection risk against drug toxicity, particularly early after transplant. AI actually based system analyze a longitudinal patient data rather than reacting to a single drug level. AI-driven autonomous dosing system using deep learning models like a low term memory network, which are designed to recognize time pattern. So in moving to more personalized immunosuppression optimization, we use all the data available for all the pharmacogenomics, real-time biomarker monitoring, patient-specific dosing, and optimizing more to nephrotoxicity and infection. So we have a real-time tool that we use, which is AI-driven autonomous dosing system. And here, this one, and here is this one. They are taking more than 50 variables of the patient data, including demographic, lab, medication, diet, and vital, and integrated automatically in the record, in the medical record. It is not automated prescribing. It is just supporting the clinician to choose the right time for dose monitoring and less toxicity for the patient. And another tools that we use, more pharmacodynamic and pharmacokinetic in model-informed precision dosing. So more drug optimization, more drug level monitoring for another drugs like tacrolimus, MMF, and mTOR. So in term of quality, kidney quality assessment, actually deep learning models can analyze biopsy images to provide more objective evaluation and improve utilization of marginal kidney. Also now AI also support in early and accurate graft rejection, and short-term models identify patients at high risk of rejection within the first 30 days using routine clinical data. Gene expert-based models improve the objective classification of rejection subtypes, particularly distinguish the classical subtypes of the rejection, and emerging non-invasive biomarker, further allowing early warning of rejection without immediate reliance on the biopsy. So overall, AI enable early detection, better classification, and more targeted intervention before irreversible graft injury occurs. And this is one of the real world tools that they use for the rejection prediction, and like ex post algorithm analysis, which is using more for the drug for the immunosuppression, thymoglobulin, and regular fraction, and donor of the active agent. It is carrying 83.9% accuracy, and it is validated. And another like gene expression and non-invasive predictor. So when all advances come, with all these advances come responsibility become bigger. AI models must be fair, transparent, and actively monitored for bias, especially when influencing allocation and clinical decision. The future now, the challenge and the future direction that we are facing now, most AI models are trained on retrospective data. So we need more prospective data. We need more prospective validation, federated learning to protect privacy, and integration in more clinical trials to remain this part is essential for the next future. So in my conclusion, AI is no longer experimental in kidney transplant. It is more now, it is in practice in the field. It is consistently outperformed the traditional models, support clinician in real time, has the potential to improve long-term graft outcome. The key challenge ahead is the thoughtful and ethical and clinical integrated implementation of all this data besides protection of the patient data. So, what is the most message that I need to share with all audience that all of these models cannot replace the clinical judgment, and it should not. It is a decision supporting tools that highlight the risk earlier, allowing clinicians to apply judgment more proactively, but we cannot replace the human judgment here. So at the end of my talk, I want to thank Dr. Amna and Dr. Fakhriya for organizing such an amazing program today. And thank you for all the audience for staying with us until this time. I am happy and I'm very honored to be with you today. Thank you, Dr. Fakhriya.
Thank you, Dr. Amjad. Now, Dr. Malas, please. Dr. Malas, can you start? Unmute, please. Yeah.
Dr. Maras, can you please unmute yourself?
Yeah. Can you see my screen?
No, we can't. Did you reshare it?
Yes.
Okay, can you stop share and try to reshare it? Yeah, now we can see your screen.
Okay. So, is it clear?
Yeah, it is clear. Thank you.
Yeah. Assalamu alaikum, everyone, and good afternoon. Thank you for staying until this time with us. I would like to thank Dr. Fakhriya and Dr. Amna for giving us this chance to present in the conference. And my name is Mela Sulaiman. I'm a second-year nephrology fellow under MBRU Dubai Health. And I'm going to continue what my colleague Dr. Amjad already started about artificial intelligence and kidney transplantation. My topic today is going to be about something which already there for some time, and it's considered as a true application of artificial intelligence in kidney transplantation. It's actually an intersection of innovation and patient care, which is virtual cross-matching in kidney transplant. I'm going to explore more about the technology that has evolved driven by artificial intelligence and how it transformed us to assess immunologic compatibility. So now you might be asking how this topic is relevant to AI, but let me tell you that artificial virtual cross-matching was there for more than 2 decades. And at the time being, it has never been stronger. We're going to look at this through different aspects, including historical context, the current evolution of it, and how is the future about virtual cross-matching. Let's start that virtual cross-matching was a rule-based algorithm. It stepped as computational decision-making for transplant immunology. Today, it's actually increasing, incorporating machine learning, more sophisticated risk stratification, and outcome prediction through different tools that I'm going to present through my slides, and already some of them mentioned by Dr. Amjad as well. This makes virtual cross-matching a perfect example of how traditional laboratory medicine is bridging into AI application in our field. To understand more about virtual cross-matching, we need first to understand what is the core immunological challenge that we face during kidney transplantation. And for most of us, we know that the primary goal is to detect the pre-transformed or the pre-formed DSAs, the donor-specific antibodies. And why is that important? Because these antibodies, if they attack the graft, they are going to cause graft rejection, which at the end might cause graft loss that all nephrologists will be don't like it and don't want that to happen. So this is a critical step, as hyperacute rejection can occur within minutes if these antibodies attack the graft. So speed is very important parameter here in detection of these DSAs. We know that for decades, the gold standard is physical cross-matching, and physical cross-matching usually use the donor cells and the recipient serum. And this, we know that takes some time, up to 24 hours. Now there is a shift, which is through the virtual cross-matching, moving from a wet lab biological reaction to computational prediction based on the molecular data that is supplied on that computer. This will be analyzed, giving us now an example of digitalization of modern medicine. So it's not just a lab test. Traditional physical cross-match, while foundational, has some limitations as we're going to talk about. The first thing that I mentioned is the time constraint. It takes up 6 to 24 hours for physical cross-match to be completed. And we know that every hour is very important for us when it comes to organ allocation and starting the transplant process itself. And increase in the cold ischemia time will cause delayed graft, prediction of delayed graft function. So the limitation include that it requires fresh donor cells, specialized labs, expert technicians available around the clock, and this is especially challenging when we have deceased donors, which are the majority of our donors nowadays. This will need to obtain viable lymphocytes, and this make it difficult at that time. These factors, along with the geographical barriers and sensitivity viability, mean that we often face offs between the speed and optimal matching for our patients. And this where virtual cross-matching play an important role and game changer. So virtual cross-matching, it's a computational solution, which is a computer-based system. It's essentially an algorithmic prediction of the cross-match outcome. It's based on the recipient anti-HLA antibody profile, along with the determination by the solid phase assays and the donor HLA HLA typing. And all of this is processed through molecular methods. The key advantage here is speed, and the results are available in 1 to 2 hours in comparison to the 6 to 24 hour by physical cross-match. And we, as I mentioned, this is very important to avoid longer ischemia time. So now let's talk about an algorithmic intelligence that powers the virtual cross-matching. And I would like to thank Dr. Ahmed Mustafa that he mentioned and touched this in his presentation earlier, making it easier for me now, that now virtual cross-matching is not just at the HLA level. Virtual cross-match early was basic binary system, simply checking for the presence or absence of donor-specific antibodies. But nowadays, it has evolved significantly. We now quantify the antibody strength using the MFIs threshold and analyze the reactivity at the epitope level, which is more sophisticated and more advanced. And not even the epitope level, we go more deeper to epileptic matching. This allows us to identify acceptable matches, moving beyond just simple HLA matching. And he mentioned the example of a key analog. And here I'm giving an example of a car and a car handle. So instead of looking to the HLA as a molecule which representing the antigen, the car, then the car has a handle which is specific for it, which is the epitope, specific part of the antibody that is going to attack. So modern virtual cross-matching does not just check if the car is there, it checks if the specific door handle, which is the epitope, is present or not. And I'm going to touch a small scenario here that where the patient has anti-HLA A2 antibody in his profile, and the donor expresses HLA A2-1. So using the traditional antigen level approach, this would be labeled as a donor-specific antibody, and the organ would typically be declined for this patient. However, when we go more deeply in this with the algorithmic pattern of the new virtual cross-matching systems, epitope-based analysis, we see that the antibody actually targets a specific epitope, which is 6.2 GE, which is not present on the donor's A2-1 allele. As a result, the antibody cannot bind to the donor HLA molecule, and the virtual cross-match is functionally negative, and we can proceed with the transplantation. I'm going to talk here about briefly about some of the major large-scale studies which prove the safety and efficacy of virtual cross-matching. The first one highlighted in the blue color is the concordance of virtual and physical cross-matching in kidney transplantation. It was a retrospective cohort study that included more than 2,000 kidney transplants, and they compared the physical cross-matching to virtual cross-matching in the form of organ allocation. And the outcome was about early rejection and graft survival. This study showed that there is 97% overall concordance between the virtual cross-match and the physical cross-match. Another large study, which was done, highlighted now in the green color, is the impact of virtual cross-matching on organ utilization in diseased donor kidney transplant. And this was from the National Registry Analysis United Network of Organ Sharing. It included diseased donor kidney transplants donors. The outcome was the organ acceptance and discard rates. And the result was that there was significant reduce in the cold ischemia time and increase in the organ acceptance rate. Another study highlighted in the red, survival benefit with kidney transplantation from incompatible living donors who are highly sensitized kidney transplant candidates. It was a multi-center observational study, and they compared virtual cross-matching based allocation and kidney exchange, and the outcome was about the transplant rate and survival. The results showed 75% increase in transplant rates with significant survival benefits versus wait list, and there was 95% one-year survival as well. The last study I'm going to tell you about it is the outcome of kidney transplantation without a prospective physical cross-matching. There were some centers brave enough to use the virtual cross-matching alone instead of physical cross-match. It was a multi-center European cohort study, including deceased donor kidney recipients, and the intervention was transplant performed using only virtual cross-matching without physical cross-match. And the outcome was to compare about the antibody-mediated rejection and graft survival. The results showed 0% hyperacute rejection with virtual cross-match only and high rate of graft survival. So how did the virtual cross-matching transform kidney transplantation? It's by broader organ sharing, increased access for sensitized patients, and operational efficiency. It allowed organs to be shipped regionally or nationally without sending blood samples, and which usually cause more delay. So this is very essential in the new allocation system if we want more patients to be transplanted. It also enabled kidney pair donation chains by virtual cross-matching incompatible pairs with compatible donors, mainly in the highly sensitized patient. And it also reduced the cold ischemia time by allowing logistics to start immediately upon virtual matching rather than just waiting for the physical cross-match results to be available. In fact, with all these proofs that it's safe and very efficient, some limitations need to be considered as well. So while it's powerful, it has some limitation, and there are some discrepancies between the virtual and the physical cross-match. There was one single center experience done in Korea, published in the Annals of Laboratory Medicine journal, showed that in 2021, it showed that 5% of positive cross-matches occur despite no detectable HLA donor-specific antibodies. And this illustrates the gap between in silico prediction and the biological reality. Another discrepancy that we can talk about here, as I'm highlighting in red, orange, and black color, is the false negative result that usually can happen with the virtual cross-match. I can say that this will mean that risk is missed. It occurs usually due to the prozone effect, where the very high antibody levels can paradoxically suppress the paradoxically suppress the SA signal, or due to non-HLA antibodies present, which are invisible to the standard Luminex texting. In rare cases, donor alleles may simply not be represented on the bead panel. So it's called the Prozone effect. A second discrepancy is the false positive virtual cross-matching, where risk is overestimated. Antibodies may bind to denaturated or cryptic epitopes on the beads that do not usually exist on the real donor cells. Or signals may be amplified because of the presence of the immunoglobulins or the complement interference. The last thing that is going to be mentioned here is about the physical cross-match artifacts, which is usually related to drug-related positivity from antibodies positive, like in case of rituximab or ATG, or sometimes of autoimmune antibodies, like in case of SLE, that they're not actually going to affect our transplant. What is the AI opportunity here in giving us more options and to improve what we have in regarding virtual cross matchings and risk prediction and the outcome prediction? I believe this was already touched by my colleague Dr. Amjad, including I wanted to mention about the iBox system and the Bridge 2 score. iBox system was mentioned by Dr. Amjad, and the Bridge score was mentioned by Dr. Ahmed Mustafa also in his slide. I'm going to add another real application of AI supporting the virtual cross-matching and another risk prediction and outcome, which is the UKidney decision support system. This is not just another algorithmic tool, it's actually an AI-powered clinical assistant. It uses natural language processing to answer complex clinical questions in plain language using evidence-based guidelines like the KDIGO guidelines. It also provides a source citation for all its recommendations. So clinically, it assists with donor eligibility, immunological risk prediction or stratification, and the protocol compliance. And this is showing how AI in transplantation is moving forward. And it's not going just to be yes or no answer. You're going to have a discussion with your AI tool to tell you about the prediction, about the outcome. Few examples here I mentioned, I took it from the tool itself. Like if the doctor is asking, is a 65-year-old donor with a history of hypertension is suitable for a 40-year-old recipient, the AI output from the tool is going to answer instantly references like KDIGO, KDBI guidelines, flags the age mismatch risk, and cites relevant survival data. Another example about risk stratification is what is the immunological risk for this transplant, for example. Then the tool will answer, integrates virtual cross-matching results, sensitization history to categorize the risk, and then to suggest even the induction protocol that you need to use. Here, I'm going to illustrate the power of this future AI application. So let's consider a case example where an AI assists decision making for physician in the clinic, for example, or during admission for some cases. Here, a 45-year-old female, highly sensitized with a CPRA of 98%, who's been on dialysis for 8 years and had a previous failed transplant due to antibody-mediated rejection. A diseased donor offer comes for her with 2 HLA mismatches. Traditionally, a simple virtual cross-matching would detect a DSA with an MFI of 3,500, leading to a binary decision, a predicted positive cross-match, and likely a decline of the organ. But with an AI-enhanced tool now, we can go much deeper. I'm going to talk about 4 different layers for this case. So the first one, in advanced virtual cross-matching, we would perform the epilept analysis rather than just an HLA analysis. The epilept analysis identify acceptable mismatching patterns, and this is going to assess the C1q binding, finding that the DSA to be C1q negative, indicating lower risk of rejection for this patient. Second layer would screen for non-HLA antibodies, could predict a 78% probability of 5-year, layer 2 would screen for non-HLA antibodies, finding none of high risk for this patient. And the third layer is going to include the machine learning algorithm here, which is going to predict a 78% probability of 5-year graft survival with an aggressive protocol showing the transplant benefit outweighed the rejection risk. And finally, the fourth level, a personalized protocol would recommend desensitization and enhanced monitoring. So multi-layered AI analysis enable decision-making beyond simple binary system and prediction, leading to a successful transplantation with no acute rejection at 1 year. And this is an example that highlights the profound impact of artificial intelligence with virtual cross-matching, risk prediction, and even the recommendation for your treatment. And this brings us to another question here, like how we're going to implement all of that. So there are some challenges for implementing all what we've talking about. The first one is lack of standardized system. So some centers use different thresholds for positive results, and this leads to inconsistent organ acceptance. Another factor is reimbursement and cost. We all know that virtual cross-matching is a complex consultation and it's costly, not cheap, requires certain labs and experts to do it. Another factor is educational gap that clinicians need now to learn new skills to interpret the molecular data rather than just the serology. So I come to my conclusion today that virtual cross-matching represents the foundational shift from biological testing to algorithmic prediction. It establishes the data infrastructure that now enables advanced machine learning application in transplant medicine. When it's performed in the correct way, it's considered safe, and the virtual cross-matching protocols have demonstrated 0% hyperacute rejection and increase in the graft survival rate. We are evolving from binary, like match and mismatch, like decisions to continue the risk scoring. Next generation tools are going to help us more in this, including the machine learning, the language learning as well. We need to be more confident in applying artificial intelligence in our systems and using them in our patient. But for sure, the final decision is always for the nephrologist. It's not going to be for the AI.
Thank you, Dr.
And
Malaz.
thank you.
Thank you, Dr. Malaz, and thank you, Dr. Amjad, for this comprehensive talk about AI. Just as a question, there is only a single question. I think I will address this question to Dr. Amjad. Has any of these AI model validated by any recognized agency? Also, have they improved medical outcome through any randomized clinical trials? Dr. Amjad.
Thank you for this
Dr. Malaz,
question.
you can comment as well, yeah.
Yeah, thank you for this question. So for the first part of the question, actually a lot of AI tools that now are integrated in the electronic medical system, like the iPods, the tools that we use for graft survival prediction, for drug monitoring. But actually, and I am being honest, this is not yet has any regulatory approval. It is in experimental phase. It is not having big or strong randomized clinical trials. So up to now, it is experimental using. It was integrated in the workflow in US, in France, but it is not yet have any regulatory or FDA approval. For the second question about the improvement in the medical outcome, actually, again, I can say that there is, yes, survival prediction. There is some good result on that. But up to now, I think AI tools in transplant have it is shown actually strong prediction and process benefit, but still outcome level is not yet guaranteed, because still we don't have any randomized strong randomized control trial, and still there is a gap before this done and we get a regulatory approval?
I can just add that the iBox system is already used in France. It's already formed by the Paris Transplant Group, as Dr. Amjad mentioned. And the Bridge 2 score was already mentioned by Dr. Ahmed Mustafa earlier, so they're already using it. And the UK Kidney Decision Support System that I highlighted, it's available online. Then you can just even check it after finishing the conference.
Thank you. Thank you. Now we came at the end of our session. It was really very fruitful session. I wish everyone can stay till the end because we are planning to take a photo group. I'd like to conclude the session today by thanking everyone to stay till the end. Today we had more than 1,000 attendees, and I think this is a real record in virtual meetings. Thank you, everyone, and I hope really that you had enjoyed all these sessions. Our kidney transplant update is, this is the 6th year that we are holding this update, and we are trying to bring expert in nephrology, a leader expert in nephrology, whether locally or internationally every year to discuss advancement in kidney transplant and related topic. As you can see here today, we had started from locally how the program had started in UAE and how it was expanded through all the donation and the transplantation process. And we had a neurology session. Beside, we had different talk in different disease, in diabetes mellitus, and transplantation in elderly, and recurrent GN. And we had very nice, interesting, challenging cases, clinical cases, and pathological cases. All this session will be available in YouTube probably within 2 weeks from now, maybe earlier than that. So you can, if anyone interested to hear a selected topic, he can go to that YouTube. It will be under the 6th transplant update, the title, and there will be a survey, short survey, when at the end of the session. And in that survey, please, if anyone want us to cover any new topic or any advanced topic in a transplant in the next year, please mention that. I'd like to thank you all for your attendance and for your patience that you stayed for full day till now. And there is 7 CME. It will be provided to all attendees in case anyone did not receive his certificate by, you can say, within 4 weeks. Please to contact the organizer, and please, Shaima, if you can put an email so they can contact the organizer. Just give them a chance for 4 weeks at least. I think it will be earlier than that. You will get your CME certificate. And now I'd like to close this session by asking everyone to open his camera. We'll take a photo, group photo, please. Thank you, everyone, and have a nice day. Thank you. So if everyone can open his camera to take the group photo. Thank you. Thank you, everyone. Thank you.